Okay, hello everyone. Am I audible? Let me please check. Yeah, everything is fine and we can start the session. So those who have got any doubts, they can just write in the live chat box and we can start the session. So if I want to tell you about the session, today's session is targeted about targeting the FMGE entrance exam, the abdomen and the pelvis. So for each and every session, actually the session will go in continuation from today. I'm starting with today, and I will take another 5 more sessions and we will complete the entire course. So exactly what I'm doing, it's a fast track revision, but the thing is that each and every aspect will be covered along with the MCQs incorporated in between. So you can solve the MCQs also. So the first topic of the abdomen which I'm going to start is the anterior abdominal wall. So we will start with the anterior abdominal wall. So an idea of anterior abdominal wall is very important, and if you see one of the question in the previous year of examination, I think it was for the last year FMG examination, they have asked about the subcostal plate. So it's important to know. So if I talk about the anterior abdominal wall, it's a musculoaponeurotic structure, as you can see, and it is surrounding structures and how it is divided into quadrants, you have to know. So it's musculoaponeurotic. When I am using that word, as you can see here, we have got the muscles. So exactly the transverse muscles has been and the flat muscles has been shown. This is the external oblique, and also one of the vertical muscle has been shown, that is rectus abdominis muscle. So this is exactly shown in this diagram. Other than that, I just want everybody to have an idea of the anterior abdominal wall boundaries. Okay, so if I'm talking about the appropriate structures or the bony structures which is surrounding it, it is bounded by the xiphoid process. So you can see here, this is the sternum, and lower down this is the xiphoid process of the sternum. This is the xiphoid process of the sternum. If you want, I can just enlarge this. So you can see here, this is the xiphoid process of the sternum. So above it is bounded by the xiphoid process, also with the costal margin. Lower it is bounded by the iliac crest, pubic tubercles, pubic symphysis, pubic crest, and on each side by the posterior abdominal wall and the mid axillary line. So if you want to enlarge, I will just enlarge this image and you can have an idea of the overall boundaries of the anterior abdominal wall. So above we have got the xiphoid process, we have got the costal margins, okay, the inferior costal margin, and we have got lower down, we have got the bone, we have got the hip bone, and we have got the iliac crest, pubic bones, and these are actually pubis bones are lower down, pubic crest and pubic tubercle, and on lateral aspect we have got the mid axillary line, posterior abdominal wall. So this is overall boundary of the abdomen, anterior abdominal wall. Now few of the surface marking has to be known to you. So if I am talking about the surface marking, you have to know about the soft tissue markings, you have to know about the bony landmarks. So if I am talking about the bony landmarks, we have got the xiphoid process, the costal margin, same thing which I have explained you. I am slightly enlarging the image. You can also see lower down we have got the anterior superior iliac spine, the pubic tubercle, and the pubis bone here. That is all already outlined. So we have got the pubic crest, pubic symphysis lower down. So here what is important for you to know the landmarks, you have to know about the details of transpyloric plane, which is important. The other name of transpyloric plane is adhesive plane. So you can just, I'm slightly more enlarging it. Yeah. So you can see the transpyloric plane is important for you to know what is transpyloric plane, what is the level, and what are the structures residing at this plane. You have to know about the subcostal plane. So why subcostal plane is important, my dear students? Why? The reason is that each and every plane has got an important landmark from where it is crossing. You have to know the level of umbilicus, you have to know about transtubercle plane, and you have to know about the supracristal plane. So you have to know about these planes and you have to know about the important structures residing in this plane, which is highly important for you. So let's see the transpyloric plane and that of intertubercular plane. So this is transpyloric plane and this is the transtubercle or intertubercular plane. So exactly, I think firstly I would like to talk about the transpyloric plane only. One by one I am going to explain it. So if you will see this, the transpyloric plane's important is that, why? Because it is traversing at the level of 9th costal cartilage and at the level of L1 lumbar vertebra posteriorly. So it's very important that you should know the level of these planes. That is highly important. The other name of transpyloric plane is adhesive plane, and it is exactly located halfway midway between the suprasternal notch of the manubrium, and lower down we have got the pubic symphysis. So in between these two important landmarks, so this is xiphisternal joint, this is the xiphoid process of the sternum, and lower down we will have the pubis bone. So exactly pubis bone, pubic symphysis and xiphoid process on the upper aspect, in between lies the transpyloric plane. So exactly in the abdomen we have got the mid clavicular lines, we have got the planes, intertubercular planes, the transpyloric plane, and all will divide the whole of the abdomen into 9 quadrants. Okay, so these are very basic thing, and I assume that you must be knowing this. We have got right, left hypochondriac, we have got epigastric region, we have got iliac region, we have got umbilical region. So these are the 9 quadrants. Now the major thing, and to start with, is the transpyloric plane, and you have to know all the important landmarks residing at this plane. So it's very, very important for you to note down. So in between I will check with the live chat, so that if you have got any doubt you can just ask me. Transpyloric plane is also called as adhesive plane. And exactly it's an imaginary horizontal plane. If I talk about these plane, this is an imaginary horizontal plane which is exactly traversing at the level of L1 lumbar vertebra and at the level of 9th costal cartilage. Okay, exactly it is lying midway between the xiphisternum lower down. So exactly it lies roughly a hand's breadth xiphisternum, midway between xiphisternum and that of umbilicus. Okay, so we have got this between xiphisternum and umbilicus. So I will write it, please. The transpyloric plane is clinically very important. Why? Because it is exactly lying between at the level of L1 lumbar vertebra, and so many important structures are located at this level. So all the structures residing at this level should be known to you. Yes, and exactly the location is between xiphoid process and the umbilicus. Okay. So for understanding the quadrants, intertubercular plane and the other quadrants, I have also tell you about the pubic tubercle and pubic symphysis. Now the crux point to be remembered is, please write down, transpyloric plane is located midway between xiphisternum. It is located midway between xiphisternum and umbilicus. Now important structures. So write down important structures. So what will be asked in the examination is its level and important structures of the transpyloric plane. So that is important. So you have to know all the important structures at this level. So you can just write down. So we have got okay. So the other thing which can be done, if something is overlapping, I will make it seamless. Okay. So see here. Okay. So here we have to know the important structures which is residing at this level. So we have got many important structures. One is the lower border of L1 lumbar vertebra. We have got the pylorus of the stomach lying here. We have got the duodenum, the horizontal part of duodenum. We have got the neck of pancreas at this level. We have got the fundus of gallbladder residing at this level. Okay, fundus of the gallbladder. We have got the hilums of the kidney, 6-point hilums of the kidney. We have got the superior mesenteric artery at this level. We have got other structures like the conus medullaris. And what is conus medullaris? The lower end of the spinal cord. So many structures are there. Okay, right and left colic flexors are also residing at this level. So if you want So we have got right and the left colic flexors also at this level. But the most important structures which everybody should not forget is the lower border of L1 lumbar vertebra, the pylorus part of the stomach, the horizontal part of the duodenum, hilums of the kidneys, the neck of the portal, neck of the pancreas. So in bracket you can write PV. What is PV? Portal vein. That means formation of portal vein is also occurring at the level of L1 lumbar vertebra. That is transpyloric plane, fundus of the gallbladder, in bracket ninth costal, tip of ninth costal cartilage is the corresponding level. So these are the structures which is lying at this level. Now coming to the, so I just want everybody to be connected for this. So any of the students is having any doubt? Yes, yes, Nitin, hello. SR, is it suprasternal notch or xiphoid process? SR, okay, SR, exactly transpyloric plane is between the xiphy sternum and that of umbilicus. Why I have told you suprasternal notch, pubic symphysis, pubic tubercle? Because these are the bony landmark for all the quadrants and all the planes. Okay, so only I have told you that. But yes, SR, if exactly you are talking about transpyloric plane, we have to take the consideration. So exactly if we are talking about transpyloric plane, it is between the xiphy sternum and umbilicus. SR, is it okay? Is it okay, SR? Your doubt is cleared? Nitin? Okay, okay dear. Now subcostal plane. So the next plane is the subcostal plane, and if I am talking about the subcostal plane, the subcostal plane is exactly is a horizontal plane which is running at the level of 10th costal cartilage. So we will talk about the subcostal plane. So this is exactly at the level of the subcostal plane is an horizontal plane. The subcostal plane is at a horizontal plane through the body of the level of 10th costal cartilage and that of 3rd lumbar vertebra. So in subcostal plane lower down you can write it is corresponding to 10th costal cartilage and it is also corresponding to the level of L3 lumbar vertebra. Is it okay? L3 lumbar vertebra. Now transumbilical plane. If I am talking about transumbilical plane, that means transumbilical plane is corresponding to the level of umbilicus and the level of umbilicus is L3 and L4 lumbar vertebra. So what will be the level, my dear students? It will be in between L3 and L4 lumbar vertebra. Okay. Intertubercular plane. The next is the intertubercular plane, and if I talk about intertubercular plane or transtubercular, please note down both name is similar. Transtubercular plane is the same name for the intertubercular plane. If I am using the word transtubercular plane and intertubercular plane, please don't get confused. These are same name, and this is corresponding to the level of L5 lumbar vertebra. L5 lumbar vertebra. Practically, it is corresponding, it's an horizontal line which is passing through iliac tubercles. So, it's an horizontal plane or a line corresponding to iliac tubercle of the hip bone. So, if an horizontal and imaginary plane passes through iliac tubercle, that line is corresponding to intertubercular plane or transtubercular plane. Now, so we are taking into the consideration of, as you can see here, transpyloric intertubercular plane. So we have got transpyloric plane at the level of L1, intertubercular plane at the level of L5 as just I have told you, and mid-clavicular line, that is a vertical line which is running from the midpoint of the clavicle. So we are able to divide the entire abdomen into 9 quadrants. The epigastric region, the right and the left, the epigastric region, the right and the left hypochondriac region, the umbilical region, we have got right and left flanks, we have got right and the left groin region, and we have got the pubic area. So we have got 9 quadrants, and this is how we are dividing into 9 quadrants. So one more plane I just want everybody to understand, and that plane is the supracrystal plane. What is that plane, my dear students? Supracrystal plane. I just want everybody to write all these things and the note point in your, so all of you will have your notebook and you will write all the noteworthy point, and for images I will also share the PDF notes. But what I want that you should write all the important points in your own handwriting. So if anything is left out, you will get the PDF notes also. So the thing is supracrystal plane. When I am talking about the supracrystal plane, it's an anatomical transverse plane lying on the uppermost part of the pelvis, and it is corresponding to the level of iliac crest. What is the level of supracrystal plane? It is at the level of L4 lumbar vertebra. So exactly it is passing through the iliac crest. It is passing through the level of iliac crest highest point. Iliac crest highest point. So it is corresponding to the level of iliac crest highest point, and it is corresponding to the level of L4 lumbar vertebra. Done? Now, I would also like everybody to see this image. Why? Because this is showing you the abdominal region. So, it is also showing the front of the thoracic region and the abdominal region corresponding dermatome level. Actually, there was one time an image based question where around the umbilicus the dermatomal distribution, which is corresponding to T10, has been asked, and this has been asked as an image based question. So, I want everybody to have an idea of dermatomal distribution of anterior abdominal wall. Now, it's also important to know layers of anterior abdominal wall. So, layers of abdominal wall is very important. If I am talking about layers of abdominal wall, you can see this image and you can understand if we exactly what we are going to do in the abdomen session. We want to study the important structures, and also we want to cut open the abdominal wall and we have to enter inside. So, for that we are incising the layers, and when we are starting to incise the layers, we proceed like first layer which we are incising is the skin. Then we go to the superficial fatty layer of the abdominal wall. Actually, the superficial fascia of the abdomen is divided into two layers. The one is the campus fascia, which is just containing the fat, and the membranous layer is the scarpa fascia. So, first thing which we are incising is the skin. Then we proceed with the incising of the campus fascia, and the next layer which is incised is the scarpa fascia. Then we proceed to the first flattened muscle aponeurotic layer, that is the external oblique muscle. Then we proceed for the internal oblique muscle. Then we proceed for the transverse abdominis muscle, the fascia transversalis, and the last structure which has been penetrated is extraperitoneal tissue. Thereafter, we will come to the peritoneum layer. So, is it okay, everyone? You should have the idea, the structures or the layers of the abdominal wall which will be incised to get inside the abdominal cavity. The layers being incised as you proceed from outside to inside is the skin, the campus fascia, the scarpa fascia, the external oblique muscle aponeurosis, the internal oblique muscle aponeurosis, the transverse muscle abdominis, the fascia transversalis, and extraperitoneal tissue. So, these are the layers. Okay, dear? If any time you want me to repeat anything or you want me to wait, is my pace okay? Those who are live, please tell me, is my pace okay? Okay? Now, the next thing is to know the remnants at the level of umbilicus. So, it's very important to know the remnants which is located at the level of umbilicus. So, if I am talking about the remnants, you have to just see this image and you can understand the remnants at the level of umbilicus. Let me try. Yes, space is okay. Okay, so let's talk about the remnants. Okay, if I am talking about the remnants, I just want to be then single, please. Okay. So, yes, if I am talking about the remnants, you can see this diagram where you can understand the remnants at this level. So, let me slightly enlarge it. Now, is it okay? Yeah. So, exactly what things you have to know for understanding the remnants. At the level of umbilicus, the level of umbilicus is corresponding to the level of L3 and L4 lumbar vertebra, and we have got following remnants. So, we have got the ligamentum teres as the first remnant, which is containing the remnant of left umbilical vein. We have got one median umbilical ligament which is containing the remnant of urachus. Urachus is the allantois, and this structure is connecting the apex of urinary bladder with the umbilicus. Then we have got the medial umbilical ligaments which is containing the remnant of umbilical artery, and then laterally we have got the lateral umbilical ligament fold. Actually, two lateral umbilical fold are there which is traversing over the inferior epigastric vessel. So exactly these are the remnants which you have to know. I just want everybody to see another image to understand the remnants more clearly. So all of you please proceed in seeing the next image. So this is exactly the level of umbilicus. What is this? This is exactly the level of umbilicus. This is exactly the level of umbilicus. Okay. Now, as I told you, there will be one remnant above. So this is falciform ligament, my dear students. This is falciform ligament, and this is the lower part of falciform ligament, which is ligamentum teres. What is it? It is ligamentum teres. Okay. Okay. So this is ligamentum teres, and this is ligamentum teres. And my dear students, what does ligamentum teres contain? Students, what does ligamentum teres contain? The remnants of, please write down, left umbilical vein. It contains the remnant of left umbilical vein. Umbilical vein, left umbilical vein. Okay. Now, in the midline, okay, in the midline, we have got another remnant. And what is this called as? This is called as median umbilical ligament. This is called as median umbilical ligament, and it is a remnant of urachus. It is a remnant of urachus. It is a remnant of urachus. Okay. Now we have got two lateral remnants also. We have got two lateral remnants, as you can see. This is one on either side. What is it called as? It is called as medial umbilical ligament. And my dear, it is containing umbilical artery. It contains the remnant of umbilical arteries. Umbilical arteries. And we have got two fold. I just want to use another color for the two folds. So we have got two folds as on either side, which is not, as you can see, this is lateral umbilical fold. So these are lateral umbilical fold, and lateral umbilical fold contains inferior epigastric. This fold is over which structure? Inferior epigastric vessel, the epigastric vessels. Okay, dear. So these are all. So that means you have to know one, you have to know this second, you have to know this third, and you have to know this fourth. So altogether we have to know these four folds and ligaments which is containing which structure. So okay, that is very important for you to note down. So we have got ligamentum teres at the level of umbilicus containing left umbilical vein. We have got one median umbilical ligament which is containing the urachus. We have got two medial umbilical ligament which is containing the remnants of umbilical artery. We have got one fold, that is lateral umbilical fold, running over inferior epigastric vessel. Is it okay, everyone? Understood? Can we move on to the next, that is the muscles, muscles of the abdomen? Okay. Now, so can everybody have a look on this image that is showing you the muscles? So basically this is showing you the muscles of anterior abdominal wall. So if I am talking about this image, I just want everybody to concentrate on the muscles of abdominal wall, that is the flattened muscle as you proceed from outside to inside. So we have got external oblique muscle as the most outermost muscle layer, then we have got the internal oblique muscle, and then we have got transverse abdominis muscle. So we have got three layers, we have got 3 layers of the muscle which is proceeding as you proceed from outside to inside. We have got external oblique, we have got internal oblique, and we have got transverse abdominis. Okay, dear. So we have got external, internal, and transverse abdominis muscle as you proceed from outside to inside. So in brief, so exactly here, if you will just see here, I am enlarging it. Can you see the external oblique muscle? So there is an direction made. So exactly, if you will see this image, you can understand that the direction of transverse abdominis muscle, this is the transverse abdominis muscle. Okay, I will come, yeah. So can you see the direction of transverse abdominis muscle is lower down and medially, it is downward and medially, and just opposed. So this was the first one, this was the first one, that is, sorry, external oblique muscle. Transverse abdominis muscle, the fibers are transversely running. So external oblique muscle, the fibers are running forward, downward, as you can see, medially. Internal oblique muscle, the direction of muscle fibers are just the opposite of external oblique muscle, it is directed upward. And transverse abdominis muscle is directed, fibers are in transverse direction. So actually, for appreciating these muscle layers, you have to go for cadaveric dissection. You have to go for cadaveric dissection in a systematic manner. You have to dissect the first layer firstly, that is external oblique, then you will go with an internal oblique, and then you will go with the transverse abdominis muscle. Now, I just want basically you have to just have an idea of these muscles attachment. So, the first muscle will be the external oblique muscle. So, if I am talking about external oblique muscle, the external oblique muscle originating from the ribs, that is 5, 6, 7, 8, from the lower 7 ribs. Insertion is in the linea alba. Actually, it inserts from the xiphoid process. It starts inserting into the midline xiphoid process, linea alba. Lower down, the fibers will also go to inguinal ligament, anterior superior iliac spine. The nerve supply is that of the thoraco-abdominal nerves, that is originating from T7, T11, and also the subcostal nerve. What will be the action? The flexion of the trunk and the contralateral rotation of the torso, that is trunk. So basically, you have to have an idea of the attachment. It's not that much detail is needed, but you should know that these muscles are originating from the ribs, lower 7 ribs, and inserting into the midline in the form of linea alba, xiphoid process, and lower it also go to the anterior superior iliac spine and iliac tubercle. The nerve supply is through the thoraco-abdominal nerves and subcostal nerves, and the action is flexion, contralateral rotation and flexion of the trunk. If I talk about internal oblique muscle, as I told you, the direction is just the opposite. The direction is just the opposite of external oblique. So this will be directed in upward direction. Okay. So that means origin will be from the lower down. Okay. External oblique was originating, if I am talking about external oblique, that was originating from the ribs and inserting lower and going also some fibers to the xiphoid process. But this will originate from the inguinal ligament iliac crest and will insert into linea alba. Also, the internal oblique muscle joins with the transverse abdominis muscle to form conjoint tendon. The nerve supply is thoraco-abdominal nerves, T7 to T11, subcostal nerve. The action is, when there is a bilateral action, it will cause compression of the abdomen, and when there is unilateral contraction, it will cause rotation. The transverse abdominis muscle, as by the name only, it is clear that the fibers are running transversely. It also originates from iliac crest and inguinal ligament. Insertion is into xiphoid process, linea alba. The nerve supply is subcostal nerve, iliohypogastric, ilioinguinal, and the action is compression of the abdominal content. Okay. So these all information are there. You just have an idea of this. Basically, you can get an image based question to identify this muscle, and the action should be known to you. Now, other than this transverse muscles, this horizontal running or flattened muscle, we have got vertical muscle also. So I just want everyone to concentrate on this image. Everyone, is it okay? Can you appreciate this? So this green color muscle is called as the pyramidalis muscle, and it is only present in 20% of the population or individual. So I have gone for the number of dissection, and what I have found that in 20% of the population and individuals only we find the pyramidalis muscle. So what is this muscle? This muscle is pyramidalis muscle. Actually, overall we have got two vertical muscle. One is the rectus abdominis muscle and the other is pyramidalis muscle. So we have got a pyramidalis muscle and we have got a rectus abdominis muscle. So we have got two muscles, and it's very important for you to know the attachment of these muscles and also the action nerve supply. So we have got one small muscle vertically, that is pyramidalis muscle, and this white color strip which you are seeing is the linea alba. Everyone, are you understanding? Any doubt, please let me know. Okay. Now, here, if I talk about the pyramidalis muscle, it originates from the pubic symphysis and the pubic crest. As I told you, it is inserting into the linea alba. The white color structure has been shown, and the nerve supply is subcostal nerve, the root valley T12. The action is, its action is to tension the linea alba. What it is causing? It is causing the action of tensioning the linea alba. So this is the action of pyramidalis muscle. This is the action of pyramidalis muscle. Okay. All of you are understanding, my dear students? I have kept multiple images to make you understand. You can write the crux point and you will get the PDF notes also, but I want everybody to be attentive to the session live, because in between I will solve MCQs along with you. Okay. Okay, Pandit. Okay, Shyans Pandit. Now, the other cadaveric image which I want you to show is that of the another vertical muscle. Okay. So, if we are concentrating into the other vertical muscle only in this image, so I am just enlarging it. Okay. So, here I just want everybody, can you appreciate the rectus abdominis muscle? This is another vertical muscle which is the rectus abdominis muscle. As you can see here, rectus abdominis muscle. Okay. Now, here if I talk about rectus abdominis muscle, the rectus abdominis muscle originates from the crest of pubis and it inserts into the costal cartilages of the ribs, that is 5-7 xiphoid process of the sternum. So, it is inserting into the costal cartilages of the ribs. 5th to 7th xiphoid process and that of the sternum, as you can see here. The nerve supply is from T7 to T11 and the action is flexion of the lumbar spine. Flexion of the lumbar spine. So now we have got an idea of the muscles of anterior abdomen. I could have skipped this topic also, but what I feel that when we go to the inguinal structures and all, the muscles name come, and at times you are quite confused about these muscles because you have forgotten it in the first year MBBS exam ke baad, it's a quite a long gap after which you are seeing this muscle. So I think you must have forgotten. So I have given a quick recapitulation of the muscles. Is it okay, my dear students? Now, the next topic is the rectus sheath. Okay. So, the next topic which everybody should understand is the rectus sheath, and why it is very important I will tell you, because rectus sheath formation and the contents are important. If I talk about rectus sheath, why it is important for you to understand rectus sheath, you have to know about the formation and content. So actually the sheath is complete in the anterior aspect, but it is deficient in the posterior aspect. So we have got a muscle, we have got a horizontally flattened muscle, that is the transverse abdominis, we have got external oblique, we have got internal oblique, and these muscles are forming anterior layer and the posterior layer for the rectus sheath. So, if we see the anterior aspect of rectus sheath, it is complete, but posteriorly it is deficient, and we have to know which are the structure which is forming these layers. So, let's talk about that. So, for understanding this, I just want everybody to see this schematic diagram. So, this is a schematic diagram which will help you to understand how the rectus sheath is made. So, the green color structure which you are seeing is the aponeurotic layer of the muscle. So, here EO, what is EO? EO for external oblique muscle, IO for internal oblique muscle, TA for transverse abdominis muscle, and TF is for the transversalis fascia. So, if I am talking about this sheath, what you can see, the anterior wall, the anterior wall of the rectus sheath is always complete and it is formed by the muscle. So, we can see external oblique muscle above the level of costal margin is forming the anterior wall of rectus sheath. So, what is the level? The level is above the costal margin. Now, we will see the formation of rectus sheath above arcuate line. So, when I am talking about above arcuate line, just see the second image, okay, the second level, that is above arcuate line. Now, what is arcuate line? I will tell you. Actually, posteriorly, all the layers of the flattened muscle when become deficient and all the layer traverse in the anterior aspect, that level is called as arcuate line. So, above arcuate line, we have got the internal oblique muscle is diverging into two laminas, as you can see. Can you appreciate? This is the internal oblique muscle, and here in this diagram you can see that this internal oblique muscle is diverging into two layers. Okay, so very nicely you can appreciate this. So this internal oblique muscle is diverging in two layers as shown in this diagram. So it is diverging in anterior and posterior lamina, and external oblique muscle, anterior lamina of internal oblique muscle is forming anterior wall of rectus sheath. Posterior lamina of internal oblique muscle, transverse abdominis, all are forming the posterior wall of rectus sheath. Now, there are two other levels which is important for you to understand. One is below the level of arcuate line, and the other is just above the pubic symphysis. So, what you can appreciate below the level of arcuate line and just above the pubic symphysis, we have got all the three flattened muscle, external oblique muscle, internal oblique muscle and transverse abdominis muscle. All these three layers has been moved outside. This is moved on the anterior wall, and only fascia transversalis is lying posteriorly. That means below the level of arcuate line and above the pubis, the posterior wall of rectus sheath is deficient. No muscle is there, only fascia transversalis layer is there, and all the other layers has moved anteriorly. Is it okay? Okay, have you understood the formation of rectus sheath? Shans, SR, Essing, Nitin, Ramu, okay. Now, the other important point is to know the contents of rectus sheath. When I am talking about the contents of rectus sheath, you have to know all the structures which is lying inside the rectus sheath in between the structure. So, actually one more thing is very important for you to know, that the neurovascular plane, in case of, we have got nerves and vessel traversing in the abdominal and the abdomen also. Exactly, tomorrow will be the session of thorax, so there also I will tell you about the neurovascular plane. Here, if I am talking about the neurovascular plane is residing between the internal oblique muscle and the transverse abdominis muscle. That means intermediate layer and that of innermost layer. So that is the neurovascular plane. Now, exactly, nerves and vessels are traversing in that. Rectus sheath content will be, it contains two vertical muscle. What is the name of that vertical muscle? Rectus abdominis and pyramidalis. You can appreciate that in pyramidalis, I have written if present. What I have written? If present. Why? Because we know that pyramidalis muscle is present only in 20% of the individuals. We have got two arteries, superior and inferior epigastric artery. We have got superior inferior epigastric vein. We have got nerves. We have got lower 6 in the thoracic nerves, including the 5 intercostal nerves, the subcostal nerves, and they are also combined by the parts of posterior intercostal vein. So, all these structures which I have written here are the content of rectus sheath. These are all the content of rectus sheath. Okay. Now, the next topic which I want everybody to understand is that of the inguinal ligament. So, let's talk about the inguinal ligament. Now, exactly what is inguinal ligament? Inguinal ligament is formed by, if I am talking about inguinal ligament, it is formed by the lower part of the external oblique muscle aponeurosis. Okay. So, for inguinal ligament, so many questions has been asked, and what are the important questions being asked? You have to know about the extent of inguinal ligament. You have to know about the extensions. You have to know about the attachment of inguinal ligament. So, in this diagram, the two concepts must be known to you. One is what is midpoint of inguinal ligament and what is mid-inguinal point. So, you have to know about the difference between mid-inguinal point and midpoint of inguinal ligament. So I just want to highlight these 2 points. So one is midpoint of inguinal ligament and the other is mid-inguinal point. So these 2 differences you have to know. So by seeing this image, everyone please concentrate on this image. The midpoint of inguinal ligament is, so if you will see the inguinal ligament, okay, so this is exactly the inguinal ligament. I am just using dark green color for showing you the inguinal ligament. So this is extending between anterior superior iliac spine and pubic tubercle. So what is, and I will put a red color mark on the midpoint. So what is the midpoint of inguinal ligament? The midpoint of ASIS and pubic tubercle. Pubic tubercle. And if I am talking about the midpoint of mid-inguinal point, so this is the line which is the mid-inguinal point. So this is mid-inguinal point. So if I am talking about mid-inguinal point, midpoint, it is exactly the midpoint of ASIS and pubic symphysis. Okay. So this is the difference between the 2 bony landmarks. Midpoint of inguinal ligament will be the midpoint of ASIS, anterior superior iliac spine of the hip bone, and pubic tubercle. Mid-inguinal point means the midpoint of ASIS and pubic symphysis. Pubic symphysis. So this is the difference and which has to be known to you. Is it okay? Now, inguinal ligament, how it is formed and what are its parts, that is highly important for you to know. So let's talk about that. Inguinal ligament. So inguinal ligament is actually formed from the lower arched fibers of, it is formed from the lower arched fibers of external oblique muscle and it is extending from the ASIS and that of pubic tubercle. So inguinal ligament, please write down inguinal ligament. So just now I have given you the details also. Inguinal ligament. Inguinal ligament. So when I am talking about inguinal ligament, as shown in this diagram also, you can see it is extending from ASIS, anterior superior iliac spine, to that of PT, that means pubic tubercle. So inguinal ligament is thick fibrous band extending from anterior superior iliac spine to the pubic tubercle. Okay. So inguinal ligament done. Now you can write inguinal ligament. Inguinal ligament lies beneath the fold of groin and it is formed by lower free border of external oblique muscle. External oblique muscle aponeurosis. So this is how the inguinal ligament is formed. The other name of inguinal ligament is, it is also called as groin ligament. So what is the other name? So you can just write inguinal ligament is also called as groin ligament and it is also called as Poppart ligament. So these are few other names of the inguinal ligament. Now the next thing is to know, so these are few other names of inguinal ligament, and the next thing is to know the extensions of inguinal ligament. So let me show you this image. So when you will see this image, I am slightly enlarging this. Okay. Now in this diagram, you can appreciate the extensions or the expansions of inguinal ligament. You can appreciate the extensions and the expansions of the inguinal ligament. So this is exactly the inguinal ligament, and we have got four extensions. So one is the lacunar ligament, the other is the pectineal ligament, the other is ilio-inguinal ligament, and the fourth is the reflected part of inguinal ligament. So you can see in this diagram, I have marked four structures, which is exactly the extensions from the inguinal, the expansions or the extensions from inguinal ligament. So if you will see the lacunar ligament, you can appreciate this is exactly this triangular structure which you are seeing is the lacunar ligament. Now, this fibers are actually the lacunar ligament. Actually, it is also called as gimbernate ligament, and it is an extension from medial deep fibers of inguinal ligament, which is passing horizontally backward, and it is attached onto the pecten pubis. So you can see it is triangular and it is attached to pecten pubis. It is the other name is gimbernate ligament. The next ligament is the pectineal ligament. So when I am talking about the pectineal ligament, this one is the pectineal ligament. So when I am talking about the pectineal ligament, it is a backward extension. So this pectineal ligament is it is a backward. Actually, it's an extension from the posterior aspect. So I will use yellow color for this. So this is a posterior extension of the. You can see this is the posterior extension from lacunar ligament, and it is going till the level of iliopectineal eminences. So you can mark this structure. This is iliopectineal eminences, and it is reaching the level of iliopectineal eminences. The other name of pectineal ligament is Cooper ligament. The third extension which everybody should understand is the ilioinguinal ligament. So actually ilioinguinal ligament is an extension which is a downward extension from the inguinal ligament till the level of iliopectineal eminences. So this is exactly running above to down. As you can see, it is an extension which is extending from downwards from the inguinal ligament to that of iliopectineal eminences. So it is also going till the level of iliopectineal eminences. Done. Now the fourth is the reflected part. If I talk about the fourth one, that is the extension, if we are talking about, that is the reflected part. So this is the reflected part of inguinal ligament. And if you will see the reflected part of inguinal ligament, this is superficially running. So reflected, if I am talking about the reflected part of inguinal ligament, which is the fourth extension, it is the superficial fibers of inguinal ligament extending medially upward. So you can see it is extending medially upward, and it is exactly lying behind the superficial inguinal ring and in front of conjoint tendon. It is lying behind superficial inguinal ring but in front of conjoint tendon. This structure which you are seeing is the superficial inguinal ring. Okay, so let's talk about the expansion. So the next thing is, so please write on the heading. Write on expansions of inguinal ligament. Expansions of inguinal ligament. So expansions of inguinal ligament. You can just highlight this also. Okay, expansions of inguinal ligaments. So how many expansions we have got? We have got 4 expansions. We have got 4 expansions. So one by one, write down the name. The first one is lacunar ligament. And what is the another name? Gimbernate ligament. Gimbernat's ligament. It is also called as Gimbernat's ligament. And if you want to write briefly, either you can just go for the, so is it okay? I have explained, can I write the names? Is it okay? We are understanding it from the image. Everyone, please let me know. Is it okay? Can I write the names only because I have already explained in the image? Is it okay? Just the names and the other name. It is quite clear by the image. Okay, the second is the patenial ligament, which is also called as the ligament of Cooper. The third is ilioinguinal ligament. And the fourth is reflected part of inguinal ligament. Okay. So these are the four parts of or expansions of inguinal ligament. These are the four parts or expansions of inguinal ligament which must be known to you. Is it okay? Now we have done with this. Now the next topic is the subinguinal space. So I just want briefly for you to understand the subinguinal space. So when I am using, please see this image. When I am using this, so you can just have, okay, this is exactly, okay. So this is exactly ASIS, anterior superior iliac spine, and this is pubic tubercle. So this green color structure is inguinal ligament, no doubt about that. Now below the inguinal ligament, you can see there is a space in which we have got the muscles. We have got iliacus and psoas major muscle. We have got iliacus and psoas major muscle as shown, and we have got the vessels, femoral artery, vessels, and the nerve. So these space is called as subinguinal space. So that is important for you to know, and we can see the nerves and the vessels are residing it. The other name of subinguinal space is pelvifemoral space. So please write down about subinguinal space. It is also called as pelvifemoral space. Okay. So it is exactly this space below inguinal ligament is divided into two parts. Is divided into two parts. A large lateral part called as lacunae, large lateral part called as lacuna musculorum, and medial small part is called as lacuna vasculorum. Okay, so when I am using the word lacuna musculorum, it contains the iliacus and psoas major muscle. When I am using the word lacuna vasculorum, it contains the femoral vessel and also the nerves. Okay, so that is already marked here. So exactly we will have here lacuna vasculorum means the femoral artery and femoral vein, and musculorum is the iliacus and psoas major muscle, and in between these two musculorum boundary only we have got the femoral nerves also. You can see this. So if you will see this, this is exactly the landmark. You can use this. Yeah. So this is exactly the landmark, and you can see the iliacus and psoas major muscle is there. Iliacus, psoas major muscle, and also the femoral nerve, and in the vascularum we have got the femoral vessel. So done. Now the next topic which is highly important for you is the inguinal canal. So you have to know about the inguinal canal, its formation, its walls, and you have to know about the details of superficial and that of, you have to know about superficial and you have to know about the deep inguinal ring. Okay dear, can we move to the next topic? That is inguinal canal. Everyone, are you understanding? Next topic, inguinal canal. Are you understanding? Okay, just checking with the, okay. Now, let's talk about inguinal canal. So, if I am talking about inguinal canal is a oblique intermuscular space as shown in this diagram also, and it is extending from deep inguinal ring. It is extending from deep inguinal ring to that of superficial inguinal ring. So, it's actually an oblique intermuscular space which is exactly 4 centimeters, 3 to 4 centimeters in the length, traversing, or it is located above the medial half of inguinal ligament, and it is extending from deep inguinal ring to superficial inguinal ring. Okay, so let's talk about that. Inguinal canal. Inguinal canal is an oblique intermuscular passage. It's an oblique intermuscular passage about 3 to 4 centimeters lying above the medial half of inguinal ligament. Okay. Now, if I talk about the extent and direction, so done with this. Now, extent and direction. Extent and direction. Inguinal canal extends from deep inguinal ring to superficial inguinal ring. And you have to know about deep and superficial inguinal ring. The next thing which is important for you is to know the deep inguinal ring and superficial inguinal ring. Then we will come to the walls. So the next thing is write down deep inguinal ring, and then we will have superficial inguinal ring. These two rings you have to know, superficial and deep inguinal. So when we are talking about superficial and deep inguinal ring, the deep inguinal ring is an oval opening. So it's an oval opening. It's an oval opening in the fascia transversalis. In which layer, my dear students? Fascia transversalis. It's an opening in the fascia transversalis and lies 1.25 centimeters. So 1.25 centimeter is corresponding to half inch above the mid inguinal point, above mid inguinal point, above the mid inguinal point. Superficial inguinal ring. So we have done with deep inguinal ring. Now the next is superficial inguinal ring. Superficial inguinal ring is a triangular opening. Superficial inguinal ring is a triangular opening. It's a triangular opening in the aponeurosis of external oblique muscle, in the aponeurosis of external oblique muscle, and is located above and lateral to pubic crest, above and lateral to pubic crest. So we have done with the location of superficial and deep inguinal ring. So we have finished with the location of superficial and deep inguinal ring. Now we will talk about the walls of inguinal canal. Okay, dear. The next thing which is important for you is to know the walls of inguinal canal. Okay, so let me just check it. Okay, anything which you are not understanding, please let me know. Now for understanding the walls, I will just enlarge this image and I just want everybody to concentrate on this image where you can understand the walls of inguinal canal. So it's very important to understand the walls of inguinal canal, has been asked so many times in the examination. So that is important. If I am talking about superficial deep inguinal ring, we have already done, and we have got many structures traversing from this ring. Actually, in case of we will have many structures traversing through it, or we can also talk about the content of inguinal canal after the boundaries. So boundaries, as you can see, we have got an anterior wall. So we have got an anterior wall. We have got a posterior wall. We have got a roof. And we have got a floor. So exactly, if I am talking about anterior wall, the anterior wall of inguinal canal is formed by the anteriorly. If we talk about inguinal canal, it will have the skin, it will have the superficial fascia, it will have the external oblique muscle in the overall extent, and also the part of internal oblique muscle that is in the lateral part only. If I talk about the posterior wall, this is P for the posterior wall. So the posterior wall is lying fascia transversalis, and it is also having the part of conjoint tendon which is formed by transverse abdominis and internal oblique muscle. If we talk about the roof is formed by the arched fibers of internal. So you can see the roof is formed by these two muscles. This two muscle is forming the roof, that is the arched fibers of transverse abdominis and internal oblique muscle, and the floor is formed by the inguinal ligament mainly, and in medial part it will have the lacunar ligament. So this is about the four walls of the inguinal canal. So write down walls of inguinal canal and then we will write the content. So the heading will be written, everyone. So seen this image, now I want everybody to write on the heading. Walls of inguinal canal. walls of inguinal canal. Walls of inguinal canal. So write down boundaries. That means boundaries. So we will talk about the first boundary, that is anterior wall. An anterior wall is formed by skin, superficial fascia, external oblique muscle, and that of internal oblique muscle. Internal oblique muscle aponeurosis. Actually, it is in the lateral part only. Internal oblique muscle. So this is boundaries, and then we will have the posterior wall. The posterior wall is formed by fascia transversalis, and by conjoint tendon. So exactly conjoint tendon, which is, we know that conjoint tendon is formed together with the transverse abdominis and that of internal oblique muscle. So they are formed in the medial part. They are forming the medial part of posterior wall, and also the reflected part of inguinal ligament will be there in relation to medialmost part. So write on this. The third is the roof and the floor. Roof and that of floor. So if I talk about the roof is formed by lower arched fibers of I am writing in short internal oblique and transverse abdominis. Floor is formed by inguinal ligament. Floor is formed by inguinal ligament and also lacunar ligament. Actually, lacunar ligament is an expansion of inguinal ligament in the medial part. So this is how we have done with the overall details of the anterior, posterior wall, roof and floor of inguinal canal, which is important for you to understand. So we have done with this topic, and the next thing is to know the content. So for the content, I will show you an image. Actually, in males, the content will be the spermatic cord and ilioinguinal nerve, and in females, it will be the round ligament of uterus and ilioinguinal nerve. So that is basically the content. So here, so exactly for the content, so please write down. Content. So continuing with the topic of inguinal canal, we will talk about the content. Yeah. So here you can write in males, the content is spermatic cord and ilioinguinal nerve. In females, the round ligament of uterus and ilioinguinal nerve. Okay, round ligament of uterus and ilioinguinal nerve. Got it? Now, if we have done with this, now we will talk about the spermatic cord and its content. So that is very, very important for you. So if I am talking about the spermatic cord and the content, you have to see again this image. Okay. So yes, students, are you having any doubt? Please let me know. Are you having any doubt? Okay. Are you understanding? At times everybody is worse that we can see the session afterwards also, but I want everybody to be concentrating live. Okay, now I already have told you that the spermatic cord is a content. Okay, I already have told you that the spermatic cord is a content, but I just want everybody that you should also be aware of its covering of the spermatic cord and the content which is lying inside. Okay, the content which is lying inside. That is highly important for you. So for understanding that, you can just see this image and you can understand the coverings of the spermatic cord and the contents lying inside. So I just in this image I will tell you the external spermatic fascia is the outermost covering. So is exactly if we see this image, you can understand the external spermatic fascia is exactly derived from the external oblique muscle. We have got the cremaster muscle and the fascia which is derived from internal oblique muscle mainly. We have got the internal spermatic fascia which is derived from fascia transversalis. So you can see we have got three layers, and this is how the three coverings are there. The structure which is lying inside, okay, these are the three layers which is covering the spermatic cord from outside to inside. What are the coverings? The coverings will be what I told you, the coverings will be. So exactly, if I talk about the coverings are exactly the external spermatic fascia, the internal spermatic fascia, the cremaster muscle and the fascia, and the internal spermatic fascia. The external spermatic fascia is derived from external oblique muscle. The cremaster muscle and fascia is derived from the internal oblique muscle. What lies inside? The innermost layer is internal spermatic fascia, which is derived from the fascia transversalis. The contents which is residing inside are the testicular artery branch from abdominal aorta, cremastic artery branch, cremastic vessel branch from the inferior epigastric, and also we have got artery to ductus deferens, vas deferens. We have got testicular veins, lymphatics, we have got genital, we have got also the Pampniform plexus, processus veins and processus vaginalis. So all the contents and coverings has been shown in this diagram. Now, for your examination point of view, I just want everybody to have an idea of three important triangles for the MCQs being asked. So, you should know what are the three important triangles which is importantly asked for your MCQ. So, please write down the three important triangles are ilioinguinal triangle, we have got ilioinguinal triangle, we have got Doom's triangle, we have got triangle of pain. So these are three important triangles which is important for MCQ and must be known to you. Okay, must be known to you. Now, first triangular space which I want everybody to understand is the inguinal triangle, which is also called as Hazelback triangle. The first triangular space which should be known to you is the inguinal triangle or Hazelback triangle. Okay, so just a minute, you just concentrate on this. Can everybody appreciate the green triangular area? That green color triangular area is the location of inguinal triangle, which is also called as the Hazelback triangle. And this image itself, you can understand the boundaries of inguinal triangle. And so let me just explain it. So here you can see this is the rectus abdominis muscle. Which muscle is this? This is the rectus abdominis muscle, the vertical abdominal muscle. Okay. Okay, so here we have got rectus abdominis muscle, and if I talk about this rectus abdominis, this is RA for the rectus abdominis muscle, which is forming the medial wall of the inguinal canal, ilioinguinal triangle, and in the lateral aspect you can see we have got the inferior epigastric vessel. What is this? This is inferior epigastric vessel. So this is lateral aspect, and below if you will see, in the lower aspect if you will see, we have got the inguinal ligament. So this is the inguinal ligament. So below we have got the inguinal ligament. This is whole about the inguinal. So this is overall boundary of inguinal triangle. Is it okay? Have you understood the boundaries? It is bounded by rectus abdominis muscle medially, inferior epigastric vessel laterally, and inferiorly by the lower aspect by the inguinal ligament. So a very important mnemonic for understanding the boundaries of if the Hasselbalch triangle or ilioinguinal triangle is RIP. RIP. So here R stands for rectus abdominis, I stands for inferior epigastric vessel, and P for Poppart ligament. We know that the other name of inguinal ligament is Poppart's ligament. So inguinal triangle boundaries or Hasselbalch triangle, you can just write down. Boundaries can be remembered by the mnemonic RIP, RIP. So write down boundaries of inguinal triangle. Boundaries of inguinal triangle. So the mnemonic is RIP. Here R for rectus abdominis muscle, I for inferior epigastric vessel, P for Poppard's ligament. So if I am talking about the Poppard's ligaments, exactly Poppard's ligament is the other name of inguinal ligament only. So here we have got rectus abdominis muscle medially, we have got inferior epigastric vessel laterally, and we have got inferiorly the Poppard ligament. And the other important aspect is what is forming the floor. If you understand, if we talk about the floor of this triangular space, the floor of this triangular space is exactly covered by peritoneum, extraperitoneal tissue, and fascia transversalis. So it is having peritoneum, it is having extra peritoneal tissues and fascia transversalis Okay, fascia transversalis. Done? Okay. Now here, so yes, done with this. Yeah. Now we will talk about triangle of Doom. The next important thing is to know about the triangle of Doom. The next important thing is to know about the triangle of Doom. So when I am talking about the triangle of Doom, so actually why triangle of Doom and triangle of pain is very important for you to note down. Actually triangle of Doom and triangle of pain is the two triangular space which has been mentioned by the these triangular spaces have been mentioned by the laparoscopic surgeon, because while putting surgical staples in this area, the anatomy should be known in this area very well. Why? Because in the triangle of Doom, if we are not paying attention to the contents lying nearby, we will be able to injure, and there can be chance of injury of external iliac vessels. So external iliac vessels are important vessels residing there, so surgical staples should be avoided in this area. So it is called as triangle of Doom. Other than that, also genital branch of genitofemoral nerve lies here. So this is showing you the triangle of Doom. So actually boundaries is already shown in this image. So boundaries is already shown in this image. Okay. So it is bounded by gonadal vessels, ductus deferens, and the peritoneal edge, and the contents are external iliac. What is this? This is external iliac vessels. Now, if I talk about triangle of pain, so exactly if we take together triangle of Doom and triangle of pain together, we term it as a quadrangular area. So together these two triangular space will form a quadrangular area, and surgical staples are avoided. So as I told you, triangle of Doom, the surgical staples should be avoided because of injury of the external iliac vessels. But if I talk about triangle of pain, the importance is that so many important nerves are lying there. So if I am talking of triangle of pain, we have got many important nerves residing there. We have got femoral nerve, we have got femoral branch of genitofemoral nerve, we have got anterior femoral nerves, we have got lateral femoral nerves. So actually these are the structures which is residing there. So exactly we have to avoid surgical staples putting in this area. So because we can injure the important nerves residing there. So done with this. So now we will talk about the next topic. So I just want you, so exactly when I will take a lower limb session, I will talk talk there about the femoral hernia. Now the clinical importance of this inguinal region is that two important hernias are located in this structure, in this area. One is direct inguinal hernia, another is indirect inguinal hernia. So it's very important to know the clinical aspects. Okay, dear. So exactly after this, I am just going with the questions. Okay. So after finishing this, we will have the questions, MCQs related to this topic. So this is the last topic, and we will have few MCQs because that is very important. So exactly in this diagram, you can see the site of femoral hernia. You can see the site of direct and indirect inguinal hernia. So basically the anatomical landmark which is important for differentiating the location of direct and inguinal hernia is inferior epigastric vessel. Is the inferior epigastric vessel. So we will have indirect inguinal hernia and we have got direct inguinal hernia. So inguinal hernias are actually protrusion of the loops of intestine through the inguinal canal, and indirect inguinal hernia occurs if the hernial sac is protruded through deep inguinal ring. So you can see this is the deep inguinal ring, and if the herniation is occurring via deep inguinal ring, this is called indirect inguinal hernia. And if the herniation is occurring via the walls of inguinal canal, or you can see via inguinal triangle, that is medial to inferior epigastric vessel, is direct inguinal hernia. That means indirect inguinal hernia is lateral to inferior epigastric vessel. Direct inguinal hernia is medial to inferior epigastric vessel, and below inguinal ligament we have got the site of femoral hernia, which is lying below inguinal ligament. These two structures are lying above inguinal ligament. So femoral hernia, we have already will talk in the femoral triangle region area, and this is a herniation occurring via femoral canal. So protrusion is via femoral ring, which is lying below inguinal ligament. So just a minute. So write down one of the important point. Direct inguinal hernia. The protrusion of abdominal content is via posterior wall of inguinal canal, that is directly via inguinal triangle. Indirect inguinal hernia the protrusion of abdominal content is via deep inguinal ring. And in between these two structures we have got inferior epigastric vessel. So other important point about inguinal hernias are that clinically it is present. If you will see, the major difference between inguinal hernia and femoral hernia is that clinically it is present as a pear-shaped swelling above and medial to the pubic tubercle. So inguinal hernias are located above and medial to pubic tubercle. And in this diagram itself you can see it is lying lying below. Femoral hernia will be lying below to that of the pubic tubercles, and it will be lateral and below the pubic tubercle. So exactly what is important for us to know that medially, if we talk about medial aspect, we have got medial inguinal hernia, that is the direct inguinal hernia, and in the lateral aspect to the inferior epigastric vessel, we have got indirect inguinal hernia. So basic difference. So the same thing has been written, but if I above and okay, above and middle. So if I talk about the basic differences, so basic anatomical difference, is the landmark of pubic tubercle. So that means if we want to differentiate femoral inguinal hernia, we will take the landmark of pubic tubercle. And if we want to see the difference between direct and indirect inguinal hernia, we will take the landmark of inferior epigastric vessel. Inferior epigastric vessel. So direct inguinal hernia is medial to inferior epigastric vessel, and indirect inguinal hernia is lateral to inferior epigastric vessel. Vessels. Got it? So the basic difference, the shape, direction, reducibility and age difference, which is very importantly asked in the surgery aspect also for the clinical note, so has been already mentioned. Okay, so that is very, very important. I just want yes, Sanjay, hello ma'am, how are you? Dr. Sharma Punit, yes, I am well. And Sanjay, yes, good morning to everyone. Can we solve few MCQs related to the topic? Everyone, can we just go through this images and can we just have, no, can we go to the MCQs now? Everyone is ready for the MCQs? Then I will start the next topic of, so today target is to finish abdomen and pelvis. Okay. So let's talk about the first question. Everyone, are you ready? So let's solve few of the MCQs related to the topic. Anterolateral abdominal wall is bounded by all except. Anterolateral abdominal wall is bounded by all except. Anterolateral abdominal wall is bounded by all except cartilages of the 7th through 10th rib, linea alba, xiphoid process, inguinal ligament and pelvic bone. So please mark the right answer. Aradha Arora. Pelvic bone wall. They are talking about the wall, dear. They are talking about the wall. So pubic crest, pubic tubercle, pubic symphysis, they are part of pelvic bone only. That is the hint given to you. Now give me the rhyme. So they are talking about the wall, entire wall. So it is bounded by all except. I have given you the hint. The pubic crest, pubic tubercle, pubic symphysis are part of the pelvic bone only, no? So anyone who wants to pay attention to this? So all these structures will be involved in the wall except one of the structures. So one of these structure is interlacing of the muscle. So that is the right answer. I have given you the hint. Can anybody give me the right answer now? Aradhya, Raish, linea alba. Rais has got the right answer and linea alba is perfectly right answer. Yes, dear, linea alba is perfectly the right answer. Yes, linea alba is perfectly the right answer. Linea alba is the interlacing of the muscle. It is not forming the wall. So you can see anterolaterally we have got inguinal ligament is inferiorly, pelvic bone is also inferiorly. We have got cartilages, xiphoid process all forming boundary, but not the linea alba. Yes, Rais, you are right. Now you got it right. Now, now the next question is aponeurosis of all the three flat muscles of anterior abdominal wall interlaces in. Aponeurosis of all three flat muscles of anterolateral abdominal wall interlaces in inguinal ligament, fascia transversalis, linea alba, anterior superior iliac spine or rectus abdominis. Which is the right answer, dear? Yes, absolutely right. Everyone is right. Raish is right. Ramagala is right. Arada is right. Yes, everyone. Yes, linea alba. Linea alba is right. Where is the extraperitoneal fat located? Extraperitoneal fat. If you remember, I have told you about the layers of the abdominal wall. So when you are proceeding in the layers of abdominal wall, I have told you about all the layers being pierced. So extraperitoneal fat is located between which layer? So SR has given the answer, and what about the others? SR, yes. Let everyone give the answer. Yes, dear, absolutely correct. Absolutely correct. E is absolutely correct. It is deep to transversalis fascia. So those who have given E as the right answer, so absolutely SR and SR and also Rama Gala has given absolutely right answer. Great. Now, so actually this I forget to tell you about when I was teaching you about the abdomen, but you can you can with the common sense give me the right answer. Superficial fibers of external oblique muscle is interlacing with one muscle. So if we talk about external oblique muscle, it will interlace with one of the muscle. Can you name it? It is internal oblique serratus anterior, rectus pyramidalis. So it will interlace with one of the muscle. So actually, I will give you an hint. Actually, there is one muscle in the medial aspect of the chest which is having digitation. So that digitation will interlock with external oblique muscle. So one of the muscle having digitations will interlock. One of the muscle having digitation will interlock. So Rais has given the right answer. Yes, it is serratus anterior muscle. Yes, Arun is absolutely right. That is serratus anterior muscle. Yes, SR. Superficial fibers of external oblique muscle will interdigitate with serratus anterior muscle. Absolutely right. Now, I told you that there is a neurovascular plane between transverse abdominis and that of internal oblique muscle. So, all of these structures will be lying in that neurovascular plane except, so that is very, very important for you to know. So, I am talking about neurovascular plane. Please pay attention. I am not talking about rectus sheath. I am talking about neurovascular plane. So, nerves and a vessel passes through it. So, please give me the answer. I am not talking about rectus sheath. So the hint is yeah, no. Yeah, everybody has given mixed bundle of answer. Between internal oblique and transverse abdominis muscle lies the neurovascular plane, and one of the structure is not passing through it. Actually, that structure will pass in the rectus sheath. That structure will pass in the rectus sheath. So exactly, I just told you that rectus sheath में कौन सा structures traverse करता था inferior epigastric vessels. So definitely inferior, yes, SR, now you are right. Inferior epigastric vessel is the right answer. It will be found along with the vein in the rectus sheath. So we have neurovascular structures, cutaneous nerves, iliohypogastric nerves, deep external iliac artery branches, ilioinguinal, everything is lying there, but not the inferior epigastric vessel, because that will lie more vertically in the rectus sheath. Now, can anybody tell me, rectus abdominis muscle is anchored to the anterior layer of rectus sheath by which of the following structures? Uh, that hint I will tell you, that rectus abdominis has a characteristic. If you will see rectus abdominis muscle, it is having in between one of the structure which is giving it strength. So only it is a muscle which is dominant in case of muscular people. So what is that structure which will anchor it to the rectus sheath? No, general anatomy. This is from general anatomy, that it is getting attached to the anterior wall of rectus sheath by anchoring of the. So in case of the hint is six pack muscle is showing you that that part. That is the hint, six pack muscle. Yes, I got a right answer from Aurora. I got a right answer from Rice. It is tendinous intersection. Yes, absolutely right. So I just want you to tell that there is one point where all the muscle, we take a landmark where all the muscles define the point where posterior lamina of internal transverse abdominis muscle, all these muscles go anteriorly. When we were talking about rectus sheath, I told you, so all the muscles forms anterior wall and it is deficient at that level. So what is that level? Take your time, take your time. Rais has given the answer. Raish Ahmad. What about others? What about others? So Tarun has given the answer. Tarun Devra and Aradhya. Everyone has given perfectly right answer. That is called as arcuate line. Absolutely correct. Yes. So actually, inferior limit of the posterior lamina of rectus sheath is called as arcuate line, where all the muscle will go posterior, anterior. So you can see this line where is called as arcuate line, and you can see why this is called as arcuate line, because this is the level where all the sheath muscles, the muscles of abdomen will only seen in the anterior wall and posteriorly they are deficient. Absolutely correct. Two medial umbilical fold is remnant of. Two medial umbilical fold is remnant of. Medial. I am talking about medial umbilical folds are remnant of. Two medial umbilical folds are remnants of. SR has given the answer. What about others? Radhya Arora has given the answer. Waiting for others. Two. See here, it is not median, it is two medial umbilical fold. And SR has definitely given a right answer. SR has given absolutely right answer, and that is umbilical arteries. Yes, umbilical arteries. It is not median. Median hota, if the question was median umbilical ligament or fold, then it was urachus. It is too medial, then it is umbilical artery. See here, median is for the remnant of the fetal structure urachus, but medial is for the umbilical artery, and lateral is over inferior epigastric vessel. Which is the site of potential direct inguinal hernia? Direct inguinal hernia. Which is the site for direct inguinal hernia? Sanjay Goyal, Raish Absolutely correct answer is given by all of you. Absolutely correct answer is given by all of you. It is medial. Absolutely correct answer is given by all. Tarun also has given the right answer, and it is medial inguinal. Absolutely correct. Inguinal canal contains which nerve? Absolutely correct. Everyone has given. This one is right by everyone. Clapping for all of you. Inguinal canal contains which nerve? Inguinal canal contains which nerve? Ilioinguinal nerve is absolutely right. Yes, ilioinguinal nerve is absolutely right. Okay, absolutely right, dear. Which structure give rise to deep inguinal ring? Which structure give rise to deep inguinal ring? SR, Sanjay Goel, Rais Ahmed, Tarun Devra. Absolutely correct. Transversalis fascia is absolutely right answer. Yes, dear, that is absolutely right answer. Lacunar ligament is an extension from deeper aspect of which of the following ligament? So yes, you all were absolutely right for this. Now my question is the next one. That is, lacunar ligament is reflections from which of the following aspects? Again, multiple right answers. All of you have again given a right answer, everyone. Yes, it's the inguinal ligament. The right answer is inguinal ligament. Now coming to the next topic. So we have done with the MCQs now. Layers of the scrotum has been shown to you, and the layers of the scrotum is, it is formed from the skin. It is having a covering of the skin. It is having a covering of dartos muscle. It is also having a covering of external spermatic fascia. Then we have got the cremaster muscle and fascia, and innermost is the internal spermatic fascia. So basically we have got these layers. We have got these layers, and these are the layers of the scrotum. Got it, everyone? What is the nerve supply of scrotum? So the nerve supply of scrotum is ilioinguinal nerve, genital branch of genitofemoral nerve, the posterior scrotal branch of perineal nerve, and the perineal branch of posterior cutaneous nerve of thigh. So these are all the nerves which is giving innervation to the scrotum. These are all the nerves which is giving innervation to the scrotum. Okay. Now the next topic is peritoneum. Okay, so peritoneum, it's a very vast topic, but most important things which you have to know about the peritoneum is that you have to know about its important structure like greater omentum. You have to know about the lesser omentum. You have to know about the hepatorenal pouch of Morrison's. You have to know about falciform ligament. You have to know about the pouch of Douglas, and you have to know about the mesentery. So these are the, and foramen of Winslow. So these are few important things which you have to know. So if I talk about peritoneum, it's a layer which is covering. So it is having a two layers. It is one layer is parietal and the other is visceral. So it is covering the viscera, and it is also covering, it is forming a layer for the abdominal cavity and pelvic cavity. So exactly, it is embryologically, it is derived from the coelomic cavity of the embryo, and it is having, it is between the, it is residing between the visceral and the parietal layer, and it is amount in normal cases is 50 ml. And what is this fluid important for the lubrication of the viscera, and also for the anti-inflammatory properties. So subdivision is, the entire peritoneal cavity can be subdivided into greater sac and the lesser sac, and these two sacs are communicating via foramen of Winslow. So that is, the other name of foramen of Winslow is called as epiploic foramen. So if we see the cavity, that is peritoneal cavity, which is residing between the visceral and the parietal layer, it is called as the layers which is lying between the visceral and the parietal layer of the peritoneum is the peritoneal cavity, and these two spaces are communicating via epiploic foramen or foramen of Winslow. So I just want everybody, this is showing you the So exactly the entire peritoneal sac is basically, can you see the pink color area? The pink color area is the entire sac, and entire sac is basically the greater sac, and the blue color area is the lesser sac. So exactly in this diagram you can see the communication of greater and the lesser sac is shown by an arrow, and this arrow is passing through epiploic foramen. So you can see the space which is lying behind the space. Lesser sac is the space which is lying behind the stomach, and the two sac is communicating via epiploic foramen. Now actually what happens in our body, most of the structures, if I talk about the most of the structures, okay. So yes dear, if I talk about most of the structures in our body is intraperitoneal. Okay, few structures are lying behind, which is having by the process of zygosis, it is few of the structures are primarily retroperitoneal, having the peritoneum covering on one aspect only, and few of the structure is become retroperitoneal by the process of zygosis. So you have to know about all the structures which is in the list of retroperitoneal structure. So you just want to know. So we have got few of the structure which is primarily retroperitoneal, and few of the structures has become retroperitoneal after the process of zygosis. So there is a useful mnemonic. There is a useful mnemonic for the So there is a useful mnemonic for the abdominal viscera which are retroperitoneal, and that mnemonic is sad pucker. What is that mnemonic called as? That mnemonic is called as sad pucker. Okay. So we have got these structures which is, so in for your MCQs it is important that you should know the list of the structure which is retroperitoneal, and the list of the structures can be memorized by the mnemonic, that is sad pucker. Okay. So S for suprarenal gland, SAD, A for abdominal aorta inferior vena cava, D for duodenum except the proximal 2 centimeter, proximal part of duodenum is intraperitoneal, P for pancreas, U for ureter, C for colon, K for kidneys, E for esophagus, and R for rectum. So you should know these are the list of the structure which has become retroperitoneal. Few of the structures like kidneys, ureters are primarily retroperitoneal structures, and few of the structures has become retroperitoneal after the process of zygosis. The mnemonic to memorize retroperitoneal structures in our body is sad pucker. Now, when the peritoneum was forming, actually viscera develop in the peritoneum, and for example, there was a liver developing in the peritoneum anteriorly, and posteriorly also we have got transverse colon, stomach. So many structures develop, starting development of viscera. So this will divide the whole of the mesogastrium into two parts. One is called ventral mesentery and the other is called as dorsal mesogastrium. And we have got stomach, liver developing. So we have to know the derivatives of ventral mesentery, and we have to know the derivatives of dorsal mesentery. So basically, so the derivatives of ventral mesentery is, right and left triangular ligament. We have got, so if you want, I can write bigger one. So it's very small, write on. So I think we have to write so write down derivatives of ventral mesogastrium. So that is right and left triangular ligament. We have got right and the left triangular ligament. We have got superior inferior coronary ligament. We have got superior inferior coronary ligament. We have got falciform ligament. We have got lesser omentum. These are the derivatives of ventral mesogastrium. Okay, these are the derivatives of ventral mesogastrium. Now, derivatives of dorsal mesogastrium. Write down. Done with this. Now, write down derivatives of dorsal mesogastrium. These are gastrosplenic ligament, these are gastrophrenic ligament, these are linorenal ligament, greater omentum. Done. Now we will talk about the greater omentum and all. So we have to know. So what is basically important for us is to know about the different structures. So it's important that we should know about the derivatives of greater omentum. What is greater omentum? What are the contents of greater omentum? What is lesser omentum? What are the contents of lesser omentum? What is mesentery? What is falciform ligament? So let's talk about that. So greater omentum is actually a fold of peritoneum which is hanging from the greater curvature of the stomach. So exactly in this image, if I show you this image, you can clearly see this is the greater curvature of the stomach. Okay, so this is exactly the greater curvature of the stomach, and from the greater curvature of the stomach, you can see the apron-like structure which is hanging, and this is also called as the policeman of abdominal cavity because it is protecting the abdominal cavity, peritoneal cavity from the microorganism invasion and any kind of infection reaching here because it contains macrophages, lymphatics in this layer, and it is actually attached to the greater curvature of the stomach, hanging from the adjacent part of duodenum and covering the loops of intestine to a variable extent. It is important to know the contents. So the contents which will be lying inside, if I talk about the contents, it contains adipose tissue, it contains aggregations of the macrophages, it contains right and left gastroepiploic vessels. So that is importantly importance of greater curvature. So greater omentum. So please write on greater omentum. Greater omentum is a large, thick fold of peritoneum. It's a large, thick fold of peritoneum which hangs from the greater curvature of the stomach, and adjacent part of duodenum, like an apron, and covers the loop of intestine, Now let's talk about the greater omentum content. So greater omentum, so content. So please write down the contents. So write down contents. So if I talk about the contents of the greater omentum, for it contains following structures. So it contains adipose tissues. It contains aggregation of macrophages. It contains aggregation of macrophages. It contains right and the left gastroepiploic vessel. It contains right and left gastroepiploic vessel. Gastroepiploic vessels. And also it's important that it's regarded as a policeman of the abdominal cavity. So it is also called as policeman of abdominal cavity. It is called as the policeman of abdominal cavity. Now talking about the lesser peritoneum. So for that you can see this. So actually lesser peritoneum is actually lesser omentum. If I talk about lesser omentum, it is attached to the lesser curvature of the stomach as shown in this image to that of the liver. So actually it is attached to the lesser curvature of the stomach and the initial part of duodenum. So it's attached to the lesser curvature of the stomach and that of initial part of duodenum to that of the liver. And again it is important that it is actually if we talk about the inferior attachment, inferiorly it is attached to the lesser curvature of the stomach and initial part of duodenum. Its superior attachment will be on the inverted L-shaped manner to the margins of ligamentum venosum and also to the porta hepatic region of the liver. So that is important. So you can see this image and you can understand this is the inferior attachment which is on the lesser curvature of the stomach and initial part of duodenum. Superior attachment is in the liver, that is it is attached to the porta hepatic region and ligamentum venosum. So this is showing you the attachment of lesser omentum. This is showing you the attachment of lesser omentum. So please write down lesser omentum attachment. We will talk about attachment and then we will talk about the contents. So first thing is inferior attachment. So inferiorly lesser omentum is attached to lesser curvature of the stomach and first part of duodenum. Superiorly, if I talk about, superiorly lesser omentum is attached to inverted L-shaped manner. It is attached to in the inverted L-shaped manner to the margins of ligamentum venosum and porta hepatic. And porta hepatis region. Done. Now coming to the lesser omentum. Done. Now coming to the lesser omentum. Now coming to the lesser omentum. So now coming to the content of the lesser omentum. So the contents can be categorized. If I talk about the contents can be categorized along the lesser curvature of the stomach, along the lesser curvature of stomach, and it contains right and the left gastric vessels. It contains right and the left gastric vessels and associated lymph nodes Other than that, it also contains branches of left gastric nerve. And now the second content level is in the right free margin. The right free margin contains the right free margin. The right free margin of the lesser omentum contains portal vein, It contains hepatic artery. It contains lymphatics. It contains hepatic artery and duct also. It contains hepatic artery, bile duct. Other than that, it also contains lymphatics and autonomic nerves. Done? So all these are the contents. Now the next topic is mesentery. Dr. Sharma Punit, yes, you are right. Dr. Sharma Punit, you are absolutely right. And yes, you are absolutely right. Yes, most posteriorly, yes, that is posteriorly we will talk about inferior vena cava in relation to foramen of Winslow. Okay, foramen of Winslow. Now, this is a cadaveric image which I want everybody to understand. Here again, I just want to show you this image. So, exactly in this cadaveric image, again you can see what I have highlighted is the lesser curvature of the stomach and the initial part of duodenum. This is having upper attachment to the liver, and the lower attachment is that of the stomach and that of the duodenum. So you can see the underline highlighted area. You can see a different color has been given to it, the orange color, and it has been highlighted the lesser omentum, and this is a viscera. It is showing the viscera being connected, the liver, the duodenum, initial part, and the stomach by the lesser omentum, which is very important for you to note down. Done? Okay. Done, everyone? Okay. Now, mesentery. The next topic is mesentery. So, exactly, mesentery is a very important topic. Why I will tell you, because as in this image also you can see the intestinal loop, the mesentery. If I talk about the mesentery, let me just write it. So basically mesentery is connecting. Why mesentery is important? Because mesentery is containing intestinal loops and it is having a connection. So it is containing the intestinal loop as you can show in this diagram, and it is having many important structures residing inside. Okay. So mesentery. Now if I talk about the mesentery, you can see the intestinal loops holded by the mesentery. So in case of mesentery, if I talk about, mesentery is a broad fold of peritoneum. What is mesentery? It's a broad fold of peritoneum which is containing coils of jejunum and ileum, not the duodenum exactly, and it is having a free margin which is approximately 6 meters, and it is having an attached border of 20 centimeters approximately. So it is important for us to know that we should also know the contents and the structures crossed by the root of mesentery or the attached border. So mesentery. So write down mesentery. Mesentery is a broad fan shaped fold of peritoneum. It's a broad fan shaped fold of peritoneum which suspends the coils of small intestine, the coils of small intestine, which suspends the coils of small intestine that is jejunum and ileum. From the posterior abdominal wall, from the posterior abdominal wall. From the posterior abdominal wall. The width of mesentery is, and the width of mesentery is exactly, if I talk about the width of mesentery, it is if we talk about the attached border, it will be approximately 15 to 20 centimeters, and free border is 6 meters. Free border is 6 meters. Now, root of mesentery, if I talk about the root of mesentery and the structures it crosses from, so it's important to know the structures crossed by root of mesentery, which is already shown. But other than that, I would also like to tell that the roots of mesentery contents I want you to tell. So, please write down contents of mesentery. Contents of mesentery. Contents of mesentery. So, if I talk about the contents of mesentery, what it contains superior mesenteric artery, it contains superior mesenteric, it contains superior mesenteric artery and vein. It contains jejunal, and ileal branches of superior mesenteric artery and vein. It contains lymphatics. It contains lymph nodes. It contains autonomic nerve plexus. It contains fat and connective tissue. It contains fat and connective tissues. It contains fat and connective. It contains jejunum and ileum. So actually all these are the contents of mesentery, or actually all these are the contents of mesentery. So root of mesentery, actually for your examination, it's also important that you should know the list of structures being crossed by the root of mesentery. So that is very, very important for you to know the structures being crossed by the mesentery. So the structures being crossed by mesentery is following. It is crossing the horizontal part of duodenum. It is crossing the abdominal aorta. It crosses the inferior vena cava. It crosses the right gonadal vessel. It crosses the right ureter and the right psoas major. So all these structures which has been enlisted here are the structures being crossed by. Is the structure being crossed by the mesentery. So you should know the list of these structures being crossed by the mesentery. So done. Now here this is an image where you can appreciate how the mesentery looks. Now let's talk about the transverse mesocolon and sigmoid mesocolon. Okay, transverse mesocolon and sigmoid mesocolon. So if I talk about transverse mesocolon and sigmoid mesocolon, you have to know the attachment and what are the structures traversing. So let's talk about that. So if I talk about transverse colon, you can see it is containing, the transverse mesocolon is containing transverse colon, and this is the sigmoid mesocolon. So basically you have to understand this. So here also you can see transverse mesocolon and sigmoid mesocolon. Sigmoid mesocolon is triangular and transverse mesocolon is hanging from the transverse colon. So transverse mesocolon is a broad horizontal fold of peritoneum which is suspending the transverse colon from the posterior abdominal wall. So I just want you to understand that. And if you will see let me first explain it. You can see this is the sigmoid mesocolon, inverted V shape. Actually, the apex of the sigmoid mesocolon is attached at the bifurcation of the common artery, common iliac artery. If you will see, this is the common iliac artery. and it is having two limbs. So if you will see, this is the bifurcation of common iliac artery. So the left, so if we talk about the apex is the apex of sigmoid mesocolon is attached, the apex is attached to the bifurcation of common iliac artery. The left limb is attached to that of the external iliac vessel. Right limb is extending till the level of third sacral vertebra. Okay, third sacral vertebra. Now, so done with this. Now we will talk about both of it. So write down. Write on the heading transverse mesocolon. Transverse mesocolon. So if I talk about transverse mesocolon, it is a broad horizontal fold of, it is a broad horizontal fold of peritoneum, which suspends the transverse colon from the posterior abdominal wall. What it is containing? It is containing the transverse colon which is attached to the posterior abdominal wall. So which suspend the transverse colon from the posterior abdominal wall. Done? Done, everyone? Now, if I talk about sigmoid, so transverse mesocolon, and if I talk about the sigmoid, the next is sigmoid. So, sigmoid mesocolon, it is triangular. It's a triangular fold of peritoneum. It's a triangular fold of peritoneum which suspends the sigmoid colon from the pelvic wall. Now here attachment की बात करें, if I am talking about the attachment of sigmoid colon, so the apex is attached to the bifurcation of common iliac artery, bifurcation of common iliac arteries. And if I talk about the right limb, till the level of S3 lumbar vertebra, the left limb is towards the left external iliac vessel. The left limb, if I talk about, the left limb is the left external iliac artery. Okay, done with this. Now the next important structure which I want everybody to understand is the falciform ligament. Okay everyone, Dr. Sharma Punit, Aradhya, Rais, SR, Tarun, Sanjay Goel, everyone, are you understanding? So we have got next the falciform ligament. Actually is a sickle shaped fold of peritoneum which is again having an attachment to the liver, and it is connecting the anterosuperior aspect of the liver with that of the anterior abdominal wall. So this is exactly the falciform ligament. You can see this is the liver, and this liver is exactly attached with that of the anterior abdominal wall by the attachment of falciform ligament. So it's a sickle shaped fold of peritoneum which is exactly connecting the anterosuperior aspect of the liver with the supraumbilical part of the anterior abdominal wall, and we have to know the contents. So write down. Here also you can see this diagram. This is actually falciform ligament, and you can see it is connecting the liver superior and anterior part with that of with the anterior abdominal wall above the level of umbilicus. The lower inferior part of falciform ligament contains ligamentum teres, which contain left umbilical vein, which contain the remnant of left umbilical vein. So write down about falciform ligament. So content, you can just write down falciform ligament. Is a sickle, falciform ligament is a sickle shaped fold of peritoneum, sickle shaped fold of peritoneum which connects the antero-superior part of the liver, the antero-superior surface of liver with supra-umbilical part of with antero-superior surface of the liver with supra-umbilical part of anterior abdominal wall. Anterior abdominal wall. Done? Done everyone? Now let's talk about the content. Let's talk about the content. So the content of falciform ligament are ligamentum teres, para-umbilical vein, which is a tributary, which is actually tributaries of portal vein, which is actually the tributary of portal vein. Numerous small veins, and also we have got numerous small veins are there which connect para-umbilical vein with diaphragmatic vein, with the diaphragmatic vein. Okay. So exactly here again in the diagram we can see the greater sac is communicating with the lesser sac via epiploic foramen, which is called as Foramen of Winslow. So this is showing so exactly this diagram is showing you the vertical tracing. This is showing the vertical tracing of the peritoneal cavity, peritoneum. It is showing the vertical tracing of the peritoneum. And here you can see in the peritoneum vertical tracing the greater sac, GC greater sac, and this is the lesser sac, and the communication is via epiploic foramen. So basically what we can see the entire, so exactly we know that the peritoneum is having two layers. We know that peritoneum is having two layers. One is the parietal and the other is the visceral layer. So the visceral layer is on the abdominal viscera and the parietal layer in the inner aspect of the abdominal and pelvic cavity. So major area of the space lying between visceral and that of the parietal layer of peritoneum is the greater sac, and the space which is lying behind the stomach is the lesser sac, and the communication of greater and lesser sac happens via epiploic foramen. Now we have got transverse section here, so also we can appreciate the transverse section of abdomen. So two transverse section I have shown you. One is the transverse section of the abdomen which is done at the level of epiploic foramen. This is the posterior aspect because we can see the great vessels and kidneys posteriorly. This is the anterior aspect where we have got the liver. So here we can see the space that is the lesser sac and the free margin of the lesser omentum, which is containing the three structures. The free margin contains the portal vein posteriorly, the bile duct anteriorly and to the right side, hepatic artery anteriorly and to the left side. We have got the gastrosplenic ligament connecting the stomach and the spleen, lino-renal ligament connecting the spleen and the left kidney. and the greater sac has been shown. The another image of transverse section, the another transverse section of abdomen done at the level of L4 has been shown to you, and we are talking about L4 level. Again, we can see the great vessels, inferior vena cava, abdominal aorta, colons, and all ascending, descending. They are all retroperitoneal structure. So they have got the peritoneum and one aspect, only one covering also. Other structures is the also we can see the folds. We can see the median umbilical fold, medial, and we can see the lateral umbilical fold containing following structure: median one urachus, medial umbilical artery, inferior epigastric vessel over lateral umbilical fold, and we can also see the mesentery here, which is connecting the small intestinal loop. Now, again, as I told you, foramen of Winslow is epiploic foramen, which is forming the connection between the greater and the lesser sac. What is so important for you? You should know the boundaries of foramen of Winslow. So here again, the lesser sac has been shown and the duodenum has been shown, and here we can see here is the foramen of Winslow, which is forming a communication between the greater and the lesser sac. And I just want everybody to go through this image. Why? Because this is showing you the important boundaries of the foramen of Winslow. So very important that you should know the boundaries of foramen of Winslow, which is also called as epiploic foramen. So superiorly it is bounded by caudate lobe of the liver. Caudate lobe of the liver is forming the superior boundary. Inferiorly is the duodenum, and posteriorly is the inferior vena cava. Actually, yes, I would like to tell basically Dr. Shraddha Punit has already told this also, that inferiorly, posteriorly we have got inferior vena cava, anteriorly in the free margin we have got hepatic artery, bile duct and portal vein. Now there is one more space which needs an explanation, that is the hepatorenal pouch of Morrison. So hepatorenal pouch of Morrison is important. Why? Because actually it is a it is a space which is lying between the inferior surface of the liver and the right kidney. Why it is important? The importance of hepatorenal pouch of Morrison's is, this is the space which is exactly lying between inferior aspect of the liver and that of the right kidney. Actually, this is the most dependent part of abdominal cavity when the person lies in supine. So the infective blood, pus and all fluid can collect in this space. So write down the heading: hepatorenal pouch of Morrison's. So exactly, if you want boundaries, you can write on the boundaries also. So anteriorly it is bounded by inferior surface of liver. Anteriorly it is bounded by inferior surface of liver. Posteriorly it is bounded by peritoneum covering the front of upper pole of right kidney and the diaphragm. Above we have got the posterior layer of coronary ligament, posterior layer of coronary ligament, and below we have got the transverse colon and mesocolon, transverse colon and mesocolon. Okay, these are the boundaries of hepatorenal pouch of Morrison's. These are the boundaries of hepatorenal pouch of Morrison. So the same thing, you can see this space is the hepatorenal pouch of Morrison's, having the liver. As you can see it is anteriorly the liver is lying there, posterior inferior surface of the liver. Posteriorly we have got the kidney, we have got the right kidney and the diaphragm also. and above coronary ligament, below will be the transverse colon. You can see this is the hepatorenal pouch of Morison's, and when the person is lying in the supine position, clinical importance is it's the most dependent part of the abdominal cavity when the person is lying in the supine position. So above the level of pelvic brim, it is the most dependent part of the abdominal cavity. So the another space is rectouterine pouch of Douglas. Rectouterine pouch of Douglas is the space which is lying anterior to the rectum and posterior aspect of the uterus. It is an extension. It's the most dependent part of the pelvic cavity, and below the level of pelvic brim, it's the most dependent part of the pelvic cavity. And you can see here the rectouterine pouch of Douglas, and most of the important in any case of infections or fluid accumulation, for example ruptured ovarian cyst, or in case of any kind of infections of uterine tube rupture, fallopian tube rupture and all, the fluid will collect in the rectouterine pouch of Douglas. So done with this. So we have finished with the topic of peritoneum. Now the next topic which I am going to start is the liver. Is it okay everyone? So actually what happens when I will go systematically, for example, if I go systematically in the liver, I go into the next topic, I will solve few MCQs right there when the session is going on. Okay. So whenever I take a session, so exactly now, so those who are till now have you understood the difficult part we have done. Now small visceras are there, and we have to know about important aspect of this viscera, and after completing that small topic like liver, when I cover liver, I will have 3-4 MCQs. I will cover stomach, I will have 3-4 MCQs. So small all the visceras we will complete, and then we will go into the pelvic cavity. Is it okay? So I will just give you a, anyone is having any doubt, please let me know. Have you understood? Okay. Okay, great. So just 5 minutes of break we can take, 5 minutes of break, and then we can start. You can take you can just take 5 minutes break. You can take your coffee and tea, and you can start studying with the visceras. Is it okay everyone? Okay. Hello everyone, so we are back here. Okay, am I audible? So let's start with the session now. So I actually whenever like we have got a, I want to complete like entire abdomen and pelvis in one go. So means overall 2 topics has to be completed in one go. So we will have a break, but I think we will take a break of just 5 minutes only, not more than that. That will be okay, so that we can finish it at time. Okay. So the next topic is the liver. So exactly, if I'm talking about the liver, the important aspect to be asked in the examination is the liver location, the hepatic segments and the relation. So that is very important. Okay, Vinay, Vinke, okay. So let's start. So this is exactly showing the liver in the, and we can clearly see the liver is a large organ, as you can see, and it is having its location. If I talk about the liver is located in the right hypochondriac region of the stomach. So exactly it is located in not only in the right hypochondriac, also in the part of left hypochondriac and epigastric region. So the inferior border of the liver is at the level of transpyloric plane. Okay. And when you see the liver, what you can appreciate in the liver, we have got diaphragmatic surface and we have got the visceral surface. So in case of liver, we have got overall the most part of the liver is covered with is the diaphragmatic surface. It's anterior, it's right lateral part, and it's superior part. Only the inferior surface relation will be in the visceral relation of the liver. So that is important for you to know the parts and its liver, surface of the liver and its relation. So I just want firstly that you should know about the location of the liver. So please write down the location of the liver. Liver is located. So the liver is located in the right hypochondriac region. Liver is located in the right hypochondriac. Let me write there. Here the space is less. Right hypochondrium in the upper part of the epigastrium region and a part of left hypochondriac region. Left hypochondrium region. Done. Now, so it's about the external features which we are talking. So if I talk about the external features, so diaphragmatic and visceral surface. So basically we have to know about the relation of the structures as the diaphragmatic and that of visceral surface. So diaphragmatic and visceral surface is meeting at the inferior border. So we have got a diaphragmatic surface and we have got a visceral surface. So again, if I talk about the diaphragmatic surface, it is again having following surfaces. So visceral surface is the inferior surface. Diaphragmatic surface is the superior surface. It's the anterior surface, it's the right lateral surface, and it's the posterior surface. So one by one you have to know the relation of this individual surfaces. Okay. So right. So done with this. So write down relation. So write down superior surface. So the first surface is superior surface. So when we are talking about the superior surface, superiorly if we talk about the superior aspect, so we know that the thoracic and the abdominal cavity in between we have got a diaphragm. So superiorly the liver will be having diaphragm. So it will be having diaphragm. Superiorly it will be having diaphragm intervening, and it will be related to the corresponding parts of, it will be related to the corresponding lung and pleura on either side. Lung and pleura on either side. either side with pericardium and heart, with the pericardium and heart in the center. So it will have the pericardium and heart in the center. This is the superior surface. Then we will have the second is anterior surface. So if we talk about anterior surface, it is related to xiphoid process of the sternum and anterior abdominal wall and anterior abdominal wall. If I talk about a right lateral surface, the right lateral surface is having lung and pleura in upper one third, lung and pleura in upper one third part. We will have costodiaphragmatic recesses in middle one third part, and we will have 10th and 11th rib relation in the lower one third part, Done. So we have done with the right lateral, anterior and superior surface. What remaining is the, if I talk about the relations which is remaining, is the posterior surface relation and the inferior surface relation is remaining. So write down posterior. The fourth is the posterior surface. So if I talk about the posterior surface relations, okay. So here posterior surface relation will be it is related with the abdominal part of esophagus. It is related with the abdominal part of esophagus and with the right suprarenal gland. And inferior vena cava. And coming to the next one, that is the visceral surface, which is the inferior surface. So visceral surface. So when I am using the word visceral surface, it means it is related with number of viscerals, visceral surface or inferior surface. So if I talk about the visceral or the inferior surface, it is related with number of viscerals, and they are, so many viscerals are related in the visceral or inferior surface. It's related with the stomach, it is related with the duodenum. So it is related with the stomach, it is related with the duodenum, it is related with the right colic flexor, it is related with right kidney, gallbladder, okay. So these are few of the viscerals which are related on the visceral surface. So I just want you to show this. So actually in this image, what you are seeing is the liver inferior surface. What you are seeing in this image is the inferior aspect of the liver. And you can see in the inferior aspect of the liver, we have got many important structures related. We have got the gastric impression shown here. We have got the tuber omental, we have got the gallbladder, we have got the colic impression, duodenum and the renal impression. So these are the important viscera related in the inferior aspect or inferior surface of the liver. Now the next important thing is to know the lobes of the liver. So we should understand how the lobes of the liver is divided. So that is important for us to know the different lobes, how it is divided. We have to know about the anatomical lobe and we have to know about the physiological lobe. So importantly, I would like firstly to tell you about the anatomical lobe. Actually, anatomical lobes are not equal division. Anatomical lobe is divided on the basis of the attachment of falciform ligament. So exactly we have got falciform ligament here, this structure which you are seeing. This is the falciform ligament. No. So basically this is the falciform ligament which you are seeing. This is a falciform to diverge in, as you can see here. So this is exactly the falciform ligament which will anterosuperiorly we can see, and by the attachment of falciform ligament on the diaphragmatic surface. So this the attachment of falciform ligament on the diaphragmatic surface. So this is F falciform ligament on the diaphragmatic surface and the visceral surface. It is again divided into 4 lobes: right, left, caudate and quadrate lobe. So actually in the visceral surface, the fissure for ligamentum teres, this is the ligamentum teres. So fissure for ligamentum teres and that of ligamentum venosum. So we have got ligamentum venosum. These are taken into consideration and the whole unequal right and left lobe is formed, and further we have got the right, left, caudate and quadrate lobe division. So, so that is an important basis of anatomical division. So you can just write down the points. Lobes of liver. So if I talk about lobes of the liver, on diaphragmatic surface, so on diaphragmatic surface, it is divided into right and left lobe by right and left lobes by falciform ligament, by the attachment of falciform ligament. This is first point. The other point is on visceral surface, it is divided okay, for visceral surface it is divided into right, left, caudate and quadrate lobe, by attachment of fissure, by the attachment of fissure for ligamentum teres, by the attachment of fissure, by the attachment of fissure for ligamentum teres and venosum. So done. This is how the anatomical lobes are formed. So we can see how the anatomical lobes are formed. So basically we are more concerned about the physiological lobe because we have to know about the hepatic segments. So this image is showing you the anatomical lobes. So this image is showing you the anatomical lobes. This is showing you the anatomical lobe. So we are concerned about the physiological lobe. Let's talk about the physiological lobe. The next image is the physiological lobe. So functional classification of the liver is called as the physiological lobe, which you have to know. And for actually physiological lobe is based on the basis of equal distribution of the intrahepatic distribution of the bile duct, the hepatic artery and portal vein. So the liver is divided into right and left physiological lobe by an imaginary sagittal plane that is called as Cantelin's plane. On the posterior inferior surface of this plane passes through is the fossa of gallbladder and the fossa of inferior vena cava. So this is fossa of this is a line which is passing through fossa of inferior vena cava, and this is the line which is passing through fossa of gallbladder. So this is again the line which is called bladder. So exactly this is how the physiological lobes are formed. Then we will talk about the hepatic segments. So you can just write down physiological lobes. Okay, just write down physiological lobes or true lobes division is based on intrahepatic distribution of intrahepatic branches of bile ducts, hepatic artery, and portal vein. The liver is divided into right and left physiological lobe by an imaginary plane, by taking a consideration of imaginary plane, and this plane is called as Cantillon's plane or line through fossa of gallbladder and to groove of inferior vena cava, So fossa of gallbladder to the groove of inferior vena cava. I would also like to tell you about hepatic segments, which is very important for you to understand. So if I am talking about, so actually hepatic segmentation is important. So actually there was a French anatomist and a great surgeon, that is Coinard. According to the Coinard, the physiological lobe of the liver is further divided into total of 8 sub-segments based on a imaginary transverse plane passing through the bifurcation of the main portal vein, bifurcation, and this is named after Claude Coinard. So this is total of 8 hepatic segments are formed. So basically you can see the portal vein is taken into consideration, and then the measure consideration is equal distribution of hepatic artery bile duct, and bifurcation of portal vein is a key point of forming 8 segments, physiological segments. Now how these 8 segments are formed? So as we know that there is a, so I just want to explain it also. As we know, there is right and there is a left physiological lobe. So further what happens, now the next step is that we are already knowing that there is right and the left physiological step. So here next what happens, the right lobe will be divided into anterior and posterior, and the left lobe will be divided into medial and lateral. And each of this is further divided into upper and lower part, which is forming surgically resectable, which leads to form of 8 hepatic segments. So accordingly 8 hepatic segments. So accordingly what happens? So this 1 to 4 hepatic segment is in the left hemiliver, and this 5 to 8 hepatic segments are in the right hemiliver. Actually, I just want to give one important point here. Actually, when one important point is why it is important, I will tell you. The reason is that if so we are talking hepatic segments, why it is important, I will tell you. We have got the odd man out here is the caudate lobe. I will tell you why, because caudate lobe is a separate special lobe, hepatic segment. Why? Because it is having receiving it is drained by right and the left hepatic duct also, and by both right and the left hepatic artery, and by the both portal vein. So that is now it's also important for you to know the bare areas of the liver. So the bare, what do you mean by the bare area of the liver? That is not having an covering of peritoneum. So exactly, it's a triangle. The main one of the important area is the triangular area, which is the bare area of the liver, which is lying on the posterior surface of the right lobe of the liver, the fossa of gallbladder, the groove of inferior vena cava, the groove of ligamentum venosum, and the porta hepatic region. All these regions are the bare area of the liver, not having peritoneum covering over it. So please write down there the bare areas, the bare areas of the liver. So the bare area of the liver are following. We have got triangular area. We have got triangular area on posterior surface of, we have triangular area on posterior surface of right lobe of liver. We have got fossa of gallbladder. We have got groove of ligamentum venosum. We have got groove of inferior vena cava. We have got also the porta hepatic region, porta hepatis region. All these areas are the bare area of the liver. Okay. Now, line of peritoneal reflection is important. When I am using the word line of peritoneal reflection, actually the peritoneum coverings are there in the liver. So, exactly if I talk about the liver, we have got false ligament and we have got a true ligament. When I am using the word false ligament, actually they are peritoneal fold, and if I am talking about true ligament, they are remnants of the fetal structures. So, basically we have got a falciform ligament which when reaches, so exactly when it reaches on the liver, it divides into left and right triangular ligament, coronary ligament. So this is the bare area. This is anterior, superior or inferior coronary ligament. And this is ligamentum peris. So all these green color lines are the peritoneal reflections on the liver, and you have to know the name of true and a false ligament. So let's write it. So write down ligaments of the liver. So we have got false ligament, that is peritoneal folds. So sorry, false ligament. False ligaments in peritoneal folds. So we have got following false ligaments. Please write down the name. The names are falciform ligament. We have got coronary ligaments, which can be the inferior superior coronary ligament. In between, we have got the bare area of the liver, which is also called as anterior posterior coronary ligaments. We have got right and the left triangular ligament. We have got the lesser omentum. Now, talking about the ligaments of the liver, the next is to know about the true ligaments. So, if I talk about true ligaments, the true ligaments are, we have got the true ligaments as ligamentum teres hepatis, we have got ligamentum venosum. So, it's importantly asked in the examination also that ligamentum venosum contains the remnants of its structure, ligamentum teres contains the remnant of its structure. These are the things which will be asked in the examination. So, it's highly important for you to note down. So, please write on. We have got ligamentum teres hepatis. We have got ligamentum teres hepatis, which is remnant of obliterated left umbilical vein. Then we have got ligamentum venosum, which is remnant of ductus venosus. And it's also important for you to know that what is the ductus venosus remnant. So, ductus venosus is the remnant of, so exactly in case of ductus venosus, what all structures is connects in the case of fetal life. So, in fetal life, it is connecting In fetal life, it connects left branch of portal vein. It connects left branch of portal vein to inferior vena cava with that of inferior vena cava. This is important point about ligamentum venosum. So we have done with ligamentum teres hepatis, we have done with ligamentum venosum. Now in brief, I would like to tell, actually the question being asked from this topic is very important, that is extrahepatic biliary apparatus. It's very, very important that you should know extrahepatic biliary apparatus. So you should know the parts of extrahepatic biliary apparatus. So the parts will be the gallbladder, the common bile duct, hepatic duct, cystic duct, the common pancreatico bile duct. Actually, these are the parts, and what is very, very important for you to note down is the difference between that of cystohepatic triangle and that of Callott's triangle. I would also like to solve an MCQs along with you after this. So after this, we will have an MCQ related to this topic. So basically, I am concentrating to the, if it's an FMG examination, I will concentrate to the most important topic. So let's solve the important difference. So actually, I just want you to show this triangular space. This triangular space is termed as cystohepatic triangle. So this triangular space which I am highlighting is the cystohepatic triangle. So this is cystohepatic triangle, and if I take the consideration of, this is the cystic artery. So if I take the consideration of this triangular unit, so this is the lymph, so this is the Callott's triangle. So let me just, so basically we have got two triangular space. So if I take only the consideration of this triangular space, so I am just using green color. So this will be the Callott's triangle. So here you can just understand this will be cystohepatic triangle, and this green triangular area inside, this will be the Callott's triangle. So basically there is a difference. So this is cystic lymph node. So basically there is so that means if I have to define, and this is the artery which you are seeing. Okay, so basically what we can say, if we are talking about the boundaries of cystohepatic triangle, its boundary is, it is bounded, as you can see, it is bounded by common hepatic duct. So you can see it is bounded by common hepatic duct on the left side, by the cystic duct on the right side, and so superiorly by the inferior surface of the liver. So this overall is the boundary of cystohepatic triangle. But when I am talking only about the Callott's triangle, its boundary will be 3C. It is bounded by cystic artery, it will be bounded by common hepatic artery, and it is bounded by cystic duct. And the structures residing inside will be the lymph node, cystic lymph node. So if I am talking about the contents of cystohepatic triangle, it will be the cystic artery, the right hepatic artery, and cystic lymph node. But if I am talking about Callott's triangle, it contains only cystic lymph node. So the boundaries of, so write down. So boundaries and the content of cystohepatic triangle is already shown in this image. Write down boundaries of Callott's triangle. Boundaries of Callott's triangle. So there is a difference between the boundaries of cystohepatic triangle and Callott's triangle. So the boundaries of Callott's triangle can be memorized by 3C. What is the mnemonic? 3C. So C, C, C. So it is bounded by cystic artery superiorly. It is bounded by cystic, common hepatic duct and cystic duct. So it is bounded by common hepatic duct on left side, common cystic duct on right side, and content will be cystic lymph node. So this is boundaries and content of Callott's triangle, and this is boundary and contents of cystohepatic triangle. So exactly Callott's triangle, so we have written. If you want, you can write down boundaries of cystohepatic triangle. So boundaries will be here. What happens superiorly? Cystohepatic triangle boundary is by inferior surface of the liver, inferior aspect. Right side is the cystic duct and left side is the common hepatic duct. Also, the content is already shown in the image, so I am not writing once again. Content is already shown in the image, so I am not writing it once again. So, few of the MCQs we can have discussion. Bile duct in relation, so if I talk about bile duct runs in the relation of which part of the duodenum. So, actually duodenum I have not done. So, basically after completing duodenum we can solve it. So, you can tell me the gallstone. So, this is from the common sense only. You can tell me the gallstone pain can be radiated to all this area except. So, what I have duodenum we have not done. So, I have waited for this. Bile duct runs in relation to which part of the duodenum. I have waited for it. But you can solve the second one. Anyone? Pain of gallstone will be referred to all the areas except. Pain of gallstone will be referred to all these areas except. Pain of gallbladder stone is referred to all these areas except. So, please mark the right answer. Pain of gallstone will be referred to all these areas except. Anyone? This is slightly to the surgical question also. Okay. Pain of gallstone is referred to all this area except. Anyone? No one is giving the answer. What happened? So, gallstone pain is referred to the shoulder region. You already know. So, it is to the right left shoulder, can be whether epigastric region. So, just a common say. Actually, the right answer is the inferior angle of the scapula. It's not referred to inferior angle of the scapula. Okay. So, I just want, actually I have skipped with this, but here also bile duct opens in relation of which part of duodenum. With common sense you can give me the answer, but duodenum session I have to taken also. I have to take just after a few topics. So, just tell me bile duct will open into which, bile duct is lying in relation to which part of the duodenum. So, we will have a session on duodenum and you will be able to understand, but any guesses you want to give me? Bile duct lies in relation to which part of duodenum? Okay. Okay, we will come to this after duodenum only. So, cystic artery is a branch of which artery? Any guesses? Cystic artery is a branch of which artery? I will show you this image. Now, tell me, cystic artery is a branch of which artery? Once more, see this image and tell me. This is cystic artery and it is branching from which artery? This is one artery, this is other artery. So, you can tell me, it is branching from this artery. It is branching from this artery. So, which artery is this? Cystic artery will be a branch of which artery? Now, you can tell me the answer. Cystic artery is a branch from which artery? Cystic artery is a branch of, this is easy one. Cystic artery is a branch of which artery? Tarun has given the answer. What about others? Tarun, a thumbs up goes for you, and Tarun has given exactly the right answer. Yes, Tarun, you have given exactly the right answer, dear. Yes, Tarun, it's the right hepatic artery. Absolutely correct. Cystic duct joins which duct? Cystic duct joins which duct? So you can see again in this diagram that cystic duct is joining with which duct. If you want, you can see this. So see here, cystic duct is joining with which duct? Cystic duct is joining with which duct? You can see this image and can give me the right answer. Cystic duct joins with which duct? And now you can give me the answer. Cystic duct joins with which duct? Tarun has again given the answer. What about others? What about the others? Tarun has given absolutely right answer. It's the common hepatic duct. Absolutely right. It's the common hepatic duct. So actually this is I have to tell you about the measurement. If I talk about the general range of gallbladder, I will tell you the answer. Definitely I will tell you the answer. Any guesses you want to tell me? The average capacity of gallbladder, bile content, capacity of gallbladder. Okay, what about others? Everyone is telling 50 to 150 ml. 50 to 150 ml. The right answer will be 30 to 60 ml. 30 to 60 ml. The capacity of gallbladder is a range of 30 to 60 ml. Okay, 30 to 60 ml. So done. Now the thing is, so exactly we have done with this. Now the next topic is duodenum. So after solving duodenum, that one question we will solve. That one question which we left will be solved once again. Now the next topic is duodenum. So duodenum is a C-shaped loop of a small intestine. As you can see, this is the overall outline of the duodenum. So if you will see, this is the overall outline of the duodenum which you are seeing. Okay, this is the overall outline of the duodenum which you are seeing. Okay, this is the overall outline of duodenum which you are seeing. Okay, so this is actually C-shaped loop. Okay, so duodenum is a C-shaped loop of intestine. It's a C-shaped loop of small intestine, means SI, and exactly it is located in respect to L1, L2 and L3 lumbar vertebra. It encloses the head of pancreas. What does it enclose? It encloses the head of pancreas. Then we will duodenum encloses the head of pancreas. The important point is before coming, so we will come to the relation of individual part of duodenum. But other than that, we have to know about the relation of individual part of duodenum. But before starting the relation of individual part of duodenum, I just want you to tell about the first part of duodenum. First part of duodenum is actually is having few important features because it is different from others. Actually, duodenum is a part of abdominal structures. Actually, this is having origin from both the part of foregut and midgut. So, initial or the proximal part of duodenum is embryologically the part of foregut, and the rest part of duodenum is embryologically the derivatives of midgut loop. So, the upper proximal part of duodenum will receive blood supply from the branch of celiac trunk, but that of the other parts of duodenum will reach the blood supply from the branches of superior mesenteric artery, which is the artery of midgut. The initial part of duodenum is the only intraperitoneal structure. Rest all the parts of duodenum is retroperitoneal structure. So, it develops from foregut. It is only intraperitoneal. It is the only intraperitoneal part. It is the freely movable, distensible, on barium meal. It is having the initial part is in the form of duodenal cap with because it is having no circular folds. It is a site of duodenal ulcer. It's a site of duodenal ulcer, and actually it is the part which is receiving blood supply from, it receives from the branch of CT means celiac trunk. It receives blood supply from the branch of celiac trunk. CT means celiac trunk. Okay. Now let's talk about the relation of the first part of duodenum. So if I am talking about the relations of the first part of duodenum, you have to understand the relations of all the parts. You have to know about the relations of first part, you have to know about the relations of second part. So that is very, very important for you to note down. So that is highly important, and it's very important that you should know the parts and its developing component. Okay. Okay. So that is highly important here. Okay. Now relations of the individual part of duodenum. So firstly, I would like with the, actually in this image you are quite clear also that we have got, if we are talking about duodenum, it is divided into 4 parts. So exactly each components and the parts, it's very important that you will be knowing about. Okay. So it's also important that you should be knowing about the relation of individual components on the parts of duodenum. And we know that initial part of duodenum is the proximal part. As you can see, this is approximately 5 centimeters. This is the second part, descending part. This is the third horizontal part, and fourth part is the ascending part. So let's talk about the first part. So exactly, let's talk about the first. So this is a schematic diagram which is helping you to understand the relation of the first part. So this is exactly the first part of duodenum, and we have to target about the relations of the first part of duodenum. So if I am talking about the relations of the first part of duodenum, it is related with the following structures: the quadrate lobe of the liver, gallbladder, and also the first part of duodenum has the relation with the gastroduodenal artery. So basically gastroduodenal artery will be related more posteriorly. So these two structures are anterior relation, and this will be in the posterior relation. So there is another image where you can see the posterior relations of the first part of duodenum. So first part of duodenum is posteriorly related to bile duct, gastroduodenal artery, and portal vein. So here we are talking about the relations of individual part of duodenum. First part anterior relation is quadrate lobe and gallbladder, posteriorly bile duct, gastroduodenal artery, and portal vein. Now can you tell me the answer of this question? Bile duct is lying in relation with the which part of duodenum? Now can you tell me the answer of this question? Bile duct runs in relation with which part of the duodenum? Okay. Bile duct runs in relation with which part of duodenum? First part is absolutely right. Yes, Tarun is absolutely right here. Now Tarun has given absolutely right answer. Yes, Tarun. Now coming to the next part. So now coming to the second part. So if I am talking of the second part of duodenum, we have got following important structures related with the second part of duodenum. Anteriorly, if you will see, it is related with the gallbladder. It is related with the right lobe of the liver, also with the transverse colon and mesocolon. So you can see this is the transverse colon and this part is the mesocolon. This part is the mesocolon. This part is the mesocolon and also with the coils of small intestine. Posteriorly, it is related with right kidney, right renal vessel, right edge of inferior vena cava and right psoas major muscle. So, in the image, all the relation is already shown to you. So, if you will see the relation, so if I talk about, if we talk about this important aspect, it's very important that it's important that you have to know about the relation. So, it's very important that you have to know about the relation on the anterior aspect and the posterior aspect. So, going through this images, it is quite clear to you, and important is that you should know about the important aspects of individual when I talk about the initial part of the proximal part, the 5-6 features which was very important, that it is intraperitoneal, developing from foregut, receiving blood supply from celiac trunk, and it is represented as duodenal cap. Relations of the third part. What is third part? Third part is the horizontal part of duodenum and it is related anteriorly to superior mesenteric vessel, root of mesentery and coils of jejunum. If we see posterior aspect, so many structures are related to the posterior aspect. The right side psoas major muscle, the right ureter, right side gonadal vessel, abdominal aorta, inferior mesenteric artery. So, all these important structures are forming the posterior relation for the third part of duodenum. When we are talking about the fourth part of duodenum, anteriorly it is related to just two structures, the transverse colon and the mesocolon as shown in this image, anterior relation. And if I talk about its posterior, this is about anterior relation, and if I talk about its posterior relation, posteriorly it is related to, so now as I told you, fourth part of duodenum will traverse horizontally and ultimately become an ascending part, and in that context it will go to the left hand side. So that means it will be related to left side structure, left sympathetic chain, inferior mesenteric vein, left gonadal vessels and left psoas major muscle. So all these structures will form the relation for the left hand side structures and the posterior relation of fourth part of duodenum. Now, arterial supply of duodenum is a very important part, and also important is the structures opening inside the duodenum. So if I talk about arterial supply, it receives blood supply from the branches of celiac trunk, from the branches of celiac trunk, that is proximal part, and from the branches of superior mesenteric artery, that is the rest part of duodenum. So you can see in this image multiple sources are there. As you can see in this image, multiple sources are there. You can see the branches from celiac trunk, that is the branches by gastroduodenal artery, which is giving superior pancreatico-duodenal artery, which is again giving anterior posterior branches. Branches from the superior mesenteric artery is inferior pancreatico-duodenal artery. We have got supraduodenal artery of Wilkes. So many arteries are there which is giving blood supply to the duodenum. Now, I will also talk about interior of the duodenum. So, when you cut open the duodenum, you can see in the interior of duodenum, we have got many important structures. So, in the second part of duodenum, there is an opening of main pancreatic duct. The accessory pancreatic duct is called as duct of Santroni. What is the other name? It is called as duct of Santroni. So, it's called as duct of Santroni. The accessory pancreatic duct is called as duct of Santroni, and you can see it is opening in the form of minor duodenal papilla. The major pancreatic duodenal papilla is the opening of main pancreatic duct, and main pancreatic duct is opening into the interior of the second part of duodenum, and above it 1 to 2 centimeter above it, you can say other words 8 to 10 centimeter distal to pylorus, we have got the opening of major duodenal papilla. So a major duodenal papilla is opening 8 to 10 centimeter distal to pylorus, and 1 to 2 centimeter above it we have got the minor duodenal papilla opening. So here you can see the sphincter polydocus is arranged along common bile duct. We have got sphincter pancreaticus around main pancreatic duct. Together they form ampulla of water, that is hepatopancreatic duct, which is surrounded by sphincter of OD, and it is opening into the second part of duodenum along with the major duodenal papillae. So that means if I talk about interior of duodenum, that means if we are talking about interior of duodenum, we have got major duodenal papillae, situated situated 8 to 10 centimeters distal to pylorus, and this is the opening of this is showing the opening of common. What is so major duodenal papilla is showing the opening of common hepatopancreatic duct. And if I talk about common hepatopancreatic duct, it is formed by the joining of common bile duct and pancreatic duct. The second is the opening of minor duodenal papillae, and minor duodenal papillae, it is a small conical, it's a small conical projection situated 2 centimeter proximal to major duodenal papillae. And which structure opens into its accessory pancreatic duct, which is also called as duct of Santroni, and okay, and main is called as Wrisprung duct. So done with this. Now I just want you to also know about arterial supply of the duodenum. So write down arterial supply. Arterial supply is important. We have got a multiple source of arteries, and we have got ligament. So then we will talk about ligaments also. So write down heading arterial supply of duodenum. So arterial supply of duodenum is important. The important arteries are so many arteries are there, and important arteries are, so basically as I told you, upper half is from the branches of celiac trunk and lower half is from the branches of superior. Major arteries are superior pancreatico duodenal artery, then we have got inferior pancreatico duodenal arteries. So here ma'am, please make videos on histology and reproductive organ. So actually yes dear, histology part I have kept as the last session. Okay, last May maine histology, I have kept a session on histology, don't worry about that. Yes, Tarun, you are right. It's a branch of gastroduodenal artery. Yes, Tarun, you are right. And I will also incorporate reproductive organs. Okay, don't worry. I will also incorporate reproductive organs after completing this FMG session. Okay. The superior pancreatico-duodenal artery is a branch of gastroduodenal artery. It's a branch of gastroduodenal artery, and we know that gastroduodenal artery is a branch of celiac trunk. It's actually, if I talk about gastroduodenal artery, it's a branch from hepatic artery and then celiac trunk. So if you want to write more details, you can write it. Gastroduodenal artery is a branch of hepatic artery, which is a branch of celiac trunk. Inferior pancreatico-duodenal artery is a branch of superior mesenteric artery. Then the other sources are like supraduodenal artery. Then branches from hepatic artery, We have got branches from right gastroepiploic artery. Actually, many sources are there, and also we have got branch from first jejunal artery. And we know that first jejunal artery is a branch from superior mesenteric artery. These are all the source of celiac trunk only. Supraduodenal artery has got a multiple source. If I talk about supraduodenal artery of Wilkie, it is a multiple source. Either it can be a branch from common hepatic artery, it can be a branch from gastroduodenal artery. Sometimes it is also a branch from superior pancreatico-duodenal artery. So basically you can say multiple sources are there for the branch of supraduodenal artery. Okay, dear? Joy is telling full histology. Okay. Okay, dear, we'll take histology part. Actually, it is one of my favorite session also. Don't worry, we will take. So done with this now. Actually, I am giving you as much as I can. I am giving you a detailed description only. So the question is definitely coming from these topics and many. So please don't skip any of the topic. All these topics are important. Generally, in the back of mind, earlier days the FMG students thought ki, we will study less, then it will be okay. But now the level is equal to NEET PG now. So you have a multiple sources. So don't worry about that. But the good point is that you have to score 50% only. So it will be done. Don't worry about that. So basically you have to go through all the topics because questions are repeated from multiple topics nowadays. Now I also want everybody to know about interior we have done. I just want that you should have an idea of suspensory ligament of Trich. When I am talking about suspensory ligament of Trich, why it is important, this is also called as, it's actually a fibromuscular band. You can see it is attaching the DJ junction. DJ means, don't think about the musical DJ junction. It is duodenum and jejunum junction with that of right crux of the liver. So it's a fibromuscular band which suspends the DJ flexor, means duodenum and jejunum, which suspends the DJ flexor from right crux of diaphragm. Its upper end is attached to the right crux of the, it's the upper end. It's the upper end is attached to right crux of the diaphragm and lower end is attached to DJ junction. Also, I would like to tell that the upper part of suspensory ligament of Trich is having only skeletal muscle. Middle fibers is made of elastic fiber. Middle part of the suspensory ligament of Trich is made of elastic fibers and the lower part is made of smooth muscle fibers, non-striated muscle fibers. I just want that you should have a look on the duodenal recesses. And why this duodenal recesses is important for you? Actually, these important duodenal recesses are inferior duodenal recesses, paraduodenal recesses, retroduodenal recesses, mesenterico-parietal duodenal recesses, and superior duodenal recesses. So these are important recesses. But Clinically or the important for MCQ, if I talk about important duodenal recesses in terms of MCQ, is that which is having an important structures there. So that is highly important for you. That is going more. Okay, so that is highly important that you should be knowing about these recesses. So if I talk about important recesses, so we have got like for example, we have got superior duodenal recesses is present in 50% of the cases. We have got retroduodenal recesses present occasionally. We have got paraduodenal recesses present in 20% of cases. Inferior duodenal recesses present in 75% of cases. Paraduodenal recesses is containing inferior mesenteric vein. Mesenteroparietal recesses containing superior mesenteric vessels. So write down the heading duodenal recesses. So two important point is paraduodenal recesses contains inferior mesenteric vein. And paraduodenal recesses are present in 70% of the cases. Mesenterico mesenterico-parietal recesses is present in 1% of the population and contains superior mesenteric vessels. The third is inferior duodenal recesses. So these two recesses are only important which is contain important structures and we have got retroduodenal recesses and we have got superior duodenal recesses. Here, inferior duodenal recesses are present in 75% of the individuals. Retroduodenal recesses is present occasionally only and superior duodenal recesses are present in 50% of the individuals. Duodenojejunal means, Tarun, duodenojejunal means the junction of duodenum and jejunum. Duodenojejunal recesses means the junction of duodenum and jejunum. Got it? So again we have done with this. Can we solve few MCQs related to the topic? So everyone, let's start with few MCQs related to the topic. First 2.5 centimeters or the first part of duodenum is not supplied by which of the following? Actually multiple sources are there and these are confusing MCQs because all of them gives the branches, but then also you have to rule out the one which is giving which is not primarily giving blood supply to duodenum directly. Joy, superior pancreatico-duodenal artery is definitely giving arterial supply. No, it is asking not supplied. See here, superior pancreatico-duodenal artery is definitely giving arterial supply to duodenum, superior pancreas. It is asking not giving directly blood supply. Not, it is asking not. First 2.5 centimeter of duodenum is not supplied directly by which of the following arteries? Yes, Joy, now you have given the right answer, hepatic artery. Yes, now you have given the right answer, it's the hepatic artery. So actually, you all are knowing the thing, only in hurry you make mistakes. The second is all of these supplies, so all of these, the second question is, all of these supply the first 2 centimeters of duodenum except. Actually, all of these are supplying arterial supply. This is a confusing MCQ. This is a confusing MCQ, but it has been asked in the previous year of NEET PG. You have to choose one. So, according to you, which will be the best? Common hepatic artery branches are giving. So I will, if I have to choose one, actually all of these are giving blood supply, Tarun, but if I have to choose one, best according to me is supraduodenal artery. It is also giving blood supply, but if I have to choose one, I will go with supraduodenal artery. The reason why, supraduodenal artery is a branch from multiple sources. Why I am choosing this? Because it's an artery which is having a branch from the multiple sources. So you can see supraduodenal artery. It can be a branch from the common hepatic, gastroduodenal, superior pancreatic, multiple sources. So if I have to choose one, I will go with this answer. I will go with supraduodenal artery. Okay, can you tell me, minor pancreatic duct is the opening of hepatic duct, hepatopancreatic ampulla, accessory pancreatic duct or bile duct? That is exactly asked you. So one of the student, Tarun, has given the answer. What about the others? Tarun has given the answer. Joy has given the answer. What about others? And both of them has given absolutely correct answer. Yes, the right answer is accessory pancreatic duct. The right answer is accessory pancreatic duct. Absolutely correct answer. Accessory pancreatic duct is the right answer. Now the next is the pancreas. Next topic is pancreas. Next topic is pancreas. Now if I talk about the pancreas, it's lying more or less horizontally on the posterior abdominal wall in the epigastric region. In the epigastric region, and it is not only lying in the epigastric region, it is also lying in the left hypochondriac region. And you have to know about its parts. So it is having uncinate process, it is having head, it is having neck, it is having body, and it is having tail. So basically this is the overall part which is important for you to note down. So write down parts. Pancreas. So write down pancreas lies more or less horizontally on the posterior abdominal wall, on the posterior abdominal wall in the epigastric and left hypochondriac region, left hypochondriac region, or in the left hypochondriac region. Okay, in the left hypochondriac region. Oh, great. Great. Rohit, okay, pleased to meet you. Chila Rohit. Rohit, pleased to meet you. Pleasure. Now, pleasure is mine. Pleased to meet you. Now, it crosses posterior abdominal wall obliquely from the concavity of duodenum, to the hilum of spleen, and it is located opposite T12 to L3 lumbar vertebra. It is located opposite T12 to L3 lumbar vertebra. Now, I just want that we should also be knowing about the important relations of the pancreas. So, basically we are knowing that it is divided into various components which we are already knowing, but I just want that few important relations are important, not all, but you can just see this image. So, if I enlarge this, I just okay. So, here we have got, yes, this is T for tail, this is the body, this is the body, this is the pancreatic neck, this is head, and this is the uncinate process. So, basically it is important that we should know the relation of all the important points in case of pancreas. So, basically if I talk about all the important relation, you have to know. So, the head of pancreas, you can see it is lying in the C-shaped concavity of the duodenum. So, if I talk about head of pancreas, it lies in the C-shaped concave. So, we can see here, this is the C-shaped loop of duodenum, and its relation superiorly, also it will have superior pancreatico-duodenal artery. It will be related also with the other important structures. So, basically yeah, that are the important structures. So, basically if I talk about uncinate process, as you see in this diagram, it is related to superior mesenteric vessels. Okay, body, you can see superiorly will have the you can just use this this is the artery which is running. So, superiorly it will have the splenic artery running, also the celiac trunk. So, you can see also the common bile duct is there. So, basically many important structures will rise. So, we will have the important structures related to it, that is actually important for us. Superiorly it is related, the head is related to the first part of duodenum part, it is related to superior pancreatico-duodenal artery. Inferiorly it will be related to the third part. So, this is superior. So, this is the first part of duodenum which is related. Inferiorly it will be related to the third part of duodenum and with the arteries, and also in the right lateral part will be the second part of duodenum, and the other structures like gastroduodenal artery, and we will have transverse mesocolon, and posteriorly if you will see there is bile duct. So, green color structure I will show to you. This is posterior aspect, and the head is related posteriorly to bile duct, as you can see in this diagram also. Okay. Okay, the neck of pancreas, a very important structure is related with the neck of portal vein formation occurs behind the neck of pancreas. We have got many structures, and the tail of pancreas is traversing into the hilum of the spleen. So, please write down important relation. The same relations has also been shown. So, once more I will come to this image and show you the relation. So, firstly I just want, please tabulate the importance. So, write down the heading relations of pancreas. Relations of the pancreas. So, important relation, the first is head. So, head lies in the C-shape duodenal loop, and the head is superiorly related with the first part of duodenum, and superior pancreatico-duodenal artery. Superior pancreatico-duodenal artery. Okay. Now, talking about inferior. So, this was about superior aspect. Inferiorly, it is related with third part of duodenum, and inferior pancreatico-duodenal artery. Inferior pancreatico-duodenal artery. Posterior aspect it is related to inferior vena cava, left bile duct, posteriorly related with left renal vein also I think, and the bile duct. Anterior surface, anterior aspect, it is related with gastroduodenal artery, transverse colon and transverse mesocolon. So we have done with the head part relation. Now talking about uncinate process. The second is uncinate process. So if I talk about the uncinate process, anteriorly it is related with superior mesenteric vessels, posteriorly it is related with abdominal aorta. Then talking about the neck, the important point of relation of the neck is formation of portal vein takes place. Formation of portal vein takes place posterior to neck, takes place posterior to neck. Take place body. If I talk about the body, anterior border of the anterior border is related to transverse mesocolon, superior border is related to celiac trunk, and anterior, if I talk about posterior relation, so posteriorly it is related to aorta, superior mesenteric artery origin, left kidney, left suprarenal gland, and also to the splenic vessels. And important relations. And if I talk about the tail, tail is going into the high. So if I talk about the tail, tail is reaching to the hilum of spleen. This is just the relation of tail. So basically important relations done. So these are all the important relations done. And what is next which is important for you to know is that you should be knowing about the important ducts and blood supply. So arterial supply, if you will see, it is basically getting blood supply. Pancreas is getting blood supply from the branches of splenic arteries. Arteria cauda pancreatica, arteria cauda magna, also via superior inferior pancreatico-duodenal artery. So this image is showing you arterial supply of pancreas. So this image is showing you arterial supply of pancreas, which is highly important for you to understand. This is showing you the lymphatic drainage. The lymphatics, actually it is mainly to the pancreatico-splenic. So it is anterior and pancreatico-splenic lymph node, pyloric, splenic nodes, and these are very, very important lymphatic drainage. Okay, and now I would like to also start with the one more important is the venous drainage. So venous drainage. Venous drainage is into the portal vein, into the superior mesenteric vein, and into the splenic vein. Next topic is the portal vein. Everyone, is it okay? Can we move to the next topic, that is portal vein? Any doubt you can ask me. Okay, any doubt you can ask me. So till now, if you have got any doubt, so the next topic is the portal vein, which I want everybody to understand. So just now only I told you, if I am talking about the portal vein, it is exactly known to you that it is formed posterior to the neck of the pancreas. So this is the pancreas, posterior to the neck of pancreas, the formation of portal vein. So write on portal vein is formed. It is formed behind the neck of pancreas. It is formed behind the neck of pancreas by the union of superior mesenteric vein and splenic vein. At the level of, so basically that is very important. Now the next thing is to know the important tributaries of portal vein. So basically portal vein is very important, it's carrying the blood supply. So portal vein is an important vein which is exactly collecting blood from the various sources. It is actually collecting blood from the various sources which collect blood from the part of abdomen and pelvic structures, alimentary canal, gallbladder. It is also connecting blood from the pancreas. So many of the important structures are there from which the portal vein is collecting blood. The important tributaries which is important for you to note down. So we have got a formative tributary, superior mesenteric vein as the splenic vein is the formative tributary. Other than that, we have got also the other tributaries like superior pancreatico-duodenal vein. We have got right and the left gastric veins. We have got para-umbilical veins. So please write down the tributaries of portal vein. Write on the heading the tributaries of portal vein. Tributaries of portal vein. So write down the important list of tributaries of portal vein. So if I talk about important list of tributaries, the tributaries are splenic vein, the superior mesenteric vein, the superior pancreatico-duodenal vein, superior pancreatico-duodenal vein, we have got the left and right gastric vein. We have got left and right gastric vein. We have got the cystic vein and para-umbilical vein. Cystic vein as the tributary and para-umbilical vein. Okay. So all these are the important tributaries which you have to know. All these are the important tributaries which you have to know. All these are important tributaries which you have to know. So now I have just made this list of photo. So I have taken a multiple source of books from also from the surgery and anatomy content, and I just want that everybody should have a look of these important site of portocaval anastomosis. Why? Because portocaval anastomosis is not only an important question being asked for your anatomy exam, it will be also asked for your surgical question. So we have to know the sites where the portocaval anastomosis takes place and what is the resultant effect. So three important sites are there which is very important for FMG exam, and for NEET PG INI-CT exam I just want everybody to know the entire list also. So these three is the most important. These three are most important for MCQs. So, lower end of esophagus is an important site of portocaval anastomosis where esophageal tributary of accessory hemiazygous vein will form anastomosis with esophageal tributary of left gastric vein, and the effect is esophageal varices and can lead to the bleeding from hematemesis. It can lead to umbilicus is the area where veins of anterior abdominal wall will form anastomosis with the portal source of para-umbilical vein and leads to the condition of radiating veins around the umbilicus, that is called as captive medusa. Lower end of the rectum, the superior and the inferior rectal vein will anastomose with superior rectal vein forming hemorrhoids. Posterior abdominal vein, the veins of the left renal vein and veins of the abdomen will be forming anastomosis with the splenic vein and veins of retroperitoneal organ. Bare area of the liver, we have got venous anastomosis between the diaphragmatic and that of the hepatic branches of the portal vein. In the liver, we have got anastomosis between the patent ductus venosus and the left branch of portal vein. In the posterior aspect of vaginal wall, we have the anastomosis between the superior rectal vein of the portal source and vaginal venous plexus. Also in the falciform ligament, the anastomosis will be formed between para-umbilical vein and diaphragmatic vein. So what I want everybody, this this source of anastomosis will be known to you, and just go through this. This is highly important, the sites of portocaval anastomosis. Next topic is ureter. So everyone, are you understanding? Please let me know. Thank you, Tarun. Thanks, Tarun. Okay. Thank you so much. Now we will talk about the ureter. Okay, the next is ureter. So, if I talk about ureter, it's another important topic. Actually, it's a muscular tube which is conveying urine from the kidneys to that of the urinary bladder. So, ureter is a narrow, thick walled. So, if I talk about ureter, if I talk about ureter, it's a narrow, thick walled, expansible, muscular tube which exactly conveys urine from kidney to urinary bladder. Okay, dear. Now, so exactly अगर हम measurements की बात, if we are talking about the length is 25 centimeters, the diameter is 3 mm. And what is important for you is to know, note down the multiple source of arterial supply, and it's important to know the relations. So, if we talk about relations, so exactly this is a diagram showing anterior relation of, this is a diagram showing right and left ureter. And this exactly, I just want you to show this image where sites of constriction will be seen, but I will also like to tell about posterior relations. So, please write down posterior relations of the So, posterior relation of ureter is similar for both the it is related to bifurcation of common iliac arteries and it is related to psoas major muscle. It is related posteriorly to psoas major muscles. Arterial supply of ureter is important. So, it's important to know the arterial supply. Actually, multiple source of arterial supply is there, and the multiple source of arterial supply is, please write down, we have got a multiple source of arterial supply, and the multiple source of arterial supply are following. So it's a highly vascular structures, and the multiple source, it can take blood supply from the arterial renal arteries, also directly from testicular or gonadal attack, like gonadal arteries, so testicular or ovarian arteries. It can also have a arterial supply direct from the direct branches of aorta. It can also have blood supply from the source of internal iliac artery. It can also have the blood supply from vesical artery, actually both superior and inferior vesical arteries. Also, the arterial sources will be from the middle rectal arteries and from uterine arteries, also 7 source uterine artery. These are multiple source of blood supply. So you can say, you can just see that ureter is having multiple source of arterial supply from different sources. Now this is already, this is showing you the arterial supply of ureter, arteries supplying ureter. Which we have already written. Now this is an image where you can also appreciate the constrictions, and you can appreciate not only the constrictions, you can also appreciate the course and its posterior relation. So if I just enlarge this in this diagram, you can see the posterior relations of ureter. Posterior relations of ureter. Okay. So if I talk about the posterior relations of the ureter, you can just see the ureter is related posteriorly to the either side psoas major muscle. You can see there is a psoas major muscle which is shown. These are the either side psoas major muscle. This is P for psoas major muscle of either side. And you can see the bifurcation of iliac vessels. So common iliac vessels, you can see the bifurcation is here. And this green color structure which you are seeing is the ureter. So this structure is the ureter, which is having the relations on the right and the left psoas major muscle of either side and running anterior to the common iliac bifurcation. Okay. Now, the constrictions. So this image is showing you the constrictions of ureter. So the important constrictions are at the pelvic-ureteric junction. This is an important constriction. The pelvic ring where it is crossing the common iliac artery bifurcation, and the third is the uretrovesical junction where it is entering into the urinary bladder. Other than that, I would like to add on the fourth point of constriction. That is, in males it is the vas deferens, and in females it is the broad ligament also. Ureter lymphatic drainage is to lateral aortic and iliac nodes, and venous drainage is into renal veins. So we already know the venous and arterial drainage is corresponding to each other. Now next is the suprarenal gland. So actually, why I want you to show this image, the reason is that why I want you to show this image, because you can have an idea of blood supply of suprarenal gland. Actually, if I am talking about the arterial supply of suprarenal gland, it is coming from 3 important sources. So we have got a superior suprarenal artery, we have got middle suprarenal artery, we have got inferior suprarenal artery, and these 3 arteries are coming from 3 sources and giving arterial supply to suprarenal gland. The other important thing is, if you will see this image, I am enlarging this image just to make you understand how you are going to. So actually, image based question has been come for the previous year of examination, and it's very important that you should have an idea of knowing the structures of identification, how we are going to know that this is the left suprarenal gland or this is the right suprarenal gland? So what you can see here, if you will see the right suprarenal gland, you can see it is triangular. It is triangular, and if you will see the left suprarenal gland, it is the right suprarenal gland, which is triangular, and it is near to inferior vena cava. You can see it is more near to inferior vena cava, and the left one is more near to abdominal aorta. This is semilunar in shape. So this is the difference. So this is R for right and this is L for left suprarenal gland. Now again, the source of arterial supply is important. As I told you, the source of arterial supply is from superior suprarenal artery, which is a branch from inferior phrenic artery, as you can see. Middle suprarenal artery, directly the branch of abdominal aorta. Inferior is a branch of renal arteries. So please write on this. Is supplied by 3 arteries. The first is superior suprarenal arteries. Superior suprarenal artery is a branch of inferior phrenic artery. It's a branch of inferior phrenic artery. Okay, it's a branch of inferior phrenic artery. And middle suprarenal artery is a branch of middle suprarenal arteries, is directly the branch of abdominal aorta. Is directly the branch of abdominal aorta. If I talk about inferior suprarenal arteries, in third source is inferior suprarenal arteries. So inferior suprarenal arteries, if I am talking about, it's a branch from inferior suprarenal artery is a branch from renal arteries. It's a branch from renal arteries. Done. Now next topic is small intestine. So we will talk about small intestine and large intestine in brief. We will have an important difference between which the GI gut parts. So we will know the characteristic features of difference between jejunum and ileum, and we will know about the large intestine colon part. So that is important for us to know. So here basically I will show you multiple images. I will show you multiple images which will help you to understand the features of jejunum and ileum. So if you will see the loop of jejunum, what you can see, the jejunum is having 1 or 2 vascular arcades and the longer vasa recta. In case of ileum, you can see it is having 1 or 2 vascular arcades. It is having 3 to 5 vascular arcades and shorter vasa rectas. So that means the space between the vasa recta will be less in case of jejunum, but will be more in case of it will be less in case of ileum and will be more in jejunum. So I just want you to show the mesentery. So see here, this is the loop which I am showing you, and this is the loop of ileum. So this is ileum, and the arterial arcades can be 3 to 5 and the vasa recta will be shorter and close to each other, close. But if you see the jejunum loop, it is having vasa rectas are long and arterial arcade is 1 or 2. So PW, what do you mean by PW? The peritoneal window between the vasa recta. So if you will see the peritoneal window, what you can appreciate, it is translucent. More. Large intestine. So I just want you to show the large intestine part. It is having transverse colon, ascending colon, descending colon, sigmoid colon. So basically large intestine, if you will see, the basic features are it is having haustration. What are these? These are haustrations. This is longitudinal band. So this is the longitudinal muscle cord, which is called as tinea, which is all converging at the base of the appendix, and small fat pouches are there. You can see these are small fat pouches, which is called as appendices epicoli. So these are all appendices epicoli. So basically these are the cardinal features of large intestine. So basically I just want everybody to understand the basic difference between duodenum and small intestine proper. Why? Because duodenum we have separately talked, because it is having a, see, it's having 4 parts, and the major basic differences is that it is short in length, only 25 centimeters, but if I talk about small intestine, it is 6 meters approximately. It is a presence of Brunner's gland. Basic and the most important feature histologically is the presence of Brunner's gland. So there is a presence of Brunner's gland in case of, there is a presence of Brunner's gland in the submucosal layer, which is an identifying point for the duodenum. And in case of small intestine proper, jejunum identifying features is valve of Kerckering, and ileum identifying feature will be Pierce patches. Now, the differences between the jejunum and the ileum has been shown to you. Actually, the walls differences, these are comparative difference if I am talking about. So you can just see, if you will see the, just see this. So if you will see the walls, this is thicker and more vascular in jejunum as compared to ileum, and wide and diameter is jejunum and narrow is the ileum. They are actually comparative thing. Most important thing is that ileum, jejunum has got leaf-like villi and shorter villi will be in the ileum. The Pierce patches will be maximum. So maximum number of Pierce patches will be present in ileum, and Pierce patches in the jejunum will be absent, or 1 or 2 can be present. And also vasa rectas are longer in case of jejunum, and peritoneal window is transparent in jejunum, but peritoneal window is opaque in ileum, and arterial arcades are 3 to 5 and vasa rectas are shorter. So all these differences are there. So actually the same thing has been shown in this diagram. So you can see here jejunum loop having 1 or 2 arterial arcades, 4 to 5 arterial arcades in ileum. Vasa recta shorter, peritoneal window opaque, peritoneal window is transparent. This will be the peritoneal window. Will be highly transparent. So this peritoneal window, you can say more spaces is there. Inside, if you will see, so solitary lymph nodes will, Pierce patches will be maximum in number in ileum, and Pierce patches will be maximum in the distal part of ileum. In the distal part of ileum. Large intestine, if I talk about, large intestine is approximately 1.5 meters long. It is extending from cecum and the right iliac fossa to the anus. And the different parts of the large intestine will be ascending colon, descending colon, transverse colon, sigmoid colon. The 3 features or the cardinal features in case of large intestine is tinea coli, appendices epicoli, and sacculation, which is also called as hostrations. So both the features are seen in the longitudinal view and in transverse section. So these are the 3 cardinal features: appendices epicoli, that is fat pouches, contraction of seen as sacculation and hostration. Tinea coli is the muscle longitudinal muscle cord. So if I talk about tinea coli, they are ribbon-like bands of longitudinal muscle cord, and these bands will be converging proximally at the base of appendix and spread out more distally to be continuous with the longitudinal muscle cord of the rectum. Location, actually it is important that we have got 3 tinea coli. All these tinea coli are containing which will be converging at the base of appendix. We have got 3 tinea coli. One is called as tinea omentalis, the other is tinea mesocolica, and we have got tinea libra. So basically, if I talk about tinea mesocolica, it is posteromedially, anterior is the tinea libra, and posterolaterally is tinea omentalis. But in transverse colon, if I talk about, they are not arranged like this, but they are spread out inferior, posterior, and superior respectively. Appendices epicoli, if I talk about appendices epicoli, they are small bag of visceral peritoneum fluid filled fat, which is important for giving lubrication. The sacculation and hostrations are pouch and dilatations in the wall of cecum colon, and they are produced by the length of tinea failing short of the length of the circular muscle cord. So it is responsible for puckered appearance of the overall large intestine. So it's also important that you should know the major difference between small and large intestine. So basically, villi will be absent in large intestine, villi is present in small intestine. As you can see, length lumen is wider in large intestine, mobility is more in small intestine because of the presence of mesentery. Transverse folds are permanent in the case of small intestine, but it is obliterated in case of large intestine. Pierce patches is absent in large intestine, but it is present in the distal part of ileum. Appendices, epicoli, tinea coli, hostration are present in large intestine. These are the features absent in small intestine. So let's talk briefly about the cecum. So if I am talking about the cecum, cecum is actually a dilated pouch, blind pouch which you are seeing, and it's basically important features of cecum is that cecum is the part which is shown here. Actually, it's the blind pouch. It's a dilated pouch of commencement or proximal end of the large intestine, and its importance location is important. It is located in the lateral half of, it is located in the right iliac fossa. What is the location? In the right iliac fossa above the lateral half of inguinal ligament. Communication, it communicates superiorly with the ascending colon, and it communicates with the ileocecal junction with ileum, and also it communicates with the appendix posteromedially. That means cecum is a blind dilated pouch of large intestine. It is having three communications: superiorly ascending colon, medially with the ileocecal junction, and posteromedially with the appendix. Now various type of cecums are there. So we have got a normal type of the cecum where right cecal pouch is enlarged, and we can see that appendix is opening below the ileocecal junction. Okay, and if you will see the exaggerated form, there the right cecal pouch is much exaggerated. We have got a quadrate infantile where there is both right and left cecal, and infantile we have got a fetal type conical shape of the cecum is fetal type. Anterior relation of the cecum is, it is anteriorly related with the coils of small intestine, greater omentum, and the anterior abdominal wall. So these are the anterior relation of cecum. It is just so few important structures are anteriorly related with the cecum. That is the coils of small intestine, the greater omentum, the anterior abdominal wall in the right iliac region. Posterior relations has been shown in this image. So the most important posterior relation of the cecum has been shown here. The posterior relations are right gonadal vessels, lateral cutaneous nerve of thigh, genitofemoral nerve. We have got psoas major muscle, also iliacus. We have got relation with external iliac artery and that of femoral nerve. So all these structures which has been tabulated here are lying in the posterior relation of the cecum. All these structures are lying in the posterior relation of the cecum. Now, interior of the cecum, if you will see, we have got two openings. One is ileocecal valve, ileocecal junction. Another is also the appendicular. So we have got the appendicular orifice which is having valve of Gerlach. Appendix is lying approximately posteromedial to that of ileocecal junction. Blood supply. So if I am talking of the blood supply, the cecum is having the arterial supply from anterior posterior cecal artery, and anterior posterior cecal arteries are, if I talk about anterior and posterior cecal arteries, anterior and posterior cecal arteries, anterior and posterior cecal arteries are branches from they are branches from ileocecal wall. They are branches from ileocolic artery. They are branches from ileocolic artery, which is a branch from superior mesenteric artery. Lymph will be draining into pre-aortic group of superior mesenteric group of pre-aortic group of lymph node, ileocolic group of lymph nodes. Nerve supply is from T11, L1 sympathetic and parasympathetic nerve supply of cecum is from both the vagus nerve. Now let's talk about a vermiform appendix. If I'm talking about the vermiform appendix, it's a narrow worm-like diverticulum which is exactly arising from posterior wall of the cecum. So exactly it is arising from posterior wall of the cecum. To be more precise, it is suspending 2 centimeter below the iliocecal junction. This is highly important point. It is from the posteromedial wall of the cecum from the iliocecal junction 2 centimeters below. Now, what is asked in the examination, what is very important and asked in the examination is the different positions of the cecum, different position of the appendix, and you can see here we have got the most common position, that is retrocolic position. We have got pelvic position is the another second important position. We have got mid-inguinal paracolic, and we have got splenic position, which is of two types, pre-ileal and post-ileal type. So we have got 3 o'clock position, which is the promontory position. The most common position is retrocolic position of appendix, but if we talk about most dangerous position, it is splenic position, that is also pre-ileal type of splenic position, because the inflamed appendix can lead to the case of inflammation, and peritonitis it can also involve the peritoneal cavity and cause peritonitis. So here we have got this are the different varieties. So splenic position of the splenic position of the appendix of pre-ileal type is the most dangerous type, and most common type is the retrocecal position of the appendix. So write down appendix. Most common, so most common position of appendix is retrocolic position. And most dangerous position of appendix is splenic pre-ileal position. And the reason is that why it is most dangerous, because infections or inflammations of this can cause peritonitis. It can communicate with the peritoneal cavity and can cause peritonitis. Done. Now, if I talk about vermiform appendix, it's an intraperitoneal structures, and it is suspended by a small triangular fold of peritoneum, which is called mesoappendix. What is it called as, dear? It is called as mesoappendix, and it's also important to know that the appendix is actually appendicular artery is running within the free margin of the mesoappendix. Arterial supply has been asked so many times in the MCQ, so it is important that you should know about the arterial supply. And the arterial supply is via appendicular artery, which is a branch of ileocolic artery. Ileocolic artery is a branch of superior mesenteric artery. The venous drainage is corresponding to superior mesenteric vein, which will ultimately drain into portal vein. Now, lymphatic drainage of the appendix. Lymphatic drainage of appendix is via ileocolic lymph node, which will drain into appendicular lymph nodes into the mesoappendix. Nerve supply, if I talk about, it is having sympathetic innervation by T10 spinal segments, parasympathetic by vagus. Actually, T10 spinal segment also give innervation to the dermatomal distribution around the umbilical region. So only pain of appendix is radiated to the umbilical region. Now, appendicitis, what do you mean by the word appendicitis? Inflammation of appendix is called appendicitis. So, basically, the pain is initially in the right iliac region, but it will be radiated to the umbilical region, paraumbilical region, because of same segmental innervation via T10 spinal segment. On palpation, the maximum tenderness is at the level of McBurney's point. And what is McBurney's point? It's the point of junction between the medial 2/3 and lateral 1/3 of a line extending from anterior superior iliac spine to the umbilicus. So this is very important point, and this point is corresponding to the base of appendix, so it is called as the McBurney's point. This location is called as Max Burney points and maximum level of tenderness. Now, before proceeding to the MCQs here, I just want everybody that you should know about two tests which is done in case of appendicitis. One is Swartz test and another is obturator test. So we have got Schwarz test in appendicitis condition and we have got obturator test in appendicitis condition. So Schwarz test is when the appendix is in the retrocecal position. It will, when it is in the retrocecal position, it's very important for you to note down that it is in the retrocecal position. It lies or irritates in the right psoas major muscle. When it is inflamed, it's called appendicitis, and that will lead on extension of the right thigh. The patient increases pain in the right iliac fossa. If I go for obturator test in appendicitis, in that case what's happened, irritation of obturator internus muscles takes place, and on the basis of flexion and medial rotation of right thigh, there is pain in the lower abdomen. So we have got obturator test positive in case of pelvic type of appendix location, Schwarz test positive in case of retrocecal position of the appendix. Now, can we have MCQs? All of you please solve the MCQs along with me. Those who are present, everyone can solve an MCQs along with me. So, which of the following is not characteristic feature of large intestine? The option are sacculation, villi, tinea coli, appendices epicoli. Which of these is not a characteristic feature of large intestine? Joy is telling B. What about others? What about others? Which is not a feature of large intestine, and absolutely correct, Joy, you are absolutely correct. Villi is the feature of small intestine. It is a feature of small intestine. It's not a feature of large intestine. Absolutely correct, dear. Pierce patches are present in which of the following structures? Pierce patches are present in which of the following structures? Pierce patches are present in which of the following structures? Duodenum, jejunum, ileum, transverse colon. Duodenum, jejunum, ileum, transverse colon. Which is the right answer? Pierce patches are present in duodenum, jejunum, ileum, transverse colon. Joy is telling C. What about others? What about others? Joy, you are again absolutely correct. Yes, ileum is the right answer. Absolutely correct. Appendices epicoli is seen in. What about others? Appendices epicoli is seen in. Appendices epicoli is seen in stomach, ileum, duodenum and colon. Appendices epicoli is seen in stomach, ileum, duodenum and colon. Joy is telling D. So Dr. Rakesh Kumar Yadav is and Joy, both are correct. Yes, colon is the right answer. Absolutely correct, dear. So the next topic is the stomach. Next topic is stomach. So let's talk about the stomach. Stomach, if I talk about the location of the stomach, it is located in the left part of the abdomen and it is basically occupying the left hypochondriac region, also the umbilical and the epigastric region. So these are the areas where the stomach is residing. So what will be the location? The parts of the stomach is, it is having a cardiac part, it is having a fundic part, it is having a body part and it is having a pylorus part. Okay. Yes, yes, baseball equipment, you are absolutely right. Yes, that is the right answer, dear. So write down stomach. Stomach is located in upper left part of abdomen, occupying left hypochondrium, umbilical and epigastric region. Umbilical and epigastric region. If I talk about the length of the stomach, if I talk about length of stomach, it is corresponding to 10 inches. So basically, actually, I just want everybody, actually there are two parts of the stomach or orifices. The cardiac orifice is continuing with the stomach, is continuing with the esophagus. So esophagus is continuing with the cardiac orifice of the stomach. And if I talk about the pyloric orifice, it is actually continuing with the duodenum parts of the small intestine. So basically what is important for you to note down that pyloric orifice is an anatomical sphincter, but that of cardiac orifice does not have an anatomical sphincter, it's a physiological sphincter. The location. So if you will see the location of cardiac orifice, it is corresponding to the level of 7th costal cartilage left side, left 7th costal cartilage at the level of the border of T11 lumbar vertebra, T11 thoracic vertebra. And if I talk about orifice, pyloric orifice, it is at the L1 level, transpyloric plane at the L1 level. So L1 is the level of pyloric end, and we have got 7th costal cartilage left hand side, or T11 is the level of cardiac orifice. Now the next thing is to know about two important areas. Actually one is trabue space. So what is trabue space you have to know, and what is gastric triangle. So gastric triangle is a triangular area which is actually not having, so why a gastric triangle is important for gastric tube is inserted in case of esophageal instinctor patients, and it is related on to the right side by left lobe of the liver, onto the left side by left costal margin, and inferiorly by transverse colon. So gastric triangle boundaries are onto the left side by left costal margin, right side by the left lobe of the liver, or inferiorly will be the transverse colon. Actually, why I have shown you this image, actually gastric triangle is not having important abdominal structures residing on this region. So this triangle will be penetrated in the case of individual which can be feed with so exactly whatever a gastrotomy tube can be introduced in this area. Gastrotomy tube can be inserted in this area, and this will be helpful for feeding the patient who is having the esophageal sphincters strictures. The other one space which I want everybody to understand is trabue space. So what is trabue space? Trabue space is an area of the stomach which is lying over the fundic part of the stomach, which is having, exactly if I talk about the fundus part of the stomach, why it is important? Because it will have air in it, so it will be tympanic on percussion. It will be tympanic on percussion. So trabue space is, write down, is lying over fundic part of the stomach. It is lying over fundic part of the stomach, which is lying over, which is containing air. So this is containing air, so it will be tympanic on percussion. It will be tympanic on percussion. Now I just want to define the trabue space. So you can see here above with the costal margin, and on the left side is the liver, and this is exactly the area over the fundus part of the stomach. Now I also want everybody to understand the stomach relation. So actually stomach is anteriorly having the relation with the anterior abdominal wall. So it is having a relation with anterior abdominal wall, the left costal margin, the diaphragm, the left lobe of the liver. Okay, and on the superior aspect, the stomach is having the left dome of the diaphragm. Posteriorly, stomach is related with many of the viscera, so it is called as the stomach bed. So we have got pancreas, transverse colon, transverse mesocolon, left kidney, left suprarenal gland, splenic artery. All these structures are forming the postero-inferior relation of stomach bed of the stomach. So this all forming the stomach bed. These all structures are forming the stomach bed. Now, ligaments of the stomach. If I talk about the ligaments of the stomach, the important ligaments of the stomach is following. If I'm talking on ligaments, it means so basically we have done with the relation. Once more, I want you to concentrate on this. We have got antero-superior relation of the stomach, which is having the gastric impression of the left lobe of the liver. It is having quadrate lobe of the liver relation. Posteriorly, it is related with lumbar of important structures as like transverse colon, pancreas, transverse mesocolon, left kidney, left suprarenal gland, splenic artery. So exactly posterior relation of the stomach can be memorized by. So if you want, you can know that posterior relation of the stomach can be very important, memorized by a mnemonic, that is Dr. S3 kills patient mercifully. So we have got this relation. I just, before proceeding to this, so here I just want to write, please write down. Oh, what is lesser sac? Yes, dear, lesser sac is the peritoneal cavity. Yeah. So, yes, dear, lesser sac. Please understand. Lesser sac is the peritoneal cavity space which is lying posterior to the stomach. So, lesser sac. If you remember, in the peritoneum class, I have told you about greater and lesser sac. And greater sac is the general peritoneal cavity in the space which is lying posterior to that of the stomach, in between that is having communication with the greater sac with that of the foramen of Winslow. We have got the lesser sac. Is it okay, Joy? Have you understood, Joy? So lesser sac means exactly lesser sac is actually called as omental bursa. It's a diverticulum of the general peritoneal cavity. If you want, you can write it here. Write down. Lesser sac is diverticulum of greater sac of peritoneal cavity. And if you remember, I have shown you that foramen of Winslow is a communication with greater and lesser sac. So lesser sac is actually lying posterior to lesser omentum. So if I talk about the location of the lesser sac, it is lying posterior to the lesser omentum and caudate lobe of the liver. So exactly, it is lying posterior to lesser omentum and caudate lobe of the liver. Is it okay, Joy? Have you understood? Okay. So I just want everybody to have an idea of about the relations of the stomach. So please write on postero inferior relations of stomach. So if I talk about posterior inferior surface relation of the stomach, the mnemonic is, which is also called as stomach bed. The mnemonic is Dr. S3 kills patient mercilessly. Okay. So here D for diaphragm. Here S3 for, we have got S for splenic artery. Another S for suprarenal gland. Another S for splenic flexor. Another K for kidneys. P for pancreas, and M for mercilessly is for mesocolon transverse. Got it? Now, arterial supply of the stomach is important. So, basically, if I am talking about arterial supply of the stomach, important arteries which is giving arterial supply to the stomach is the branches from. So, we have got the branches of splenic arteries. So, we have got the branches of splenic artery. We have got the branches of hepatic arteries branches via right gastric artery, left gastric artery, gastroduodenal artery. Many sources of arterial supply is there. So, if you want, you can just write on the arterial supply. Write on the heading branches. Write on the heading. Arterial supply of stomach. Arterial supply of stomach. So, the important arteries giving blood supply to the stomach is following. Left gastric artery. Then we have got right gastric artery. Then we have got left gastroepiploic artery. Then we have got right gastroepiploic artery. Then we have got short gastric artery. So, left gastric artery is a branch, direct branches from celiac trunk. Right gastric artery is a branch from common hepatic artery. Left gastroepiploic artery is a branch from splenic artery. Right gastroepiploic artery is a branch from gastroduodenal artery. Short gastric artery is a branch from splenic artery. So, these are the arterial supply of the stomach. These are the arterial supply of the stomach. Okay. Now, so here you have got right and the left gastroepiploic artery anastomosing around greater curvature. Right and the left gastric arteries is anastomosing on the greater curvature. Short gastric artery is giving blood supply to the fundus part of the stomach. Veins will be corresponding to the arteries. The veins will be corresponding to the arteries. So, we will have like for example, it's important. So, directly or indirectly they are draining into portal veins. So, left gastric artery, right gastric, right and the left gastric vein, left gastroepiploic vein, right gastroepiploic and short gastric vein, all this. Lymphatic drainage, if I talk about it, is 4 quadrants are formed. And this is how it is draining into following lymph nodes. Draining into celiac lymph node, gastroepiploic lymph node, pancreatico-splenic lymph node, and ultimately pyloric nodes. Ultimately, all these lymphatic drainage are draining into celiac lymph node. Nerve supply we have got sympathetic and parasympathetic. So, write on sympathetic is via T6 to T10 and parasympathetic is via vagus nerve. Parasympathetic is via vagus nerve. So, if I talk about vagus nerve, it is via right and left vagus, which is also called posterior and anterior vagal trunk, and it is via nerve of lethargic. And other than that, there is also nerve of Grassi. There is one of the nerve which is called as criminal nerve of Grassi. Why it is important to know? Because it is giving innervation to It's a branch. It is a branch from posterior vagal trunk, and it is giving innervation to acid producing area of stomach. Okay, so that is the reason. Okay, can we solve few MCQs related to the topic? Everyone? So let's solve few MCQs. Everyone, can we solve few MCQs related to the topic? A posteriorly perforating peptic ulcer will most likely produce peritonitis in the following. A posteriorly perforating peptic ulcer will most likely produce peritonitis in the following. Okay, yes, Joy has given answer. So see the relation. If you will see in the stomach, anteriorly it is related with the following structures. So yes, infection can go onto the lesser sac, and it can also involve the liver. Also, it can also involve the liver. So it's also a peptic ulcer. It can go to the lesser sac. It can go to the bare area of the liver. Also, it can involve the lesser sac. So if we talk about the posterior perforating ulcers, it will cause the peritonitis. Yes, it can go peritonitis to the lesser sac, and it can also involve the bare area of the liver. So that is important. Okay. So can we move to the next one? Which of the following arteries supply the fundus of the stomach? Which of the following arteries supplies the fundus part of the stomach? Short gastric artery is absolutely right answer. Yes, short gastric arteries are absolutely the right answer. Short gastric arteries are absolutely the right answer. Following structures forms the part of stomach bed except Okay. All of the following structures forms a part of stomach bed except absolutely correct answer. Celiac trunk is absolutely correct answer. Absolutely correct answer. Yes. Which of the following is not present in the bed of the stomach? Which of the following structure is not present in the bed of the stomach? Which of the following is not present in the bed of stomach? Hey, Dr. Rajesh, splenic artery is present. No, which of the following is not present? Not present. The question is not present. So I will show you stomach bed once again. See here. Dr. S3 kill mercilessly. Mercilessly. Patient mercilessly. So these are all the posterior relations. No. So which is not forming? See the list. See the list. See the list quickly. Posterior relation, stomach bed. Now tell me the answer. Which of the following is not present in the bed of stomach? Now tell me the answer. Tarun has given the right answer. Fourth part of duodenum. Yes, now you got the right answer. Fourth part of duodenum. Yes, fourth part of duodenum is not a part for the stomach bed. Cardiac orifice is located behind one of the costal cartilage. I told you in the explanation, first part in the, I told you, if you remember, cardiac orifice of the stomach lies behind one of the following costal cartilage. Cardiac orifice. Joy and Tarun, both of you have given absolutely correct answer. Absolutely correct answer. Yes, the right answer is left. The right answer is left 7th costal cartilage. The right answer is left 7th costal cartilage. Absolutely correct. Left 7th costal cartilage is absolutely correct answer here. Let's move on to the next one, that is spleen. Next topic is spleen. Okay, next topic is spleen. So let's talk about the spleen, where it is located and what are the features. So exactly, spleen is actually a very important hemopoietic structures, and it is located in the left hypochondriac region. It is sandwiched between the fundus of the stomach and diaphragm. So spleen is located in left hypochondriac region, in left region between fundus of stomach and diaphragm. So exactly, it is related in relation to 9, 10th, 11th, but it is obliquely corresponding to and located parallel to the 10th rib. Its long axis is directed. Its long axis is directed. Its long axis is directed parallel to 10th rib. Measurements. If I talk about the measurements are correspond, it is thick. The thickness is 1 inch. The breadth is 3 inch. The length is 5 inches and the weight is 7 ounce. So actually 7 ounce means 1 gram. 1 ounce is, if I talk about 1 ounce, it corresponds to the weight of 28.35 grams. So this is the dimension of the spleen. This is the dimension of the spleen. So the spleen is having two ends, anterior, posterior. It is having two surfaces, diaphragmatic and visceral. So if you will see the spleen, this is the anterior border of the spleen, this is the visceral, this is posterior border, and this is the visceral surface of the spleen. So we have got diaphragmatic and we have got visceral surface in the spleen. So basically important viscera related is the gastric impression, the renal impression, the pancreatic and the colic impression. These are the four impressions in the spleen and relations. So please write down visceral surface is concave and irregular, and it is having four impressions. It is having four impressions, and these four impressions is for gastric impression is there, we have got renal, that is left kidney impression is there, we have got colic, left colon, colic, and pancreatic impression, tail of pancreas. Now ligaments of spleen is very important. You have to know the ligaments and you have to know the contents of the ligament also. So basically important ligaments in respect to the spleen is linorenal ligament, gastrospleen. You can see linorenal ligament is containing tail of pancreas and splenic artery. Gastrosplenic ligament is containing short gastric artery, accessory spleens also. So that is important. One more ligament is there, that is called as phrenico-colic ligament. So if you will see the phrenico-colic ligament, it is indirectly passing below the spleen. As you can see, it is passing below the spleen and giving indirect support to the spleen. It is not letting the spleen to descend downwards and the left. Why? Because of the presence of phrenico-colic ligament. So write down ligaments of the spleen. That is the peritoneal resistance of the spleen. So the first ligament is gastrosplenic ligament. Gastrosplenic ligament. So if I talk about gastrosplenic ligament, it extends from hilum of the spleen to upper 1/3 of greater curvature of stomach. It contains short gastric vessels and accessory spleen The next is linorenal ligament. And if I talk about linorenal ligament, it extends from the hilum of the spleen. To anterior aspect of left kidney. It contains tail of pancreas and splenic vessel. Tail of pancreas and splenic vessels. So it contains tail of pancreas and splenic vessels. So if I talk about linorenal ligament, so what is it containing? It is containing tail of pancreas and that of splenic vessels. It contains tail of pancreas, splenic vessels, and this is the gastrosplenic ligament. Third ligament is, if I talk about the third ligament, it is the phrenicocholic ligament. Actually, phrenicocholic ligament is giving the support to the inferior aspect of the spleen, and it is not letting the descent of spleen to the downward direction. So that is an important point. That is an important point. The next topic which I want everybody to understand is kidneys. Let's start with the topic of kidneys. So exactly, kidney is a very important topic. We have got right and the left kidney. What we have got? We have got right and the left kidney. So location is, actually we have got a heavy weighted liver on the right side. So the right kidney is slightly lower in location to the left kidney. Okay. So basically, if you will see kidneys, what you can appreciate exactly is that of the kidneys. So we have to know kidneys. So we are seeing that this is the right one and this is the left one. This is the right kidney which is related with the 12th rib. As you can see, this is the left one which is related with 11th and 12th rib. Now in the hilum of the kidney, if you will see, this is showing the hilum of kidney and the structure from anterior to posterior. If we are talking about the structures from anterior to posterior, the mnemonic is VAP, VAP. So here V stands for renal vein, A for renal artery, and P for renal pelvis. This is accessory renal artery, which can be at times present. So basically, we have got structures from anterior to posterior, that is VAP, V for renal vein, A for renal artery, and P for renal pelvis. So relation of the kidney is also important. I just want everybody to understand the coverings of the kidney also. So basically, please write down the coverings of the kidney, because relations can be understood by the images. So please write down coverings of the kidney. That means of renal gland or kidneys. So basically, so following coverings are there as you proceed from inside to outside. So from inside to outside. So the first structure is fibrous capsule. The first structure is fibrous capsule. The second structure is so we have got perinephric fat. We have got renal fascia. And the most outermost structure is the paranephric fat. So renal fascia is an important structure which is also having the fascia of it is called as fascia of Zerota, and actually this is why important, because if we talk about renal fascia, the fascia of Zerota, it is again having two walls. That is, if I talk about renal fascia, it is having two walls. It is having anteriorly the fascia of Tolt and posteriorly the fascia of Zuckerland. And this renal fascia is enclosing above, it is merging with the suprarenal. So it merged with it is merging superiorly with the diaphragmatic fascia. It is merged superiorly with the diaphragmatic fascia and medially with the corresponding adventitious tissues of the abdominal aorta, inferior vena cava, laterally by the fascia transversalis. So exactly. Now this diagram is showing you the anterior relation of right and left kidney. So why this is important? Because this diagram is showing you the anterior relation of right and left kidney. So right kidney will be closer to inferior vena cava, left kidney will be slightly away from the inferior vena cava. Anteriorly, if you will see, the right kidney is related with suprarenal glands of both the structures. In the anterior aspect, right kidney is related with hepatic area, duodenal area, and also below it is related with colic and jejunal area. In case of left side, it is related with gastric, spleen and the pancreatic area. It is also related with the stomach, the spleen and the pancreas. So this is the difference of relation of both side of kidney. Here we can see we have got right kidney which is posteriorly related only to the 12th rib, but left hand side both 11th and 12th rib. Three muscles are related for the posterior aspect: psoas major medially, then quadratus lumborum, and more laterally the muscle related posteriorly is transverse abdominis. Superiorly will be the diaphragm muscle related. So write down the heading: posterior relations of both the kidney. Posterior relations of both kidneys. Posterior relation of both kidneys. So if I talk about posterior relation of both the kidneys, the relations are like this. The first relation will be of muscles. We have got the relation of diaphragm. We have got the relation of psoas major muscle. We have got the relation of quadratus lumborum. We have got the relation of transverse abdominis muscle. Then we have the relations of nerves, that is iliohypogastric and ilioinguinal nerves, subcostal nerves, and also the subcostal nerves, subcostal nerves and vessels. The third point is the relation of the ribs. And if I talk about the ribs relation, it is related with 11th and 12th rib in case of left kidney, and only 11th rib in case of right kidney, because we have got a liver in the right side above. We have got liver in right side above. The next topic is, this is the last topic of abdomen, and then we will have few topics of the pelvis also. But this is the last topic of abdomen, and if I am talking of the abdomen, what is important for you to understand is that you have to know important branches of abdominal aorta. So we have got images for it, and you can understand the important branches of the aorta, which is very, very important for you to note down. So that is highly important that you should know the branches. So basically the important lateral branches are the lumbar branches. We have got ventral celiac branches, celiac artery, the superior mesenteric, inferior mesenteric artery. We have got gonadal, renal arteries. These are showing the branches of abdominal aorta. So one more image is there which will show all the branches, and you can see this image. So here you can see we have got actually we have got many important branches. So we have got paired branching inferior phrenic artery is there. We have got inferior phrenic arteries. We have got also the four pair of lumbar arteries. We have got renal, gonadal, middle suprarenal arteries. We have got ventral branches, celiac artery, the inferior mesenteric and superior terminal branches, the right and the left iliac, and also median sacral artery. So before proceeding to celiac trunk, I just want everybody, please write down the branches of, write down the heading: branches of abdominal aorta. Branches of abdominal aorta. So branches of abdominal aorta is very, very important for you to understand. So write down. Three ventral branches. Ventral branches. We have got celiac trunk. We have got superior mesenteric artery. We have got inferior mesenteric artery. We have got 3 lateral paired branches. We have 3 lateral paired branches of the viscera. We have got 3 anterior, that is anterior unpaired branches to viscera. We have ventral branches, that is 3 unpaired branches to the viscera. We have got 3 paired branches to the viscera, that is so these are 1, 2, 3. Then we have got suprarenal artery. We have got So exactly, suprarenal artery is a branch of inferior phrenic artery. So we have got middle renal arteries, middle suprarenal artery. We have got renal artery. We have got testicular ovarian arteries, testicular and ovarian arteries. Now, we have got 5 lateral paired branches. We have got 5 lateral branches, paired branches. So in this case, we have got 1 inferior phrenic artery, and we have got 4 lumbar arteries, 4 pair of lumbar arteries. 4 pair of lumbar arteries, and we have got 3 terminal branches. So the last one is 3 terminal branches. We have got 3 terminal branches. So if I talk about 3 terminal branches, what are it? They are right common iliac artery. We have got left common iliac artery, and we have got median sacral artery, median sacral artery. So done. So we have done with all the branches of the abdominal aorta, also all the branches of abdominal, which I have shown to you also. Then now next comes the celiac trunk. Next come the branches of celiac trunk. Actually, this is very easy to remember by seeing. So here you can write on the heading branches of celiac trunk. Celiac trunk, which is given at the level of T12, and this artery which you are seeing, which has been not labeled here, actually this artery is actually superior pancreatico-duodenal artery. This artery is superior pancreatico-duodenal artery. Now let me explain to you the branches. So see here, this is CT is for celiac trunk. CT, what do you understand by CT? CT means celiac trunk. And 3 direct branches are, one is the left gastric artery, other is splenic artery, and third is common hepatic artery. So please understand, when I am using the term celiac trunk, it is one of the ventral branch of abdominal aorta. It gives 3 direct branches. One is the left gastric artery, which is the smallest branch. The largest branch is splenic artery and common hepatic artery. Common hepatic artery gives gastroduodenal artery, which again divides into 2 branches, right gastroepiploic and that of superior pancreatico-duodenal artery. The common hepatic artery divides into proper hepatic artery, which is giving right gastric artery, and the proper hepatic artery again divides into right and the left hepatic artery. Here right hepatic artery is giving the cystic artery. So basically what I want everybody that these are all the branches of the celiac trunk. So if I am talking about direct branches of celiac trunk, directly the celiac trunk is giving three branches only: splenic artery, it is giving left gastric artery, it is giving common hepatic artery. Splenic artery is the largest direct branch of celiac trunk. Left gastric artery is the smallest direct branch of celiac trunk. Common hepatic artery gives gastroduodenal artery, which further gives two branches. Gastroduodenal artery is giving superior pancreaticoduodenal artery and right gastroepiploic artery. The common hepatic artery gives proper hepatic artery, which gives right gastric artery, and proper hepatic artery divides into right and the left hepatic artery, where right hepatic artery gives the cystic artery. Now we have got two more arteries here which needs to be explained. One is the superior mesenteric artery and the other is inferior mesenteric artery. So let's talk about that. So here superior mesenteric artery is given is one of the ventral branch from L3, it's one of the from L1 level, and inferior mesenteric artery here is IMA, which is given at the level of L3 lumbar vertebra. Now the direct branches of superior mesenteric artery is middle colic, ileocolic, right colic, jejunal ileal, and also inferior pancreaticoduodenal artery. The inferior mesenteric artery gives three branches, that is superior rectal artery is the continuation, left colic and sigmoidal arteries. This is again showing you, so we will just make a, I just want to write it, so please write down. Superior mesenteric artery is ventral branch of abdominal aorta at the level of L1. Its branches are, if I talk about the branches of superior mesenteric artery, it gives following branches. So it's following branches, it gives following branches, please write on the name. The important branches of superior mesenteric arteries are, it gives inferior pancreaticoduodenal artery, it gives right colic artery, it gives ileocolic artery, it gives middle colic artery, it gives jejunal branches and ileal branches, jejunal branches and ileal branches. Now let's talk about the branches of inferior mesenteric artery. Done with this, now write down the next source, branches of inferior mesenteric artery. Inferior mesenteric artery. So if I talk about the branches of inferior mesenteric artery, it is given at the level of L3 and it's a ventral branch and it gives three important branches. It gives sigmoidal arteries, it gives left colic artery as a branch, and it gives superior rectal artery. Actually, superior rectal artery is the continuation of the inferior mesenteric artery. Superior rectal artery is a continuation of inferior mesenteric artery. Okay. Now, I just want you to show this image which is showing you the celiac trunk, which is giving splenic artery, left gastric artery and the common hepatic artery as the direct branch. Common hepatic artery giving the gastroduodenal arteries, the right gastric branch from proper hepatic artery, right hepatic artery is giving cystic artery. So all these are shown here. These are showing you the branches of celiac trunk. Now, can we solve few MCQs also related to this topic, everyone? So let's solve few MCQs of the abdomen. Now let's solve few MCQs of the abdomen. Okay, let's solve few MCQs of the abdomen. Cremaster muscle is getting innervation from which of the following nerves? Ilioinguinal nerve, genital branch of genitofemoral nerve, lateral femoral nerve, femoral branch of genitofemoral nerve. Cremaster muscle is innervated by which of the following? If you are not knowing, not worry, I will explain it. Cremaster muscle is everyone, please mark the right answer. Cremaster muscle is innervated by which of the following nerves? Ilioinguinal, Joy, okay. No worries, if you are not knowing, I will tell you. Cremaster muscle is getting innervation from genital branch of genitofemoral nerve. So the right answer is genital branch of genitofemoral nerve. So this is the last topic of abdomen, but I will also start with the pelvis. So pelvis is I will take another 1.5 hours for completion of the pelvis. Okay. So cremaster muscle is innervated by genital branch of genitofemoral nerve. Genital branch of genitofemoral nerve. Superficial inguinal lymph nodes drain all of the following except. So exactly अगर हम बात करते हैं, we are talking about superficial inguinal lymph node, it drains anal canal below pectinate line, it drains urethra perineum, but it doesn't drains the glans penis. Glans penis drains into deep inguinal lymph node. Please note down, glans penis drains into deep inguinal lymph node. Glans penis drain into deep inguinal lymph node. Okay, dear. And this I have explained. Anterior relation of right ureter are all except. Anterior relation of right ureter is all except. Anterior relations of right ureter is all except. So a thumbs up goes for Joy. He is absolutely right. He is absolutely right. Yes. Bifurcation of common iliac arteries are in posterior relation, does not in anterior relation. Absolutely correct. Absolutely correct. Absolutely correct. So here the psoas major muscle and common iliac bifurcation. This is the common iliac bifurcation is in the posterior relation. Posterior relation of head of pancreas are all except. Posterior relation of head of pancreas is all except. So which of the following structures, okay, is not posteriorly related to the pancreas? Inferior vena cava, first part of duodenum, aorta, common bile duct. What is it? So you just see which structure is related with head of pancreas. Yes, Tanishka. Hi, hello. Can you give the answer? Joy, you are absolutely right. Another thumbs up goes for Joy. He is absolutely right. Yes, and the right answer is first part of duodenum. It is not lying in the posterior relation. You can see the duodenal loop is, if you will see this diagram, you can understand the duodenal loop is not posteriorly related, but duodenal loop is encircling the head of pancreas. It is encircling. Rest all structures, abdominal aorta, the arteries, the bile duct, portal vein, all is posteriorly related. Callot's triangle is bounded by all except. This I have explained. Callot's triangle is bounded by all except. Callot's triangle is bounded by all except. Callot's triangle is bounded by all except 3C. Remember 3C. No, cystic duct. No, C, 3C. I told you the boundaries of Callot's triangle is 3C. So that is giving you the right answer. Callous triangle is bounded by all except. No dear, inferior surface of the liver. Inferior surface of the liver is not. Callous triangle boundary is 3C. 3C, and this 3C is for cystic artery. This 3C is for cystic duct and common hepatic duct. Yes, Dr. HKR, you are right. Yes, you are right. See here, in this triangular space, I will make you understand. In this triangular space, if you will see the boundary, you can understand. See here. This is exactly the Callot's triangle. So this triangular space is Callot's triangle. This triangular space is Callot's triangle. So it is bounded by 3C, cystic artery, cystic duct and common hepatic duct. But if we are talking about, I will take another color. So if we are talking about this triangular space, this is cystohepatic triangle. This is cystohepatic triangle. Cystohepatic triangle is bounded by inferior surface of the liver. Okay dear, okay dear. Now can you tell me which of the following ligament conduct portal triad, portal vein, portal hepatic artery, bile duct? Which part of the ligament? So exactly lesser omentum I have shown you, it is attached with the part of liver and the stomach and also part of duodenum. So can you tell me which part is conducting the three structures? Free margin, I told you, that the free margin is given as the name. So can anybody give me the right answer here? Yes, Tanishka, absolutely right. Hepatoduodenal ligament is the right answer. The free margin of lesser omentum is hepatoduodenal ligament. So gastrohepatic ligament will carry gastric arteries, right and left gastric arteries, but hepatoduodenal ligament, yes, Joy, you are right, which contains portal vein, hepatic artery, and bile duct. Which structure forms the superior boundary of superior boundary of omental foramen? So omental foramen means foramen of Winslow. Hint, foramen of Winslow. Omental foramen is foramen of Winslow. So epiploic foramen, foramen of Winslow, this you tell me which is forming the superior boundary. Yes, caudate lobe of the liver is definitely the right answer. Yes, caudate lobe of the liver is definitely the right answer. Yes, caudate lobe of the liver is definitely the right answer. Absolutely correct. Which structure contain both smooth and skeleton muscle? There is one structure which is having both smooth and skeleton muscle. Which structure contains, yes, Joy, you are absolutely right. It's the esophagus. Absolutely correct answer goes for Joy. Absolutely correct, dear. It's the esophagus which contains both smooth and skeleton muscle. Which contains both smooth and skeleton muscle. Absolutely correct answer, Joy. Okay, dear. Left gastro-omental. Left gastro-omental means left gastroepiploic artery. So left gastro-omental is also called as left gastroepiploic artery, and it is a branch from which of the artery? Left gastroepiploic. Left gastro-omental artery, left gastroepiploic artery is a branch of which artery? Splenic artery is absolutely right answer, Joy. Absolutely right answer, Joy and Tarun. Absolutely correct. Superior anterior posterior pancreatico artery is a branch of. So superior pancreatico artery means superior pancreatico artery is a branch of. Superior pancreatico duodenal artery is a branch of. Yes, gastroduodenal artery is absolutely correct answer. Yes, dear, gastroduodenal artery is absolutely correct answer. Again, a thumbs up goes for all of you. Very good. Root of mesentery crosses all of the following structure except. Root of mesentery crosses all of the following structure except. Root of mesentery contains all of the following structure except. Root of mesentery crosses all of the following structure except. Question number 11. No, any other guesses? Abdominal aorta is not the right answer. No, dear. No. Anyone wants to try? So it's basically if I talk about root of mesentery, right ureter. No, dear. It's all the structure is crossed except the splenic artery. Except the splenic artery. So splenic artery is the right answer. It doesn't crosses the splenic artery. Rest all structure is crossed by the root of mesentery. Now this I have explained to you. Formation of portal vein occur where? By joining superior mesenteric and splenic vein will join to form the portal vein, and this formation of portal vein occurs where? In relation to which of the following structure is the formation of portal vein occurs? So I got an answer from Joy. What about others? And this is absolutely right answer, the neck of pancreas. Yes, it occurs posterior to the neck of pancreas. Absolutely correct, Joy. Absolutely correct, Ved Mittal. Yes, Ved Mittal is also absolutely right. Which structure crosses the horizontal or third part of the duodenum? Which structure is crossing the third part of duodenum? Which structure is related to third part of duodenum in other words? Which structure is related to third part of duodenum in other words? Hepatic artery, no dear, hepatic artery, no. I have shown you the image also. We have shown you the superior mesenteric vessel related to the uncinate process of duodenum. In that way, it is related with the horizontal part of duodenum. So, superior mesenteric artery will be the right answer. Superior mesenteric artery will be the right answer. Yes, Joy and Tarun has given the right answer. Now, this I have explained you. Duodenojejunal junction is supported by the attachment of its structure. Duodenojejunal junction is supported by the attachment of which of the following structure? Tarun has given the answer, Ved Mittal has given the answer, Joy has given the answer, and absolutely the suspensory ligament of duodenum, ligament of Trich is the right answer. Absolutely correct. Absolutely correct. Appendicular artery is a branch of which artery? Appendicular artery is a branch of which artery? SR has given the answer. What about others? Ved Mittal has given the answer. What about the others? Taru, absolutely correct. It's a branch of ileocholic artery. Absolutely correct. It's a branch of ileocholic artery. Yes, it's a branch of ileocholic artery. Absolutely correct. Which structure is located deep to the point that is lying between the 1/3 of the way of oblique line connecting AS, IS and umbilicus? What is the location? Which structure can be located deep to a point that is 1/3 of the way connecting oblique line joining AS, IS and umbilicus? And the right answer is sprouting up, and that right answer is absolutely correct. All of you has given the right answer. D, absolutely correct. D is the right answer. Appendix. Superior suprarenal artery is a branch of, I have explained you this. Superior suprarenal artery is a branch of which artery? Let me see who remembers. Let me see who remembers. Superior suprarenal artery is a branch of which artery? I have explained this. Superior suprarenal artery. I have explained this. 3 sources of suprarenal artery. Dr. Sarma, Dr. Ved, Dr. Tarun, Dr. Joy. No, till now no one has given the right answer. Till now no one has given the right answer. I told you 3 sources, and superior suprarenal artery is a branch of one of the following. No, Joy. The right answer is inferior phrenic artery. Inferior phrenic artery. Superior suprarenal is a branch of inferior phrenic artery. Middle suprarenal is directly the branch of celiac trunk, and inferior suprarenal artery is a branch of renal artery. Okay, dear. So done with this. So again, actually, the next thing which I have to start is the pelvis. So I just so we have done with the most of the thing. Only pelvis is remaining. In which pelvis I will take another 1.5 hours. So basically 1.5 hours more session is remaining. So I will give you a break of 5 minutes. Is it okay? Because I want to complete it. Is it okay? We will start with the pelvis. Few more structures. Pelvis, many of the topics will be done in gynae and obs, but few anatomical topics which I want to complete. Is it okay? So just 5 minutes break. Everyone, just 5 minutes break. Is it okay? Yeah. I will just give you 5 minutes break, and we will again start with the pelvis. Few more topics, and then we will end for today's session. And tomorrow, exactly at 5 p.m., we will meet with the session. Okay. So yes, hello everyone. So let me start with the session. Let me just check, am I audible? Okay, so let's start with the session now. Okay, so now the next few topics of the pelvis also needs to be completed if I want to complete the entire abdomen and pelvis. So we have done with the whole abdomen important topics. Pelvis few topics are needed because I will not go into the important structures is very important. So let's start with this, which is generally left out in the gynae and obs part, which I will explain. So let's start with the first topic, that is pelvic diaphragm. So it's important to know what is pelvic diaphragm, what are the structures which is forming pelvic diaphragm. So actually, if I want to just give you the whole details of the pelvic diaphragm, so pelvic diaphragm is a muscular partition which is taking place between the true pelvis and the perineum. So it's a muscular partition. It's a muscular partition between true pelvis and perineum. It's a muscular partition between the true pelvis and that of perineum. Okay. It forms the gutter shaped pelvic floor. It forms a pelvic floor and is formed by large. So exactly, if I talk about the formation, what are the muscles which is forming? So it is formed by large levator ani muscle and a small coccygeus muscle. So it is formed by a large levator ani muscle and a small coccygeus muscle So exactly the formation of this gutter shaped pelvic diaphragm occurs when the two sides levator ani muscle converge, and these two sides of levator ani muscle converge with that of the small coccygeus muscle. So this will ultimately lead to the formation of pelvic diaphragm. Okay. Now, so exactly this is the superior view of the pelvic diaphragm. So it is incomplete anteriorly. If you will see, it is having an opening for urethral hiatus and vaginal hiatus. And also in case of in case of females, there are three hiatus: vaginal, rectal, and urethral. In case of males, there will be no vaginal opening or hiatus except urethral. So except that, urethral and rectal hiatus will be present. The principal function of pelvic diaphragm is to give support to the pelvic viscera and has a sphincteric action on the rectum and vagina. If you talk about the function, it is having sphincteric action on the rectum and vagina. It also assists in increasing intra-abdominal pressure during defecation and micturition and pasturation. So we'll talk about the parts, but that pelvic diaphragm important function is to be known. So write down. Pelvic diaphragm provides principal support to the pelvic viscera and has sphincteric action on rectum and vagina. It also assists in increase intra-abdominal pressure during micturition. It also assists. Yes, Dr. Sharma Puneet, levator ani muscle. Yes, yes, we will talk about that. Yes, Sharma, you are right. That levator ani muscle will further divide into three parts and iliococcyges. Yes, we that all are the parts. Yes, you are right. You are right, dear. Yes, you are right. It also assists in increasing the intra-abdominal pressure during defecation, micturition and pasteuration. Okay, done with this. Now the part. So exactly opening, which we have already told, we have opening I have already shown to you. You can see here also we have got the two openings which has been shown, that is levator hiatus opening. One is exactly, this is a superior view, which is again showing the opening. So it is having a hiatus urogenitalis opening and it is having hiatus rectalis opening. So if I am talking about hiatus urogenitalis, it is a triangular gap which is lying in the anterior part, and this triangular gap which is lying in the anterior part, it is in the levator ani muscle of two sides. It is traversing through it traverse urethra in males and vagina and urethra both in case of females. If I talk about hiatus rectalis, it's an opening between the two side muscles of the pelvic diaphragm, which is having an opening for the rectum traversing through it. So these are the openings of the pelvic diaphragm. Now I just want everybody to understand that the muscles of the pelvic diaphragm levator ani is made of three components. It is made of pubococcygeus, it is made of puborectalis and iliococcygeus. So if you will see this image, you can understand that levator ani muscle is made of three components. So it is having puborecta, it is having actually it is having puborectalis, pubococcygeus and iliococcygeus part. So that is very, very important. As you can see here, this is the puborectalis part, this is the pubococcygeus part, and this is the iliococcygeus part. So these are the three parts which is together part of levator ani, and along with the coccygeus muscle. This muscle is the coccygeus muscle. So together they are the parts of pelvic diaphragm. So here also you can see the parts of the pelvic diaphragm of the female has been shown to you. We can see levator ani muscle. So we have iliococcygeus part. So this is the iliococcygeus part. This is also the coccygeus muscle. C for coccygeus muscle. This is iliococcygeus part. This is the pubococcygeus and puborectalis. So this is pubococcygeus and puborectalis. So these are all the three parts of the levator ani muscle. So please write down about this. Yeah, levator ani muscle is having following parts. It is having pubococcygeus part, which is forming pubovaginalis part in case of females, and it is forming puboprostatic part in case of males. The other parts is it forms puborectalis part, and the puborectalis part is arising from the lower part of pubic symphysis and from the superior body. So it is arising from the parts of lower part of pubic symphysis. It is attached to pubic symphysis and it is also emerging with the superior aspect of urogenital diaphragm. Ileococcygeus arises from inner side of ischium from the tendinous arch of and also from the tendinous arch of and also from tendinous arch of obturator fascia, which is attached to coccyx and that of anococcygeal raphe. And other than that, this is levator ani muscle. Other muscle which I want you to tell is the coccygeus muscle. So these together, coccygeus, these together is forming. So called coccygeus muscle, levator ani muscle. This together is forming the pelvic diaphragm. So coccygeal muscle arises from the apex of pelvic surface of ischial spine and sacrospinous ligament. I am from sacrospinous ligament. Now done with this. Now let's talk about the nerve supply of these. So if I talk about, so just write down, then we will move on with the next topic, that is the arteries. So nerve supply of levator ani muscle is from perineal branch of fourth sacral nerve and perineal branch of pudendal nerve. S2 and S3 is the root value. Nerve supply of coccygeus muscle is from ventral rami of fourth and fifth sacral nerve. Fourth and fifth sacral nerve. Done? Done with this. Now I would like to talk about internal iliac artery. Actually, the major arteries which is giving blood supply. If I am talking about the major artery which is giving blood supply to the pelvic structure is the internal iliac artery. So you have to know the important branches of internal iliac artery. So internal iliac artery is a branch from common iliac artery, and common iliac artery gives external iliac artery which is giving. So this is exactly giving here we can see this is external iliac artery, and this will be the IIA, internal iliac artery. So it is having anterior and posterior. This is showing the branches of internal iliac artery. So lateral, sacral, superior, gluteal and iliolumbar. These are the branches from posterior division of internal iliac artery. Rest all the branches like obliterator umbilical artery, superior vesical, inferior vesical, uterine, rectal, internal, pudendal, inferior gluteal. All these are the branches of internal iliac artery. So for your examination, it is important that you should be knowing the branches of internal iliac artery. So quickly write down the branches of internal iliac artery, which is very, very important for you to understand. So write down. So I just want everybody to write down the heading branches of internal iliac artery. Branches of internal iliac artery. So please write down. Any doubt you can ask me. If you are not understanding anything, please let me know. So branches from anterior division. So internal iliac artery has two division, one is anterior division and the other is posterior division. So firstly we will write the branches from anterior division. The branches from anterior division are superior vesical artery, obturator artery, inferior vesical artery, middle rectal artery, internal pudendal artery, inferior gluteal artery, uterine artery in females and vaginal arteries. Obliterated umbilical arteries is also. These are all the branches from the anterior division of internal iliac artery. I just want everybody to write the branches of posterior division also. So done with this, now write down second posterior division branches. So if we are talking about the branches of posterior division, the mnemonic is SIL. SIL. So here S stands for superior gluteal artery, I for iliolumbar artery, and L for lateral sacral artery. So done. So we have done with this. So we have done with the branches also. We have done with the topic of branches of internal iliac artery. Next topic is very important, that is perineum. Next topic which is highly important is the perineum. So what all things you have to study in perineum? So yes, just a minute. Yes, Dr. Sharma Punit is absolutely right. Yes, Dr. Sharma, you are absolutely right. Yes, good one. Yeah. Now, basically, if I am going to summarize the important things to be asked in the pelvis is perineum, you have to know about ischiorectal fossa. You have to know about location of urogenital triangle, anal triangle. You have to know about urogenital diaphragm. You have to know about superficial and deep perineal pouch and the contents of it, and you have to know urinary bladder, urethra. These are the topics which I am going to cover in the perineum, and also rectum and anal canal. So if I am talking of the perineum, it's an anatomical region in the pelvis. It's an anatomical region in the pelvis, and it is located between the thighs, and it represents the most inferior part of pelvic outlet. What it is representing? It is representing the if I talk about the perineum is an anatomical region of the pelvis, and it is exactly located between the thighs and represent the most inferior part of the pelvic outlet. The perineum is separated from the pelvic cavity superiorly by the pelvic floor. So that is important. So perineum is an anatomical region in the pelvis, and it is located between the two thighs, and it is exactly separated from the pelvic cavity by pelvic floor. The boundaries. So the boundaries of perineum is important, and there is two ways to know the boundaries of the perineum. You have to know about the anatomical boundaries, and you have to know about also the not only the anatomical, you have to also know about the bony boundaries. That is highly important for you to know. So that is important. So in practice, if I just tell about the perineum in anatomical terms, it's a diamond-shaped structure, and boundaries can be defined in two aspects. So let me first explain you the anatomical boundaries of the perineum. So the first thing is to know the anatomical boundaries of the perineum. So if I am talking about anatomical boundaries, the anatomical boundaries are anteriorly it is bounded by pubic symphysis, posteriorly by the tip of coccyx, laterally by the inferior pubic rami, ischial rami, and also by the sacrotuberous ligament. If I talk about the roof, it is by the pelvic floor, and the base is by the skin and fascia. Okay. So, anatomical boundaries of the perineum will be anteriorly by the pubic symphysis, posteriorly by the tip of coccyx, laterally by the inferior pubic rami and inferior ischial rami and the sacrotuberous ligament. Roof is pelvic floor and skin. Base is formed by skin and fascia. Anterior aspect is the pubic symphysis, posteriorly is the tip of coccyx, laterally is the inferior pubic rami, ischial spine and sacrotuberous ligament. Now, if I talk about the perineum surface borders, the surface border, it is anteriorly bounded by mons pubis in case of females and penis in case of males, laterally by the medial aspect of thigh and posteriorly by the intergluteal cleft. So, this is about the surface boundary. Now, to better make you understand these borders, I just want firstly see this anatomical boundaries. So, firstly see this image where you can understand the anatomical boundaries. So, in case of anatomical boundaries, you can see if I am talking about anatomical boundaries. So, basically if I am talking about anatomical boundary, anteriorly it is bounded by pubic symphysis. Anteriorly it is bounded by pubic symphysis. In the inferior border by the tip of coccyx and laterally by ischiopubic ramus and sacrotuberous ligament. Ischiopubic ramus and sacrotuberous ligament. This is anatomical boundaries. The bony pubis symphysis anteriorly, coccyx posteriorly, sacrotuberous ligament, ischiopubic ramus laterally. And if I talk about surface boundary, anteriorly in females mons pubis, laterally medial surface of the thigh and posteriorly the intergluteal cleft. Intergluteal cleft. So Joy is asking how is FMC different from other medical college. So Joy is asking how is FMC different from other medical college. So if I talk about UG curriculum, it is not only targeting your academic goals but also targeting your physical fitness, your activity, discipline and many other things which is very important in arms for medical college. So you become more so your activities other than your physical fitness is also paid attention. You have more of seminars and general clubs are connected, so you become more confident speakers if you go through the FMC training. That is important. And if you are in UG, you will become a cadet and you have to join the army, either Air Force, either army or navy. For you have to serve the country for 5 years if you are going for the UG. If PG also, if you are going postgraduate degree from FMC, then also you have to serve the country for at least 5 years. There is a 5-year bond and then you can work as a civilian, but you have to 5 years serve for the country. And you can be posted in a medical college like FMC Pune, but you can also be sent to the borders. Okay, you will get a training in all the fitness that takes place in the Lucknow center. Okay, Joya, is it okay? Joya, is it okay? Okay, so the main content. So I also would like to tell the actually an imaginary line is passed in the from the ischial tuberosity. So this will divide the whole of the perineum into two triangular space. One is the anterior triangular space and the other is posterior triangular space. The anterior triangular space will be the anterior perineum, which is contains urogenital triangle. The posterior part will be the posterior perineum, which contains the anal triangle. So if I talk about anal triangle, it's posterior half of the perineum. It is bounded by the coccyx, sacrotuberous ligament, and there a line is passed from the ischial tuberosity. And if I talk about the main contents of anal triangle, anal aperture is there, external anal sphincters are there, ischioanal fossa is there, which is located laterally to one on either side of the anus. So ischiorectal fossa, one on either side of anus. And we will also talk about ischiorectal fossa in detail. So you can see this is the ischioanal fossa or ischiorectal fossa on either side of anal sphincters. Urogenital triangle is the anterior perineum. It is bounded by the pubic symphysis, pubic rami, and so exactly if we divide the whole of the perineum, a imaginary line is passing through ischial tuberosity. It is dividing the perineum into anterior triangular space and posterior triangular space. Anterior triangular space will contain urogenital triangle which will have the urinary and genital structures. Posterior triangle will contain the anal structures and the ischiorectal fossa and anal apertures. So I just make you understand. So here you can see what I have drawn is an imaginary line. Okay, this imaginary line is passing through which bony structure? Through the ischial tuberosity, and this through the ischial tuberosity, and this will divide the perineum into A for anterior part and P for the posterior part. The anterior part is the urogenital triangular space and the posterior part is the anal triangular space. And we have to know. Yes, yes, Ganeshan. Yes, please say Sundara. Yes, Sundara Ganeshan. Yes, yes, please put your doubt. Yes, dear, please put your doubt. Okay, please write, dear. Yes, dear. Okay. So yes, we have to know the important structures of urogenital triangle and important structures of anal triangle. Basically, what is asked, considering anatomy as important, I will not go into the gynae aspect and obs aspect. But what is asked in anatomy consent is the ischiorectal fossa and their boundaries and the content. You have to know about the pudendal Alcock's canal. You have to know about the superficial and deep perineal pouch and urogenital diaphragm and all. So that is very, very important for you to note down. So let's start. So if I talk about urogenital triangle, it is actually additional strong fascia, that is perineal membrane is there. The membrane has two pouches, superior inferior surface. It is having superficial and deep pouches. So what is perineal membrane? If we want to define perineal membrane, what is it? It's a rough fascicle sheath which is perforated by, if I talk about perineum, it is perforated in males by the urethra and in females by the urethra and vagina. So two structures are penetrating the perineal membrane, both urethra and vagina in case of male. The role of this is to provide attachment of the muscles of external genitalias. Actually, so many muscles are interlacing in the perineal body also. There are 10 muscles and I will give you the list of all 10 muscles. So superficial and deep perineal pouch. See here. So this is the image which is coronal section of the, this image is coronal section of pelvis. So basically this is the image which is coronal section of the pelvis, and to make you understand, I want everybody to concentrate on this image. Okay. So actually there is one space which is called as deep perineal pouch and the other space which is called as superficial perineal pouch. So this is deep perineal pouch, this is this area. So this is the space of deep perineal pouch and this will be the space of superficial perineal pouch. Lower down we have got another layer which is actually the membranous layer of the abdomen. Membranous layer, that is scarpa layer of the abdomen, will continue in the pelvis as the Colles fascia. So we will have two spaces. One is the space which is lying between the inferior fascia of urogenital diaphragm and the Colles fascia is the superficial perineal pouch. Another space is lying between the superior and inferior layer of the urogenital diaphragm, that is deep perineal pouch. And what is important for your examination is to know the content of each of this space. So write down. Another image is there where you can know the two superior and inferior layer of urogenital diaphragm will contain the deep perineal pouch, and lower to it we will have the another space, that is the superficial perineal pouch. So firstly, I want, before coming to the contents, I just want everybody to write down this. Write down deep perineal pouch. It is the space, deep perineal pouch. It is the space lying between superior and inferior. It is the space lying between superior and inferior layer of urogenital diaphragm. Yes, you are right, Dr. Sharma Punit. Yes, you are absolutely right. Yes, you are absolutely right. Superficial perineal pouch. So when I am talking about superficial perineal pouch, when I am talking about the superficial perineal pouch, it is the space lying between, it is the space lying between, it is the space lying between inferior layer of urogenital diaphragm and it is the space lying between inferior layer of urogenital diaphragm and Colles fascia and that of Colles fascia. Yes, dear. The list of important structures, I will give you the list, but I think Dr. Sushant Punit has already given. Very good, dear. Very good, dear. So, this is the space, and actually, this is a coronal section of male pelvis. So, this is the coronal of male pelvis, which is showing you the important structures. Okay, so what you can see here exactly, if I enlarge this, I already told you here that this space is the superficial perineal pouch and this space we are talking about is the deep. So here I just want to write it for you. So this is the space of deep perineal pouch and this is the space of superficial pouch, perineal pouch. So basically you have to know the structures residing. So that means you have to know the structure residing in this space and the structure residing in this space. So exactly you can see in this diagram also important structure. So basically you have got the bulbourethral gland, you have got the membranous part of urethra, you have got deep transverse sphincter urethral muscle, deep transverse perineal muscle, you have got ischio-cavernous muscle and bulbospongiosus lying lower down in the superficial perineal pouch. So basically I will list the structure. So basically content of superficial perineal pouch. So basically let's start with the list, that is the content of, so I have given you the whole list. So I will give you the whole list of the content of superficial and deep perineal pouch, which is highly important for you to know. So basically the content of superficial perineal pouch, the muscles are ischio-cavernous muscle, bulbospongiosus muscle, we have got ischio-cavernous, bulbospongiosus muscle, superficial transverse perineal muscle. So basically these three muscle, other than that there is also erectile bodies, other than that there is erectile bodies and corpus spongiosum and cavernosum. But I want the first three, you should not forget, these are the three muscle as the content of superficial perineal pouch, that is the superficial transverse perineal muscle, bulbospongiosus muscle and ischio-cavernous muscle. Now coming to the contents of the vessels, so we will have okay Punit, I will tell you. Okay dear. Okay. So basically the vessels are posterior scrotal arteries, labial arteries, artery to bulb of penis and urethra. Nerves are posterior scrotal nerves. Other structures may in superficial perineal pouch we have got Bartholin's gland. We have got Bartholin's glands, we have got bulb of penis, we have got crudas of the penis and spongy urethra. These are the contents of the superficial perineal pouch. In deep perineal pouch, the important muscles which you should not forget is these two. the deep external pudendal muscle, the deep external sphincter muscle, and that of deep transverse perineal muscle. So basically these are the, all the muscles are there, but first two is very, very important for you to know that these muscles are the content of deep perineal pouch. The membranous urethra, the bulbourethral gland in males, actually very important. The corresponding structure gland in female is a content of superficial perineal pouch, but in males the bulbourethral gland is a content of deep perineal pouch. The branches of arteries are there and the branches of nerves are there. Now, urogenital diaphragm. So we know that urogenital diaphragm is covered by superficial and deep perineal, superficial fascia and of urogenital fascia and inferior fascia of urogenital diaphragm. But important is to know which two muscle is lying in urogenital diaphragm. The answer is it contains sphincter urethrae and deep transverse perineal muscle. So urogenital diaphragm is containing two muscles, the sphincter urethrae muscle and deep transverse perineal muscle, deep transverse perineal muscle. Now, perineal membrane, if I talk about perineal membrane, it's a thin horizontal layer of dense tough fascicle sheath, and it is actually having two parts. It is having urogenital triangle, superficial deep perineal pouches, and it contains many important structures which we have already written. So, in females, it is having an opening of vagina urethra, and in males it is having the opening of membranous urethra. It is having the opening via duct of bulbourethral gland. Now I just want you to show this image where you can appreciate the perineal membrane. So this is exactly the perineal membrane, which is attached anteriorly to the pubic symphysis. It is also attached to the pubic arch and ischial fibrosity. Now, what is important for examination and MCQ is the structures piercing perineal membrane. So, actually the structures piercing perineal membrane is already written in this image. So, you have to just go with the male and the female image. So, you can compare two images. Actually, this is the schematic diagram of the pouch. Yes, Dr. Perineal membrane. So, Dr. Sarma Punit, perineal membrane is inferior fascia of urogenital diaphragm. Perineal membrane is stretching anteriorly with the pubic arch, and you can see here, this is having perineal membrane is attachment having anteriorly pubic symphysis, and perineal membrane has got an opening of various structure as shown in this image, that is the artery of penis, bulb of penis, urethra, vagina in females. But perineal membrane is actually the inferior fascia which is lying on the urogenital diaphragm. Perineal membrane is forming inferior wall for the deep perineal pouch, and perineal membrane is forming a boundary between deep and superficial perineal pouch. But perineal body is the area where 10 muscles are interlacing. Many muscles of the perineum region are interlacing at a point which is lying close to external anal sphincter, that is called as perineal body. I am coming to that. I have given you an outline, Dr. Sarma. I have given you an outline, and you will understand that perineal body means the muscle which is interlacing there. Perineal membrane means the sheath of separation which is lying between deep and superficial perineal pouch. Okay. So see here. Now I want you, Sarma, please see this image. This is the, can you see the red color circled area? That red color circle area is the location of perineal body. What is it? That is perineal body. So when I am talking about perineal body, you can understand that there are two lateral muscles which is interlacing. We have got deep and superficial transverse perineal muscle. We have got levator ani muscle of both which is interlacing. We have got bulbospongiosus muscle of both. Other than that, also the muscle of this external anal sphincter. So you can see this is external anal sphincter. So all these muscles are interlacing at this red color area. This red color area where many muscles crosses or interlaces, this area is called PV, that is perineal body. Okay, that is called as perineal body. Now, one more diagram is there for making you understand. See here, this is the location of perineal body. See here, this is the location. So you can see here that the transverse perineal muscle, superficial and deep transverse perineal muscle, the levator ani muscle, this is levator ani muscle of both the side. the external anal sphincter muscle, and also the bulbospongiosus muscle of both the sides. So these all muscles are interlacing at the perineal body, and you can see ischio-cavernous muscle is more laterally, it is not interlacing. Many times in the examination this question has been asked, which muscle is not interlacing at the perineal body. So ischio-cavernous muscle is lying on the top, it is not interlacing in the midline structure, that is perineal body. So this structure is basically perineal body, which is lying at the junction of many of the important muscles. So please write on the list. So please write on muscles. Please write on muscles forming perineal body or interlacing in the perineal body. So what I told you, there is a total of 10 muscles. There is a total of 10 muscles. So write down. We have got levator ani muscle of both the sides. So we have got two levator ani muscles of both the sides. We have got superficial transverse perineal muscle. Of both the side. We have got deep transverse perineal muscle of both the side. We have got deep transverse perineal muscle of both the side. We have got bulbospongiosus muscle of both the side. Bulbospongiosus muscle of both the side, and we have got, so how many? It becomes 2, 2, 2, 4, 8. How many? It becomes 8 and 2 more. We have got external anal sphincter muscle which is 1, and we have got longitudinal muscle coat of anal, canal and rectum. So this is also 1. So what it makes? It makes a together of 10. So how many muscles are interlacing? 10 muscles are. So it makes a together of 10 muscle interlacing. So it makes a together of 10 muscles which is interlacing at this position. So perineal body is the junction or interlacing of how many muscle? 10 muscle. Yes, 4 paired and 2 unpaired. Absolutely great, doctor. Absolutely great, Dr. Sharma Dutt. Absolutely great. So before going into the next topic, can we solve 1 or 2 MCQs related to this? Okay. So tell me the answer. Deep boundaries of perineum is all except. 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 So Gajendra, Aradhya. Anyone else? No dear, it was sacrospinous ligament. The right answer is sacrospinous ligament. All these pubic ligaments, sacrotuberous, tip of coccyx was the boundary. Sacrospinous ligament is not forming any kind of boundary for the perineum. Sacrospinous ligament is the right answer. It is not forming any kind of boundary for the perineum. Got it, everyone? Got it, everyone? Following are the paired muscle attached to the perineal body except which of the following muscle is not paired to be attached at the perineal body? All the muscles are paired, but one of the muscle is not paired to be attached to the perineal body. Dr. Sarma Punit Gajendra Arora, Aradhana Arora. So basically, part of sphincter ani, sphincter is the right answer. Sphincter ani is unilateral, it is not paired. Yes, Joy, it is unilateral, it is not paired to be inserted in the perineum. Absolutely correct. So absolutely correct answer has been given with all of you. Absolutely correct. Okay, so can we go into another topic, that ischiorectal fossa is a very important topic which I told you, ischiorectal fossa. So why perineal ward is very important? Because in gynae and all, when you will study, you can see the structure of episiotomy. To enlarge or in vaginal delivery, sometimes the head of the fetus is not coming out. So we have to give a episiotomy incision. In that case, sometimes it can happen that the perineal body is injured. Okay, perineal body is injured in case of episiotomy incision. That is the clinical importance of it. Now, we know that there is an anal triangle, and on either side of anal sphincter, we have got ischioanal canal or ischiorectal fossa. So, what is ischiorectal fossa? So, I will come to that. Firstly, please write down. Ischiorectal fossa is a wedge. It's a wedge shaped. It's a wedge shaped fat filled space situated on each side of anal canal, on each side of anal canal, below the pelvic diaphragm, below So if I talk about this two ischiorectal fossa which is lying below the pelvis, the two fossa communicate on each side behind the anal canal. This helps in dilatation of anal canal during defecation and passage of flatus and fecus. So that is an important passage of flatus and fecal matter is an important function of ischiorectal fossa. So if I talk about the base of the fossa, it lies on the, so basically if I talk about so done with this ischiorectal fossa. Okay, now so the boundaries are important. So basically you can see this area which I am crossing it on. This is the rectal fossa. This is the image of rectal fossa both the side. So basically it is having boundaries. It is bounded by levator ani muscle of both the side medially. Laterally we have got obturator internus muscle, as you can see here. And basically if we talk about the floor which is formed by so floor will be formed by perianal skin, and the apex is formed by the joining of levator ani muscle and that of obturator internus muscle. And we have got roof which is meeting point of the fascia of this important fascias, and posteriorly there will be the sacrotuberous ligament and covered by gluteal muscle structure. So this is all about the boundaries, and it is lying on either side of the anal sphincter. You have to know the contents also. You have to know the contents of ischiorectal fossa also. So firstly write down the boundaries and contents. So please write down boundaries of ischiorectal fossa. So laterally it is bounded by fascia covering obturator internus muscle. Medially we have got levator ani muscle and external anal sphincter. Okay. Posteriorly, if I talk about posterior aspect, if I talk about posteriorly, we have got sacrotuberous ligament, which is also having the covering of gluteus maximus muscle. And anteriorly, it is having the posterior border of perineal membrane. Floor is having the perineal skin is lying in the floor, and the roof is the meeting point of fascia covering, obturator internus, and inferior fascia of pelvic diaphragm. Got it? So this is all about the boundaries of ischiorectal fossa. This is all about the boundaries of ischiorectal fossa. Now coming to the contents of ischiorectal fossa. So basically here we can see the ischiorectal fossa contents. So basically here also we can see the boundaries only. Here I just want the splitting of obturator fascia leads to a space that is called as pudendal canal. So here we have got inferiorly the perineal fascia, and also the boundaries has been shown. Here you can see this is ischiorectal fossa and the content. So it is showing you also the contents of ischiorectal fossa. Okay, so we will have exactly important contents are, we will have pudendal. So basically important contents are ischiorectal pad of fat, internal pudendal vessels is there, and the branches of the nerves will be lying there. So this is showing you the boundaries and also the content. So I just want everybody to write in the contents of ischiorectal fossa. So if I talk about the contents are ischiorectal pad of fat, ischiorectal pad of fat is the content, ischiorectal pad of fat, inferior rectal nerves and vessels, inferior rectal nerves and vessels. Then we have got perineal branch of fourth sacral nerve, perineal branch of fourth sacral nerve, and we have got posterior scrotal and labial nerves. We have got posterior scrotal or labial nerves. posterior scrotal and labial nerves and vessels. So we have got posterior scrotal and labial nerves and vessels. So all these are the contents of ischiorectal fossa. Now, what is pudendal canal or Alcock's canal? As I told you, pudendal canal or Alcock's canal is a space which is lying in the lateral wall of ischiorectal fossa, which is formed by the splitting of obturator fascia. So write down. It is a fascicle canal. Pudendal canal is also called as Alcock's canal. So the pudendal canal and Alcock's canal, please don't get confused. It's a similar thing. Pudendal canal and Alcock's canal is a similar thing. It's a fascicle canal present in the lateral wall of ischiorectal fossa. In the lateral wall of ischiorectal fossa, about 1 inch above ischial tuberosity. Above ischial tuberosity. So you can see here, this is the Alcock's canal or pudendal canal, and you can see inferior rectal nerves and vessel. Pudendal nerve is traversing, which is formed by ventral rami of S2, S3 and S4. So basically it extends from lesser sciatic foramen to the posterior limit of deep perineal pouch. So it is extending from lesser sciatic foramen to the posterior limit of deep perineal pouch. This will be the deep perineal pouch. So write down. Pudendal canal extends from lesser sciatic foramen. Pudendal canal extends from lesser sciatic foramen to the posterior limit of deep perineal pouch. Deep perineal pouch. Pudendal canal is formed by splitting of obturator fascia, which I have written actually. No. So please write down. It is formed due to splitting of obturator fascia. It is formed due to splitting of obturator fascia. It is formed due to splitting of obturator fascia. Got it? Now, pudendal nerve, as you can see, what a structure is the pudendal canal is containing the pudendal nerve, and please write down about pudendal nerve. So I just want you to know about pudendal nerve. Pudendal nerve arises from ventral rami of S2, S3 and S4 nerves. It is arising from ventral rami of S2, S3 and S4 nerves, and it gives various branches: posterior scrotal nerves, dorsal nerve of penis. So all these are the branches from pudendal nerve which is given. So yes, please let me know, are you understanding or not? Yes, let me just check with the students. Okay, so now we are just left with 2-3 topics, then that is rectum, anal canal, and then the urinary bladder. So let's start with the rectum. If I am talking of the rectum, it is actually a continuation of sigmoid colon in front of the sacral vertebra, and below down it becomes continuous with the anal canal. Rectosigmoid junction is indicated. So if I talk about rectosigmoid junction, it is indicated at the level of sigmoid mesocolon. So already talked about. So what do you mean by the word rectus? When I am using the word rectus, it means straight. What do you mean by the word rectus? It means straight. So location of the rectum is, it is located in the lesser pelvis. It is located in the lesser pelvis. Lower 3 piece of sacrum and coccyx is lying there. And Dr. Sharma, Punit, your topic will come, don't worry. I will tell about the urethra part. I will tell you about the membranous and the bulbar part of urethra injury. Okay, so location and extent. So it is in the lesser pelvis, located anterior to the 3 sacral vertebrae and the coccyx, and it is actually 5 inches in length, and lower part of the rectum is called as rectal ampulla. Okay, so you can just see this diagram. This is showing you the female genital section. Okay, so here you can see this is the rectum which is lying posteriorly, and anterior to it is the recto-uterine pouch in female, when anterior to it is lying the uterus. This is the female sagittal section. So direction of the rectum is, if you were talking about the direction of the rectum in the upper third part, so in the upper 1/3 part, the rectum is directed downward and backward. In the middle part, it is directed vertically downwards, and in the lower part, it is directed vertically downwards and forwards. Okay. So these are the overall course of the rectum in the upper, middle, and the lower part. So if I am talking about the upper part, the direction of the rectum is downward and backward. If I am talking about the middle part, its direction is vertically downward. If I am talking about the lower third part of the rectum, it is directed downward and forward. Okay, so this is about the direction of the rectum. Upper part downward, backward, middle part vertically downward, and lower part is slightly down and forward. Antero-posterior. So actually in the rectum there is perineal curvatures, there is antero-posterior curvatures are there. So sacral curvature. So antero-posterior curvature we have got sacral curvature, and if I am using the word sacral curvature, it is corresponding to the concavity of the sacrum and coccyx. So it is, if we talk about sacral curvature, it is corresponding to the concavity of sacrum and coccyx. If I talk about perineal curvature, it is corresponding to the backward bend which is occurring at the level of anorectal junction, and it is maintained by a sling. What is the name of that sling? That sling is maintained by the puborectal sling of levator ani muscle. So that is maintained by puborectal sling of levator ani muscle, which is important for you to note down. So antero-posterior curvature, we have got two curvature, we have got sacral curvature and we have got perineal curvature. Other than that, we have got also the lateral curvatures in the rectum. So see this image here, antero-posterior curvature, one is the sacral curvature and this is the perineal curvature which is maintained by anorectal sling. So we have got upper lateral curvature, we have got middle lateral curvature and we have got lower lateral curvature. So these are the lateral curvatures of the rectum. So in this image, we can appreciate not only the anterior posterior curvatures, we can also maintain the lateral curvatures. So here I just want you to tell that puborectal sling is maintaining the continuity of the rectum. So we have got the perineal curvature which is exactly lying at the level by puborectal sling. So this is maintaining the perineal curvature. Now lateral curvature. So if I talk about lateral curvature, how many curvatures I have told you? In case of lateral curvatures, we have got 3 curvatures. So if I am talking about the lateral curvatures, we have got three curvatures. We have got upper, middle and the lower lateral curvatures. How many curvatures, dear? We have got upper, lateral and middle curvatures. Everyone, if you want to have any discussion, if you are not understanding anything, please let me know. Okay, dear? Upper lateral curvature is there, middle lateral curvatures and lower lateral curvatures. So upper lateral curvature is at the level of S3 and S4 sacral vertebra junction. Okay, Gajendra. Okay, Gajendra. Just we have got another 40 minutes I will take for completing it. Okay, is it okay, Gajendra? So middle rectal curvature is at the level of sacrococcygeal junction and lower lateral curvature is corresponding to tip of coccyx. Middle rectal curvature is at the level of sacrococcygeal junction. Lower lateral curvature is at the level of coccyx. Middle lateral curvature is on the left hand side and other two are on the right side. So upper one S3 S4 junction, middle rectal is at the level of sacrum and coccyx junction, lower is at the level of tip of coccyx. The curvature upper lateral S3 S4 S4 junction, sacrum and coccyx, sacrum and coccyx junction, and lower is at the level of coccyx base. Now, if I talk about the peritoneum covering, it is important for you to note down the peritoneum covering of the rectum can be understood by dividing the entire rectum into three parts. So, if this is exactly showing you the peritoneum in respect to the rectum. This is the peritoneum. So, if we talk about peritoneum, so see here in the so basically this is the peritoneum covering. So in the upper 1/3 part, peritoneum is covering the anterior and the lateral part of the rectum. Okay. In the middle part, it is only attached onto the rectum and there is no peritoneum. There is no peritoneum in the lower part covering of the rectum. No peritoneum in the lower 1/3 part. Now relations, so we will have anteriorly in males, if I talk about the perineum, if we talk about the relations of the rectum anterior aspect, inferior and lateral, to be more specific, I would like to tell the relation both in males and females, because slightly that relation will vary because we have got uterus in between the urinary bladder and rectum in case of females. So anterior aspect in case of males, we have got the bladder, we will have the ureter, prostate, seminal vesicles. In females, we will have also vagina and rectovaginal septum. Inferiorly, both will have piriformis muscle and laterally, both males and the females will have sigmoid colon and terminal part of ileum. So basically, the relation which varies is in the anterior aspect. In males, it is related with prostate and seminal vesicle and ureter, and bladder in females, bladder, ureter, vagina and the septum. With septum, rectovaginal septum. So rest lateral and inferior relation is same for male and female, but anteriorly the relation slightly varies. Now you can see here, this is again this is the male sagittal section. This is the male pelvis sagittal section, and here you can see the rectum is anteriorly related with, as you can see in this diagram, it is a seminal vesicle. It is related with the vas deferens seminal vesicle in the anterior aspect. Now, this is an image where you can appreciate the posterior relation. When I am talking of the posterior relation of the rectum is similar on both the sides. So, write down the heading, posterior relation of the rectum. So basically posterior relation is same for both the rectum in males and the females. In midline only the relation is this, the posterior relation is divided in the relation in the midline and the relation in the each side. So in midline it is related with median sacral vessels. So you can see median sacral vessels, and lateral side lateral sacral vessels are there. Okay. Superior rectal artery is in the again in the midline. Lower 3 piece of the sacrum is there. Ganglion impar is there. Coccyx anococcygeal raphe. So we have also got the anococcygeal raphe in the midline. Other than that, in case of lateral side posterior relation, we have got piriformis muscle, levator ani muscle, coccygeus muscle. The nerves which is lying laterally is with the, we have got anterior primary rami of the nerves. We have got pelvic splanchnic nerves, coccygeal nerves. All these are the nerves which is related on the lateral side. So this image is the schematic diagram showing you the relations, posterior relation, the rectum, both in the midline and also in the lateral side. Now coming to the next, transverse folds of the rectum. When I am talking about transverse folds of the rectum, the transverse folds contains Houston valve or the Houston valve. So there is Houston valves which is lying inside the rectum. And what is the importance of this transverse folds or Houston valve? It is important for maintaining it is important for holding the fecal matter. The importance is it is semilunar transverse folds in the rectal wall which is protruding inside the lumen of the rectum, and it is why input is important. It is important for holding the fecal matter. So it is supporting the fecal matter and prevent the urge towards the anus, which produces strong. When it travels down, it produces an urge to defecate. These folds are 12 mm in width, and basically we have got 3 folds. Sometimes there can be 4 rectal Houston valves also present. Most of the time there are 3, but at times there can be 4. So we have got the one which is situated in the right side upper, then second is opposite the middle of the sacrum, and we have got the third which is lying backward, and we have got the fourth which is lying on the left hand side in the posterior aspect. So basically you can see this is showing you the image of Houston valves, rectal valves or Houston valves. So we have got superior rectal valve, we have got the inferior rectal valve and the middle rectal valve, which is important for holding the fecal matter. Arterial supply. So basically if I talk about the arterial supply, we have got the rectum supply by the arteries like superior rectal artery, middle rectal artery, inferior rectal artery, and sometimes by median sacral artery. Here we know that superior rectal artery is so we already know the superior rectal artery is a terminal branch of inferior mesenteric artery. Middle rectal artery is a branch of anterior division of internal iliac artery. And here we can see the arterial supply, that is the superior rectal, middle rectal, inferior rectal artery. And we know that inferior rectal artery is a branch from the internal pudendal artery. So this is very important for you to note down. Inferior rectal artery is a branch of internal pudendal artery. Median sacral artery is the fourth source of arterial supply. Mainly superior rectal, inferior rectal and middle rectal arteries are the arterial source of blood supply to the rectum, but there can be a fourth source from median sacral artery, which is a terminal branch of abdominal aorta. Venous drainage is corresponding to that of the arterial supply, and there is venous plexus, which is a common site for portovenal anastomosis. So we have got superior, inferior and middle rectal vein. So here superior rectal vein, if we talk about, superior rectal vein is draining into inferior mesenteric vein, middle rectal vein in internal iliac, and will also drain by inferior rectal will drain into internal pudendal and then into inferior internal iliac vein. So we have got internal iliac vein, ultimately they are draining. We have got middle rectal vein, we have got superior and inferior rectal vein which is draining and which is actually the tributaries, and this forms a source of portocaval anastomosis. The innervation. Upper part of the rectum is innervated by inferior mesenteric innervation. Middle and lower part is via superior inferior hypogastric plexus. Lymphatic drainage. So the upper part drains into, if we talk about the lymphatics of superior, drains into inferior mesenteric group, and if we talk about the lower part, it is draining into internal iliac group of lymph node. So basically everything is detailed here. If I have to summarize what is asked in rectum is the posterior relation, you have to know about the arterial supply and the venous drainage of rectum, because that is a source of portocaval anastomosis. Lymphatic drainage has been shown, and lowermost part of anal canal will drain into superficial inguinal lymph node. Now, I would also like to give you briefly about rectal prolapse. Actually, rectum is well supported by the fat. There is enough fat in the ischiorectal fossa which is supporting the either side of the rectum, but at times in a chronic constipated case or in case of injury to the spinal cord, the rectum prolapse can open. It can be of various degrees. So rectal prolapse reason will be long history of constipation, old people's, any kind of vaginal delivery complications, spinal injury. So we have got three types of prolapse. One is external prolapse. When I am using the word external prolapse, means the entire rectum is stucking out of the anal verge. If I am talking about mucosal prolapse, means a part of the rectum lining is protruding outside the anal. Internal is rectum has started to protrude out, but it is not seen coming out from the anal opening. So these are the three categories. There is quite common ischiorectal abscess is there, and actually if I talk about ischiorectal abscess, so basically at earlier times that is not so painful because there is a space for the dilatation of ischiorectal abscess, but when it can also form fistulous, it can also form communication internally and outside. In that case, the rectal fistula is formed. If it is blind end, then it will be a rectal sinus. So also you can see that anal fistula is formed, and if it is communicating both internally and externally. The next topic is anal canal. So anal canal, basically what is asked in examination is the difference between upper part of anal canal and the difference between lower part of anal canal. So anal canal is basically, anal canal is lying within the anal triangle of the peritoneum, and it is exactly lying between the right and the left ischiorectal fossa. What is exactly the location of anal canal? It is lying between the two side ischiorectal fossa. We have already talked about the boundaries and the content of ischiorectal fossa. It's a final segment of GI tract, and the canal begins at the continuation of rectum and then ends at the anus. Okay, and I will give you the anatomical facts which is required for the anatomy of anal canal. So basically, anterior relation, it is related with perineal body, and basically everybody is knowing this. Perineal body is which area? Anteriorly, anal verge, it is known to you, it will be having perineal body. 10 muscles are interlacing at the level of perineal body. There is urogenital diaphragm which contains sphincter urethrae and deep transverse perineal muscle. Other than that, we will have anteriorly, we will have the urethra and bulb of penis. Posteriorly, two structures are lying. Posterior relation of anal canal, we have got two structures. We have got coccyx and the sacrum, two parts of the of the vertebral column. We have got anococcygeal raphe. These are the two structures which is related in the posterior aspect of anal canal. So I just want you to show this image. This is a schematic diagram, and actually in the interior of the anal canal, you can see there is anal column. These are anal column. The lower part of anal column is formed by anal valves, and line corresponding to this level is called as pectinate line. So this is the upper part and this is the lower part of anal canal. The upper part of anal canal is endodermal in origin. The lower part of anal canal is ectodermal in origin. Lower part of the anal canal, there is white line of Filton which is corresponding to mucosal skin junction, mucosa and skin junction, which is a black line, and the lowermost part is anal orifices. Actually, there are too many differences between the upper and the lower part of anal canal. So let's know about that. So here also you can see another image where you will see these are anal columns. These are anal columns, and these are exactly surrounded by internal and external anal sphincters. So a line passing through the anal column sinuses is called as the pectinate line. which divides it into upper part and the lower part, and there is quite much difference in the anal canal, upper and lower part anal canal. So basically all the differences I have written. Basically it's very important for you to understand what are the difference between the upper and the lower part. So let's start with this. So the first point is arterial supply. Above the pectinate line, the arterial supply is via, above the pectinate line, the arterial supply is via superior rectal artery, and we know that superior rectal artery is a continuation of which artery? Inferior mesenteric artery. The lower part is having the blood supply from middle. So basically upper part is from superior rectal and middle rectal artery. Middle rectal artery is branched from the anterior division of internal iliac artery. Below the pectinate line, the arterial supply is via inferior rectal artery, and all of us knows that inferior rectal artery is a branch of internal pudendal artery. Venous drainage. Upper part venous drainage is corresponding. If I talk about upper part, the upper part venous drainage is corresponding to that of superior rectal vein, and which drain into inferior mesentery. Below it, it corresponding to inferior rectal vein, which will correspond to internal pudendal vein. So both of these, upper part is forming the part of portal venous system, and the lower part, which is draining into internal pudendal, forming the part of systemic venous system, and there can be a chance of portocaval anastomosis in this region. Above pectinate line, it is developing, it is endodermal in origin, it is developing from embryonic hindgut. Below pectinate line, it is ectodermal in origin, it is developing from ectoderm of proctodeum. So these are the differences between upper and the lower part. The superior aspect of anal canal has the name. So other than that, if I talk about the superior part of anal canal, its lining epithelium is columnar epithelium. And below pectinate line, the lining epithelium of anal canal is non-keratinized stratified squamous epithelium. Non-keratinized stratified squamous epithelium. Anal sphincter. So as I told you, there is a internal anal sphincter and there is external anal sphincter. So external anal sphincter is again having three parts. So internal anal sphincter, if I talk, what is the importance of these? So these external and internal anal sphincter is very important for maintaining fecal continence. It's very important to maintain fecal continence. Internal anal sphincter surrounds the upper 2/3 of anal canal, and it is formed by the thickening of circular smooth muscle in the bowel wall. It is formed by the thickening of the muscle wall only, and it is surrounding the upper 2/3 of anal canal. So you can see this diagram where you can see, here in this diagram we can see the three parts of external anal sphincter, that is deep, superficial and subcutaneous. This is showing you deep, superficial and subcutaneous. And the upper part, here you can see internal anal sphincter, which is basically the muscle coat only forming and surrounding the upper 2/3 of the anal canal, which is the internal sphincter. So internal sphincter is not having various parts, but external anal sphincter is having three parts: subcutaneous, superficial and deep. External anal sphincter is surrounding the lower part of anal canal. It blends with the puborectalis muscle. And exactly what is the importance of this external and internal anal sphincter is to maintain the fetal continence. Hemorrhoids. I would also like to tell about the hemorrhoids. Actually, hemorrhoids are is a vascular cushion, and which is helping, and if it is become distended, and it can also be at times pathological bleeding can happen. So basically there are two types of hemorrhoids. One is the secondary hemorrhoids and other is primary hemorrhoids. So primary hemorrhoids are corresponding to three locations, that is 3 o'clock, 7 o'clock and 11 o'clock position. So pathological hemorrhoids is seen in the people's in those individuals, they are having a long-term constipation history, straining while defecating, and increasing pressure is required while defecating. Intra-abdominal pressure is like in case of ascitic patient or pregnancy condition, and this leads to hemorrhoids, and which is located primarily in the location. So they are primary hemorrhoids at the location of 3 o'clock, 7 o'clock and 11 o'clock position. So you in this diagram, I just want everybody to see the primary. So this is the diagram which is showing primary hemorrhoids location. So there is 3 o'clock position, 7 o'clock, there is 3 o'clock, 7 o'clock and 11 o'clock position. So hemorrhoids at this location are termed as primary hemorrhoids, and hemorrhoids other than this location is called as secondary hemorrhoids. So basically 3 o'clock position is corresponding to, if we talk of 3 o'clock position, it is corresponding to left lateral position, and right anterior position is corresponding to 11 o'clock position, and this is the position of right posterior, which is corresponding to 7 o'clock position. These are the three primary hemorrhoids location which has to be known to you. Other than that, I would like to tell, so we have finished with this, and quickly we will solve few MCQs related to this, and we'll move on to the last topic of the pelvis, that is urinary bladder and urethra. Is it okay, everyone? Okay, so let's. Inferior rectal artery is a branch of which artery? Anyone? Inferior rectal artery is a branch of which artery? Inferior rectal artery is a branch of which artery? Inferior rectal artery is a branch of which artery? Aradhana Arora is selling C, and C is the right answer. Inferior rectal artery is a branch of internal pudendal artery. So absolutely correct. Aradhana, you are absolutely correct. Internal pudendal artery. So Aradhana, thumbs up for you. Superior rectal artery is a continuation of which artery? Superior rectal artery is a continuation of which artery? Superior rectal artery is a branch or continuation of which artery? Absolutely correct, Aradhana. Absolutely correct. It's the inferior mesenteric artery. Yes, you are right. It's the inferior mesenteric artery. Again, a thumbs up goes for you. Again, a thumbs up goes for Aradhana. So now coming to the last topic of today's session. So now I am coming to the last topic of today's session, urinary bladder and urethra. Is it okay? So let's see. First thing is urinary bladder. If I am talking about urinary bladder, it is located in the lesser pelvis. It is located in the anterior part of the lesser pelvis. I just want to show you. This is exactly the outline of urinary bladder, and exactly you can see it is located in the anterior part of the lesser pelvis, and it is exactly located immediately posterior to which bone? Pubis bone. Anterior to it lies the pubis bone. So it is lying posterior to pubis bone. It is lying posterior to pubis bone. It is lying posterior to the pubis bone. And posterior to the uterus, posterior to the urinary bladder, we have got the uterus in case of females, and also most posterior structure is the rectum. Now write down here, this was the female pelvis in which the urinary bladder is seen, and in case of male pelvis, see here, in case of males you can again see the outline of urinary bladder, tetrahedral in shape, surrounded lower down by the prostate gland, anterior to that of the rectum, as you can see in the diagram. And posteriorly, if you will see here, we have got the structures like prostate gland and seminal vesicle ejaculatory duct, and these are all the structures related to the urinary bladder. This is a schematic diagram to make you understand in the male pelvis. So you can see this is the urinary bladder, which is posteriorly related to seminal vesicle, prostate gland surrounding the neck area of the urinary bladder, rest, and we have a seminal vesicle and vast difference in the posterior aspect. So please write down the details. So all of you, please write down the details. Write down the heading urinary bladder. Urinary bladder is located in anterior part of lesser pelvis, immediately behind the pubic symphysis. And in front of rectum in case of males, in front of rectum in males, and uterus in females, When empty, urinary bladder lies in the pelvis. So basically, when the urinary bladder is empty, it lies in the lesser pelvis, and when it is so when empty, urinary bladder lies in the lesser pelvis and located exactly, it is when it is expanded, it is located in the abdominal cavity. So when empty, urinary bladder lies in the lesser pelvis, but when full, it is can go upward in the abdominal cavity. Now we should also know about the capacity of urinary bladder. So normal capacity is 120 to 320 ml, and generally by 220 ml there is a desire to micturate. And normally the micturation is occurring between 250 to 300 ml. The micturation occurs. Okay. Here I just want everybody to see this image and to understand that this is the urinary bladder which has been shown. So basically in the urinary bladder we have got superior surface, we have got the apex to which the urachus is attached, we have got the posterior surface on which posterior surface in case of males is having seminal vesicle and vas deferens. We have got the neck in males surrounded by the prostate gland. We have got the two infrolateral surface. This is also showing the superior surface and borders, and so we have got superior surface, we have got two infrolateral surface, this is the apex, this is the base posterior surface, and this is the neck of urinary bladder, and we have got two infrolateral surfaces also. So what is important for us to know is the relations of urinary bladder. So let's talk about the relations. So please write down urinary bladder. Heading is relations. So we know that urinary bladder is having apex, it is having base, it is having infrolateral surface, it is having superior surface, it is having infrolateral surface, it is having superior surface, apex, base, and it is having four borders. And two lateral. Now write down about the relation. So first thing is to know about the apex. So apex of urinary bladder is providing attachment to urachus And what is urachus? It is the remnant of allantois. It is connecting the apex of the urinary bladder to umbilicus. So, apex of the urinary bladder provide attachment to, which you already know, median umbilical ligament. And we know that medial umbilical ligament is a remnant of urachus. So many times I have told you in the first topic also I have told you it's a remnant of, it is the remnant of urachus. The second part. So done with this. Now coming to the base. The base is also called as the posterior aspect, and it is directed in males. So in males, if I talk about the base, it is related to rectovesical pouch, which contains coils of small intestine in the upper part, and lower part in males it is related to vas deferens seminal vesicle. Together these two forms the joints and forms the ejaculatory duct, and this is separated from the rectum by rectovesical fascia of Denouville. So I just want, this is the urinary bladder showing important surface. So the neck is surrounded by the prostate gland, and this is the posterior surface. This is the apex which is related to the median umbilical ligament, which is obliterated umbilical artery. Okay dear. Now I just wanted to show, this is the apex which is shown here. This is the neck which is surrounded by the prostate gland, and this is the posterior surface. Now just now I told you this is a schematic diagram to show you the structures related on the posterior surface of urinary bladder. So what I have shown you and what I have told you, the posterior aspect of urinary bladder in case of males are related to seminal vesicle. So this is what, this is the seminal vesicle which is lying laterally. Medial to it is the vas deferens, that is called as ductus deferens. Seminal vesicle and ductus deferens both joins to form the ejaculatory duct. So you can see the vas deferens is lying medially and the seminal vesicle is lying laterally, and both so here we can see clearly that this structure is the vas deferens. The vas deferens will be joining with that of the vas deferens will be joining with that of the seminal vesicle, and both of which will join to form the ejaculatory duct, which is related to the posterior aspect. So here I just want to write that is important for you to note down. So the triangular area between vas deferens is separated from the rectum, by rectovesical fascia of Denouville. Now, this was the relation of the posterior surface in males, which we have talked about in females. So this is the relation. So we have done with the apex, we have done with the base, but I was talking about the base in case of females. In case of males, in females you can write, in females the posterior surface of urinary bladder is separated from cervix, the cervix of uterus by vesicouterine pouch, by vesicouterine pouch, by vesicouterine pouch. By vesicouterine pouch. Okay. Done. The neck of urinary bladder. So write on next. Neck of urinary bladder in males is surrounded by prostate gland. Is surrounded by prostate gland. In females, neck of urinary bladder is related to urogenital diaphragm. So done. Now, so we have done with this. I would also like to talk about few more important relations which has to be known to us. So here you can just write on superior surface. Superior surface is related to the peritoneal cavity. It is related with coils of ileum and jejunum. Coils of ileum, sigmoid colon, and also it is related with uterine cervix in females. So this is the relation of superior surface of urinary bladder. Now coming to the relations of anterior surface of urinary bladder. So anterior surface of urinary bladder is related to rectopubic space. It is related to retropubic space, and it is related to puboprostatic ligament. Prostatic ligament. And anterior surface is also, it is related to retropubic space, puboprostatic ligament is also related with obturator internus muscle and levator ani muscle. Now I would like to slightly brief you about retropubic space of Ridgius. Actually retropubic space is also called as space of Ridgius. So I just want you to show that space. So if you will see this diagram, you can see relation of infralateral aspects of urinary bladder. So we will have so basically relations of infralateral surface on the anterior aspect. Basically here I just want relations of infralateral surface anterior aspect. So please write down basically clearly this. You can get confused by this. Please write down. So here we have got infralateral surface anterior relation is via infralateral surface anterior relation is by retropubic space, and puboprostatic and obturator internus is more posteriorly in the infralateral surface. Okay, please don't get confused with this. Now you can see this is the urinary bladder and it is related on the anterior aspect. It is related on the anterior aspect laterally by the retropubic space of Ridgius, right? And more posteriorly laterally we have got obturator internus also. Now this is the retropubic space of Ridgius, and I just want everyone to know about the boundaries of retropubic space. You can see this. This is exactly the space of Ridgius which is lying on the urinary bladder infralateral surface. So just in brief know about retropubic space. So this is the cadaveric image, and in this cadaveric image you can see in relation to urinary bladder we have got the space of Ridgius which is called as retropubic space of Ridgius, which is called as the retropubic space of Ridgius. Now let's talk about retropubic space of Ridgius. So briefly we will know about retropubic space of Ridgius. It is actually perivesical space. Anteriorly, it is having posterior aspect of pubic symphysis. Anteriorly, if we talk about the boundaries of retropubic space, it is bounded by posterior aspect of pubic symphysis. Posteriorly, it is related with the infralateral inferiorly, it is related with puboprostatic ligament and pubovesical ligament. Superiorly, reflections of peritoneum. So done with this, we have done with this. Now it's important to know about the ligaments. So okay, we will not now talk about the ligaments. So important ligaments of urinary bladder, actually very important is to know about the ligaments name, and it's important for us to know about one of the important ligament, that is posterior ligament, which is containing vesical venous plexus. So exactly ligaments of urinary bladder has been shown. So there are two types of ligament, one is false and other is true. So basically false ligament are the peritoneal folds, but here they are basically showing the true ligament. So posterior ligament is there, lateral ligament, lateral medial ligaments are there. So I just want you to know about peritoneal fold. We have already talked in so many sessions previously also. We are knowing that important fold, so I am not going once again in the details of that. But I want everybody to write the true ligaments of urinary bladder. So write on ligaments of urinary bladder. So basically we are talking about true ligaments. So what is true ligament? You have to understand, when I am using with the word true ligament, it is the condensation of pelvic fascia. Exactly, true ligaments are condensation of pelvic fascia around the neck and the base of urinary bladder. So this is formed by condensation of pelvic fascia. This is formed by the condensation of pelvic fascia around neck and base of urinary bladder. Now neck and base of urinary bladder. Okay. So the ligaments are, so just write down the name of the ligaments. The ligaments are lateral ligament, which is 2 in number. We have got puboprostatic ligament, which is again you can say 4 in number. Why? Because 2 lateral and 2 medial. We have got 2 lateral and we have got 2 medial. We have got median umbilical ligament. We have got posterior ligament. Posterior ligaments. Actually, posterior ligament is very important, which is 2 in number. Why? Because it encloses. Posterior ligament is very important. Why? Because it encloses. What does it enclose? It encloses vesical venous plexus. It encloses plexus. It encloses vesical venous plexus. That is the reason it is very, very important. Now, my dear students, let's see the interior of the urinary bladder. So, when you see the interior of urinary bladder, you can see 2 ureters are opening interiorly, and there is also urethra which is communicating. So, this two openings of ureter and lower down urethra opening, if they are connected, they will lead to the formation of trigone. The lining epithelium of urinary bladder and ureter is transitional epithelium. What is it? It is transitional epithelium. So I just want you to see the interior. So when you see the interior, you can see there is two ureteric orifice. So please see, here we have got two ureteric orifice, and lower down there is an opening of urethra. There is internal urethral orifice, and then if we connect here, there is a line. If we are connecting this, so if we are connecting this to ureteric opening, this line is called as interureteric bars of Merces. If we connect urethra and the ureter, this is lateral and this is called as Bell's bar. So interiorly we will have an opening of two ureters superiorly and urethra lower down. So two ureters are connected by the bar of ureteric orifice. Two ureteric orifices connected by bar of Merces, interureteric ridge, and the urethra and ureter opening is connected by interuretro-urethral ridge, which is called as Bell's bar. Now let's talk about arterial supply. The important arterial supply is via the branches of the superior inferior vesical artery, and please write down arterial supply of urinary bladder. So arterial supply of urinary bladder is, it is supplied by following arteries: superior and inferior vesical artery, superior and inferior vesical artery, obturator artery, inferior gluteal artery, vaginal and uterine artery. These are important source of arterial supply to urinary bladder. Venous drainage. So important veins draining are the plexus. So exactly we will have vesical venous plexus in the posterior ligament. So we will have vesical venous plexus in the posterior ligament. The vesical venous plexus is communicating with prostatic plexus in males and with the veins in the base of broad ligament in case of females. So please write down. Vesical venous plexus. This communicate in males with puboprostatic venous plexus, and in females it communicates with veins in the base of broad ligament. Veins in the broad ligament. Done? Okay, so that is important. So basically that are all important which you have to know. Lymphatics is basically it is draining into external iliac lymph node. External iliac lymph node. Lymphatics, it is draining into external iliac lymph nodes. Some lymphatics will be into the obturator nodes and also to the internal iliac lymph nodes. Nerve supply. Most important topic is the nerve supply in the urinary bladder. Let me enlarge it. So if I am talking about the nerve supply, it's most important is to know the nerve supply, which is a highly important for you, is to know about so exactly if I talk about urinary bladder, you have to know about its nerve supply, that is sympathetic, parasympathetic, and that of somatic. So sympathetic is by T11, T12, L1 and L2, which is exactly if I talk about the sympathetic innervation is exactly it is exactly it is a negative to the detritus muscle, and it is contracting the internal urethral sphincter. That means sympathetic innervation is widening of urine. Parasympathetic, which is formed by S2, S3 and S4, it is important for micturition of urine, which is having positive effect, that is contraction of detritus muscle and relaxation of internal urethral orifice. And pudendal nerve is just having innervation, it is a voluntary control, it is a somatic innervation which is having voluntary control over external urethral sphincter. So only we can have a voluntary control on urination. So write down about nerve supply. So nerve supply, parasympathetic is via pelvic splanchnic nerve, nerves, S2, S3, S4, which is important for micturition to occur, which causes micturition. Why micturition? It is contracting the detritus muscle and it is relaxing the internal urethral orifice. So when I am talking about micturition to occur, that means parasympathetic is on the detrusor muscle, it is positive contracting, and on the internal urethral sphincter, it is negative, it is relaxing. So that is how the micturiation occurs. Just reverse of this is sympathetic, which is causing widening of urine, which is by T11, T12, L1, L2, and it is causing widening of urine, which is exactly negative on detrusor muscle and internal urethral sphincter, it is positive. That means it is important for widening of urine. And so this is about sympathetic, this is about parasympathetic. I would also like about to the third is somatic. So here you can write down the third, which is somatic, which is via pudendal nerve, and which is positive on external urethral orifice, external urethral sphincter. So I have written in short, but I think this image enough is for you to understand. So when you see this image, enough is for you to understand. You can see the pudendal nerve having the root value S2, S3 and S4, which is formed by anterior primary rami of S2, S3 and S4, which is having an effect on external urethral sphincter. It is having voluntary control. Other is autonomic innervation, which is sympathetic and parasympathetic. Sympathetic is important for micturition to occur, and parasympathetic is important for micturition to occur. Sympathetic is for widening of urine. When I am telling micturition to occur, urination to occur, what does it mean? It means there will be contraction of detrusor muscle and there will be relaxation of sphincters, internal urethral sphincter. Now, clinical aspects. So, one of this case is trabeculated bladder. So, when I am using the word trabeculated bladder, actually this is the result of chronic obstruction of urine. So as you can see, if I just enlarge this, you can see this is a case of trabeculated bladder. So chronic obstruction of urine occurs if there is an enlarged prostate gland, if there is a strictures to the outflow of urine, there is chronically accumulation of urine that will cause hypertrophy or distended musculature of the urinary bladder. You can see the muscle fibers are directed and weave-like appearance in the internal musculature of the urinary bladder. So that is, so this will cause the bladder become distended and musculature hypertrophy, and causes musculature hypertrophy. Trophies, and the muscle fibers are going in different directions. So they are traversing in different direction. The next is suprapubic cystotomy. So in case of suprapubic cystotomy, what happens? We use this procedure for the extra peritoneal approach to open the uterine cavity. To open the urinary bladder. So catheter is inserted. Actually, firstly, the urinary bladder is filled up with fluid. If it is filled, so we have to approach the urine through extra peritoneal approach. So that is important. So that is the case. So we will have an extra peritoneal approach. So in this case, it is used in case of intravesical stones. It is used in case of intravesical stones. Distend the urine with 300 ml of fluid. Distension is done, and then the urinary bladder is approached. And in that case, it can be approached via anterior abdominal wall without injury of important structures. It can be approached. So that is exactly the key features of this suprapubic cystotomy. Now, okay, now I just want you to tell about the last important point, that is of neurogenic bladder. So injury. So neurogenic bladder, we have got two types of injury as the neurogenic bladder. One is autonomous bladder, another is automatic reflex bladder. So exactly the injury, micturition is essentially a reflex which is controlled by sympathetic, parasympathetic and motor supply. So if there is a two conditions are there, if there is injury, complete transaction of spinal cord occurs above the micturition center, that is S2, S3, then in this case the automatic reflex bladder will be. Other than if the only the spinal, if the lower micturition center is involved, that is S2, S3, then the condition will be autonomous bladder. So we have got autonomous bladder, and autonomous bladder results from destruction of S2, S3 and S4, that is lower micturition center, that is lower center of micturition. So in this condition, what happens, the clinical finding will be that the bladder wall is flaccid, capacity increases, and there is continuous dribbling of, urine. So exactly, there is actually what happens, the reflex and nervous control of micturition center is not functioning. So the bladder wall capacity is greatly increased. So the urinary bladder capacity is greatly increased. So it fill up. So the filling is going on, and when it fills at a particular level, and then there will be dribbling of urine. This kind of bladder is called autonomous bladder. The other kind of injury is automatic reflex bladder. Actually, this happens due to the injury of actually this result in due to complete, in cases of complete transection of the spinal cord above the level of micturition center, So in this case, what happens? Now the level of injury is above. So in this, what happens? Actually, if we talk about this feature, so basically the pyramidal control is lost. Upper motor neuron pyramidal control is lost, and there will be voluntary inhibition and initiation of micturition is lost. So voluntary inhibition and initiation of micturition is lost. So basically what happens, the bladder will reflexively filled with a rhythm of like 1 to 4 hours, and then it will be the micturition will be done. So reflex kind of thing. So basically it occurs like early infancy. The bladder will be behaving like an automatic reflex bladder, and it will reflexly empty urinary bladder in every 1 to 4 hours. The cycle goes, and it reflexly fill and empties, fills and then empties. So the bladder, for example, in early infants also, what happens, the urinary bladder fills and it empties, because there is no upper motor neuron control on the urinary bladder micturations. So that is the reason. So we have done with this last topic also. Now other than that, just urethra. So actually, just let me show. Yeah, one of the student has asked me about that. So one of the student has asked me about the injury. Dr. Sharma. So bladder. So basically male urethra is having different parts. Male urethra is having prostatic urethra, membranous urethra, bulbous urethra. So basically the narrowest part or the least dilatable part is that of membranous urethra, the part of urethra which is lying beneath. So it's exactly, if you talk about part of urethra which is lying beneath, inside the prostate gland is prostatic urethra, within the urogenital diaphragm is membranous urethra, and the rest part in the penis is spongy urethra. So if we take a transverse section, we can see the shape of prostatic urethra horizontal, star shaped is the cut section of membranous urethra, and the spongy urethra which is long 15 centimeters and long. It cut at 3 level. In the body it is in the body it is transverse slit, in the bulb it is trapezoid, and at the level of external urethral sphincter it is just like a vertical slit. So most dilatable part is the prostatic urethra, least dilatable part is the membranous urethra. And I just want you to show this is the this is the part of the urethra which is lying inside the prostate gland. So this is prostatic urethra, which is on cut section it is horseshoe shape, membranous. Other than that, if you will see the membranous part of urethra, it is star shaped. The penile urethra will have trapezium in the upper part, middle part horizontal slit, and at the part which is lying near to external urethral orifice. At that level, at the level of external urethral orifice, it is in the form of vertical slit. Now, rupture of urethra. Actually, one of the students and have asked me, ma'am, how to know about rupture. Actually, questions has been asked about rupture of urethra. Two types of injuries are common. One is rupture of the bulbar urethra, and the other is membranous urethra. So you have to know, most common is the injury of bulbar urethra, bulbous part of the urethra, bulb of the urethra, bulbar part of the urethra. And when there is an injury on the bulbous part of urethra, actually what happens, the urine extravasation occurs in the superficial perineal pouch. It will pass over, superficial perineal pouch will be full with the urine or any kind of fluid accumulation or any kind of hematoma, and the fluid will accumulate around the scrotum, around the penis, and anteriorly it can go to the anterior abdominal wall. So that is superficial extravasation of urine will be seen in the bulbar part of urethra. See here there are two images. This is the injury of the A, which is actually the bulbar part of urethra. Bulbar urethra is injured, and the second image is injury of membranous urethra. So in bulbar part of urethra, you can see the urine has accumulated around the scrotum, penis, and also deep to anterior abdominal wall. Also deep to anterior abdominal wall. So this is the image where we can see the injury of bulbar urethra. The fluid is accumulated in superficial perineal pouch, around the scrotum, penis, and beneath the anterior abdominal wall. In the membranous urethra, the extravasated urine and ruptured membranous urethra, we know that it lies in urogenital diaphragm. So we are clearly knowing that there will be injury at the level of urogenital diaphragm, as you can see, and due to injury of urogenital diaphragm there is deep extravasation. So deep extravasation of urine will be there, or the fluid, and in this case the extravasation of urine will be in the extraperitoneal space. It will be in the extraperitoneal space. So please note down, injury of bulbar urethra will lead to extravasation of urine in superficial perineal pouch, around the scrotum, around the penis, beneath the anterior abdominal wall. But if the injury in the membranous part of urethra, which is traversing in the urogenital diaphragm, there will be deep extravasation of urine and fluid that will accumulate in the extraperitoneal space. Okay, I think this was a question asked from one of the student, that is Sarma Punit. Now before ending, let's solve few one or two MCQs, and that is the end topic. Is it okay? That is the last topic. So can we solve one or two MCQs related to this topic? Which of the following is true? Which of the following is true regarding innervation of urinary bladder? Parasympathetic efferent fibers are motor to detrusor muscle. Sympathetic is sensory to sphincter vesicae. Pudendal nerve innervates sphincter vesicae. Awareness of distension of urine is mediated by lateral spinothalamic tract. So yes dear, just last two MCQs I want to solve with you, then we will end today's session. So anyone who wants to give the answer? Which of the following statement? Gajendra has given the answer. Gajendra has given the answer. Joy has given the answer, and I have explained. Aradhya, Aurora, okay. And my dear, the right answer is given by Gajendra. Yes, parasympathetic is motor to detrossus muscle. Yes. So micturition has to occur. So it is motor to detrossus muscle and it relaxes the internal urethral orifice. That is the function of parasympathetic innervation. Sympathetic is not sensory to the sphincter urethra. Pudendal nerve is somatic. It is somatic, so it is wrong. Awareness of is not via urinary bladder. Lateral spinothalamic tract is for pain and temperature sensation. So the right answer is A. So yes, Gajendra has given a right answer. A thumbs up goes for him. Gajendra has given the right answer. So a thumbs up goes for Gajendra. Okay, dear. So can we move to the next MCQ? Everyone, we know that parasympathetic innervation is required for micturition to occur. So it will be contracting the detrossus muscle and relaxing the internal urethral orifice. Now moving to the next question, capacity of urinary bladder in case of adults. 300, 200, 1500, 500 ml. Which is the right answer? Capacity of urinary bladder. Capacity of urinary bladder. Joy, yes, Joy has given the right answer. Normal capacity is 300 ml. 500 ml will be very much urged to micturition. So normal capacity is 300 ml. So it is a range of 220, 240 to 320 ml. So best answer I will pick is A. That is 300 ml. Is the 300 ml. So yes, we have done with this. So this was the last one. So I hope actually we have kept the name that it is a rapid revision, but I have covered entire abdomen and pelvis. Tomorrow I will start with the thorax topic, and tomorrow will be an evening session starting from 5 p.m. Is it okay? So I will take a session of 4 to 5 hours in which I will cover the entire thorax. Today there was two topics, abdomen and pelvis. Both I have completed. So only it has taken certain more time, but I have completed overall entire aspect. Is it okay? Can we end now, or is it okay? Have you understood? Please let me know. We will again meet tomorrow at the 5 p.m. So I think you just go. Many of you must have missed because I was sitting continuously only. I didn't take a break. So I think if you have missed any of this aspect, just go and see the session once again, because all the points are highly important and this will be absolutely asked in your examination. So it's an all the topic has been covered. So I think for abdomen and pelvis, 90% of the questions are coming from these topics only. Yes, great. Thank you so much. Yes, Gajendra, it was a right session. All the best and keep studying. All the best. All the best. We will meet tomorrow at 5 p.m. Tomorrow at 5 p.m. Tomorrow 5 p.m. All the best. Keep studying. We'll meet tomorrow. Thank you so much. Thanks.